morning, and welcome to the first hearing of Portfolio Committee number 2's inquiry into the impact of ambulance ramping and access block on the operation of hospital emergency departments in New South Wales. My name's Greg Donnelly and I'm the chair of Portfolio Committee number 2. I acknowledge the Gadigal people of the Eora Nation, the traditional custodians on the lands on which we are meeting today. I pay my respects to elders past, present and emerging, and also acknowledge the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands and waters of New South Wales. I also acknowledge and pay my respects to any Aboriginals and Torres Strait Islanders who may be joining us today either in person or over the internet. Today we'll be hearing from a number of stakeholders, including peak medical bodies, organisations and unions, as well as emergency medicine staff, specialists. While we have many witnesses with us in person, some will be appearing via video conference today. I thank everyone in advance for making the time to give evidence to this important inquiry. I appreciate how very busy people are. Before we commence, I'd like to make some brief comments about the procedures for today's hearing. Today's hearing is being broadcast live via the Parliament's website. A transcript of today's hearing will be placed on the committee's website when it becomes available. In accordance with the broadcasting guidelines, media representatives are reminded that they must take responsibility for what they publish about the committee's proceedings. While parliamentary privilege applies to witnesses giving evidence today, it does not apply to what witnesses say outside of their evidence at the hearing. I therefore urge witnesses to be careful about comments you may make to the media or to others after you have completed your evidence. Committee hearings are not intended to provide a forum for people to make adverse reflections about others under the protection of parliamentary privilege. In that regard, it is important that witnesses focus on the issues raised by the inquiry's terms of reference and avoid naming individuals unnecessarily. All witnesses have a right to procedural fairness, according to the Procedural Fairness Resolution adopted by the Legislative Council in 2018. If witnesses are unable to answer a question today and want more time to respond, they can take a question on notice. Written answers to questions taken on notice are to be provided within 21 days. And finally, if witnesses wish to hand up documents, they should do so through the committee secretariat staff. In terms of audibility of the hearing today, I remind both committee members and witnesses to speak into the microphone. As we have a number of witnesses in person and via video conference, it may be helpful to identify who questions are directed to and who are speaking. For those with hearing difficulties who are present in the room today, please note that the room is fitted with induction loops compatible with hearing aid systems that have a telecall receiver. And finally, could everyone please turn their mobile phones to silent for the duration of the hearing. So we'll welcome now formally our first witnesses and go through the formality of having you either affirmed or sworn with respect to the evidence that you'll give to the inquiry today. So easiest to do it from my left to right. I mean, I know there's only two of you, but if we start with Dr. Skinner. Doctor, could I ask you to state your name, your position title, and swear either an oath or affirmation, whichever you prefer, the words of which should be before you. If not, just raise your hand and we'll provide them to you. So, Dr. Skinner.
Thank you. My name is Dr. Claire Skinner. I'm the President of the Australasian College for Emergency Medicine. I work as a Senior Staff Specialist in Emergency Medicine at Hornsby Ku-ring-gai Hospital in Northern Sydney. And in terms of affirmation, I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you very much. And Mr. Gray, can you please follow suit?
My name is James Gray. I'm the Policy and Advocacy Manager at the Australasian College for Emergency Medicine. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you very much. Well, can I confirm that your submission has been received and we're most grateful for that. Your submission stands as submission number 16 to the inquiry. It's been processed and uploaded to the webpage for the inquiry. It's a most helpful submission, and thank you for that. It's laden with a lot of content, and I'm sure it'll lead to a number of questions from committee members, but you can take the actual submission as read. So with that said, can I invite an opening statement, and then if you're comfortable with that, we'll then move into the questioning part, and we'll be sharing the questions around. And just to confirm, we've got members on this committee from the opposition, the government, and crossbench representatives as well, and we'll be sharing the questions between ourselves. Just before we start, though, could I just check, is Kate far away?
Just
Oh.
here.
A
6
couple of metres.
That's really got me off
Highest
to it.
I've ever
Kate,
been, obviously, for a few minutes.
I've never
I was
known
looking
you
down.
to be.
I was looking down here for Kate, and there she is. Welcome, Kate. Kate in person. Welcome, Kate.
Thanks, Greg.
Good to see you. So, with that, then, your opening statement.
Look, thank you very much for recognising the serious and urgent nature of these complex and interrelated problems. And thank you very much for the opportunity to speak with you today. And I'd also like to acknowledge the traditional owners of the lands upon which New South Wales emergency departments are located. First of all, we are here representing the Australasian College for Emergency Medicine, which is a not-for-profit organisation which is tasked with training specialist emergency physicians in Australia and Aotearoa, New Zealand, and also maintaining professional standards in emergency medicine. It's fair to say that we've been involved in research, policy and advocacy on ED overcrowding and access block since our big origins nearly 40 years ago. So we would regard ourselves very much as immersed in this space and experts around this problem. So we really welcome the opportunity to present to you today. Access block is a situation where a patient has received care in an emergency department and needs admission to an inpatient hospital bed, is unable to access that hospital bed in a timely fashion, and we define that as at 8 hours from the time of presentation to the emergency department. The problem of access block, which is closely related but slightly different to emergency department overcrowding and ambulance ramping, is well known, and the problems have been well described now for many years. Pressures on emergency departments in New South Wales have been on an increasing trajectory for decades. We've seen a trend of increasing presentations with a slight dip during the height of some COVID waves, but otherwise a rising trajectory. And not only have we seen increasing presentations to emergency departments, but we've seen the patients who present having increasingly complex problems, and those are a mix of medical and social problems. Access block and overcrowding manifest in the emergency department, but it's actually a sign of broader health system and social system dysfunction. We know that access block is harmful for patients. So we know from research that there's a 10% increase in preventable mortality when more than 10% of patients in the emergency department have waited too long, so over 8 hours, to access an inpatient bed after their emergency department care is completed. We also know from our research and from surveying our members that access block and ED overcrowding are harmful for healthcare workers. So our members, when they're asked, reflect on access block as being the biggest cause of stress, poor morale and burnout in their work. I want to remind us all and set the scene here that we're talking about real people. So today and on Friday, you're going to hear a whole bunch of stats and policy statements and targets and KPIs, but these are real people, and these are real people who need acute health care. So I keep close to mind, and I want you as well to keep this close to mind, that these people are our parents, our neighbours, our friends, and potentially our children. They're worried, they're frightened, and they're seeking help. We also need to remember that the problems of access block, ambulance ramping and ED overcrowding have the greatest detrimental impacts on people who are already the most marginalised in our society. And it's very important that we don't blame patients for seeking care in emergency departments. Instead, we should blame the system for not providing the care that they need when they need it. Access block is a very complex problem, and I would encourage you all not to be distracted by potentially simple solutions. In particular, we are concerned that there's always been a focus on diverting low acuity patients away from emergency departments. Look, we can provide that sort of care better and differently, but that won't solve the problem of access block, which by definition relates to people who need admission to a hospital bed. Access block is a complex problem. It needs deep thinking. It needs a collaborative multidisciplinary approach, and it's going to require complex and multifaceted solutions. Since we made our submission to the inquiry, we have a completed paper which we commissioned from the Sachs Institute, which we would like to table to you today, which is an evidence review of the literature of solutions to access block from around the world. So James has got a copy of that which he can provide.
Thank you very much.
Again, I'd like to thank you for the opportunity to speak to you. Access block, ED overcrowding and ambulance ramping are big, complex problems, but I want to also encourage you to think that these can be solved. We have a need for urgent, transformative, genuine health system reform in New South Wales, and that's going to require clinicians, health service executives, politicians and communities to work together, because we need the people of New South Wales to be able to have access to timely, affordable, safe, high quality, compassionate care when they need emergency care.
Thank you very much, Doctor. That was very good. It sets the scene very nicely, I think, for us to now open up for questions. We've got effectively about 15 minutes or 16 minutes each for the three groups. So we'll commence with the opposition, the Honourable Rose Jackson.
Thank you. Thank you so much, Dr. Skinner and Mr. Gray, for coming along and your submission and your presentation about this incredibly important issue. I just wanted to get a little bit of a sense, firstly. I mean, you say in your submission, you said in your opening statement that access block is a symptom of a broader health system in crisis. Sort of how long do you think the health system has been in crisis? How long is that a term that you'd use to describe the situation in New South Wales?
So the first reference to ED access block, again, the situation I've described where a patient can't receive the care they need in a timely way because the service is overloaded, that first emerged in the 1990s in the literature. I've been working mostly in the New South Wales, but also in the ACT health system for over 20 years. When I was a junior doctor, we maybe had a couple of times a month where the hospital went on what was called bypass, where we were unable to provide timely care and offload ambulances. During my career, that's now become a regular occurrence to the point where it's actually now normal, where every shift we will have trouble offloading ambulances, seeing people in beds. We'll be forced to provide care to people when they first arrive in the emergency departments, in corridors and in waiting rooms. And as all of you can probably not relate to from your own experiences of seeking emergency care, that means that it's public, it's not dignified, and it also seriously limits your ability to perform a proper medical examination, take a complex medical history, and form rapport with a patient. It's just not adequate and it's not safe.
So it's gone from a couple of times a month to a couple of times a day.
It's constant. It has become our new normal. Look, we had a dip off during and you'll see in the Sachs report and you'll see in some of the data in our submission, we did have some dip offs during the heavy COVID waves, particularly early in 2020 when people stayed at home and they didn't have other respiratory problems. So I would advise you not to look at that data. But if you look at the trajectory, we've had rising presentations, rising complexity, and the problem of access block and ED overcrowding, which was an every now and then event, has now become a permanent state of being in emergency departments in New South Wales.
I mean, it's interesting your point about COVID, because in a way, part of the public discourse is, oh, look, there are problems in the hospitals, but that's just because of COVID, or it's just because it's winter. And, people have more flu in winter. And so I'm just interested in your description of it, not as a sort of particular, say, seasonal or particular issue related to the pandemic, but in fact a much broader and growing problem over, say, the last decade.
Yeah, it has been a growing problem. I think it's fair to say that COVID was a straw that broke the camel's back. So that we've seen examples of deferred care, particularly during the pandemic, which means that people with chronic conditions haven't been able to access care, so their conditions have deteriorated, which has probably led to some of the pressures we're seeing more recently. But it's really important to stress that this is not a COVID phenomenon. This is a global phenomenon of hospitals, which has been growing for decades due to underinvestment and under-resourcing and poor coordination of community-based care.
And just in terms of, your description of the impact of access block on real people, and I think that is, as you say, a really important part of the story here. You mentioned that we kind of use these not fancy terms, but kind of, clinical terms like access block or whatever. And what that means, though, is that someone is receiving care, as you say, perhaps in a hallway or in a waiting room. I mean, what types of care is occurring there? What does that look like for that individual patient? What types of things would normally occur, say, in a room or in a more private setting that occurring in a hallway or in a waiting room?
I'm really mindful this is a public hearing, which limits me telling detailed patient stories, and hopefully you'll find them elsewhere in your submissions. But so, for example, if you take an elderly patient who's fallen at home, might have a broken hip, instead of the ideal patient journey looks like them calling an ambulance, the ambulance being able to arrive in a timely fashion, paramedics being able to administer pain relief medications, putting on a stretcher, transporting to hospital, offloading into a hospital bed, nurses and doctors in a coordinated way, taking a history, providing pain relief, organising x-rays, we give an anaesthetic injection into the hip to relieve pain and organising a timely orthopaedic procedure to fix the hip. At the moment, unfortunately, that elderly patient who's fallen at home, and this has happened on my recent shifts, will often be either in the back of an ambulance. It's cold and rainy in Sydney at the moment, so that's pretty uncomfortable. Or they'll be queuing up in a corridor in an emergency department. We'll try and ask the paramedic staff to help us get them into x-ray really quickly to try and get that done. We'll be forced to listen to their chest and examine them to look for other injuries like an associated head injury while they're on an ambulance stretcher. That limits our ability to do a proper examination. Imagine that patient needing to go to the toilet. That's very undignified, needing either catheterisation or to be on a pan in a hospital corridor. None of that's not fair on people. You know, we should be able to do this better. But this is not happening because of the emergency department. We want to provide good, timely care. We want to look after people in beds. This is happening because the emergency department is full of people whose emergency department care is completed but they can't go to the wards. And then in turn, the hospital wards have a high number of people on them whose acute hospital care is completed and they need to be discharged either back into community care or community services, but there's simply no places available, or the processes are discoordinated and non-integrated, so it's very hard to arrange that care in a timely and effective way.
I mean, I think that description of, someone who has fallen and, injured themselves and the way that the current arrangements, would be very difficult for them, I think, is very relatable. I mean, one of the things that you've also talked about is that, for example, previously in a media release, even more adverse outcomes, including death. You mentioned that, some of your research indicated that there was a 10% increase in mortality, I think you said, as a result of the current crisis in the hospitals. And so how does that occur? I mean, as I said, we can all understand, someone who it's, very undignified and unpleasant to be, treated in a waiting room or in an ambulance. How does that then manifest into a very serious situation because they're unable to access a hospital bed in a timely way?
So imagine this patient's turning up to an emergency department with, say, 20 beds, for example, and all of those 20 beds are already full of people. They've been worked up by the emergency department, doctors and nurses. They need admission to the wards. They're now there, and the emergency department doctors and nurses are still attempting to care for them while maybe caring for 30 or 40 people in the waiting room, and also caring for people down the corridor or potentially arriving in ambulances. Part of this is distraction, that we've simply got staff doing too much for too many people at once in a poorly controlled environment. So you just ricochet around the department trying to make sure nothing's going wrong. You can't do anything in a proactive or systematic way. The second reason is because, and we tend to forget this, is emergency departments, people who work in emergency departments, all of the clinicians and even the clerical and technical staff receive training in providing that acute episodic care. We don't particularly have skills in longitudinal ongoing care. So when people get stuck in the emergency department for 12, even up to 24, 36 hours after they presented, we simply don't have the skill set for that sort of care. We are specifically trained to provide that emergency level care at the start. And we want people to go to the wards, not because we don't want to look after them. We want everybody to feel welcome and looked after, but simply the skill set for those people with those sorts of care needs is actually in the ward-based environment, not in the emergency department environment.
And yes,
Sorry.
please. So, I mean, I'm just sort of directing these questions generally. Feel free, Mr. Gray, to jump in whenever you have something.
One additional risk that I think it's quite important to be aware of is the waiting room itself as an area of risk. So if the beds are full and you've got dozens of people in the waiting room, potentially undifferentiated patients, the capacity of the ED to monitor them and check for deterioration in their condition is also a really major risk. And we've been seeing cases of this around the country, that when the ED is overloaded, managing that risk before they even get to the bed is creating a lot of problems as well.
And what are the risks also then in terms of staff from that high stress environment? I mean, I can imagine particularly people in a waiting room, perhaps family members of someone who is in there seeking care, who's been waiting a long time. They're stressed. They want their loved one to receive care quickly, as I'm sure we all do. I mean, how are they reacting towards staff? Is there an increase in aggressive behaviour because people are frustrated?
People who choose to work in emergency departments do it because we like people and we feel a deep sense of connection to the community. And basically we effectively work up, it's like working with a conveyor belt full of things you can't get to fast enough, but what's on the conveyor belt is human distress and suffering, and it causes enormous moral injury to be in a position where you're trained to provide care and you're not able to provide it in a timely way. We are seeing a lot of distress in waiting rooms, so we're seeing people become very upset and anxious, and this does manifest often as verbal and sometimes physical aggression. Emergency departments have become very uncomfortable places to work, and I do think the root cause is the overcrowding and access block, not because people are bad people.
Yeah, of course. I mean, I think, you said in your opening statement that, you felt as though the consequences of access block was the biggest cause of burnout, which it was an interesting comment to me because, as you say, I mean, they're difficult places to work. You can imagine that there are lots of stresses and pressures on someone working in an emergency department. And so for this to be the biggest cause of burnout, presumably that's making retention a real challenge?
Yeah, and look, it's a cause of burnout, but both because of not being able to provide the clinical care you want and constantly worrying that you might have missed something clinically, but because also because of interprofessional tensions. So just acknowledging that other parts of the hospital are also under-resourced and also struggling with these problems, and so there can be significant interprofessional tensions. And look, it's horrible when you have an anxious, particularly a parent or a carer of an elderly patient, someone who's presented to the emergency department with psychological distress, and you're not able to provide their care they need, and their symptoms of anxiety and worry can sometimes manifest as behavioural disturbance. It's preventable if we run a better system.
And so, I mean, I am interested in the retention of staff question because I think that's quite a significant one. I mean, is your view that if we are able to do better in terms of managing access block and the pressure on our emergency departments, we're going to see a direct improvement in our capacity to keep good staff on our emergency departments?
A good day in an emergency department is literally the most satisfying working day you could possibly have. Like, you have human connection and stories and you can help people and save lives. It's fantastic. A bad day is really hard work. We currently have a crisis in emergency department staffing, and you talked about when's a crisis. We have a crisis now. The crisis is particularly with senior nurses. There are a lot of I don't want to speak for them, but there are a lot of alternatives to working in an emergency department in an environment where you're doing night shifts, the pay's not great, and people are quite aggressive with you, and you can't solve the problems and provide the care you're trained to provide. We have a crisis with medical workforce, particularly at middle grade, which is that trainee non-specialist level. We've seen the locum market in New South Wales go out of control in terms of the dollars that people are claiming to do locum shifts in emergency departments. I honestly believe that if you provided good working conditions, it was resourced properly, and we got rid of, there's a whole bunch of process issues here which are deeply frustrating on the day-to-day level and impede good patient care. People are willing to work hard. People like the psychological and emotional challenge of emergency medicine, but they're not willing to put up with the current frustrations and the current lack of support and resourcing.
I just want to ask my colleague,
Yes, no, I'll jump in.
Okay, great, excellent.
Thank you. The issue of the trajectory that you mentioned, Doctor, in your opening statement, a trajectory that's been increasing over time. Has there work been done that you're familiar with which at that commencement of that trajectory starting to increase was identifying why it was starting at that point in time? Because we are here at this point now, and words like dysfunction and crisis, words that have been used this morning, and in fact used quite often when referring to the matter of the state of play and state of affairs in our emergency departments and our public hospitals. But in terms of where this all started, and this may be too much of a simple question to be answered in simple terms, but why did it start where it did? Is there any understanding of that? Because trying to understand the rate of the trajectory, the gradient, whether or not there is any plateauing or that trajectory is moving in any particular direction, all of that is obviously of interest, I think, to us. But obviously this has started some time ago.
Yeah, look, so the Australian Institute of Health and Welfare runs pretty detailed emergency department stats, as does the BHI in New South Wales. And I'm not an epidemiologist around emergency departments.
Yeah.
The types of patients we see has changed markedly during my career. So we used to see, I look at your television vision of, your television view on what happens in emergency departments. It's car accidents and strokes and heart attacks. In fact, the vast majority of what we see at the moment, we're seeing a lot of elderly care, we're seeing a lot of people with mental health problems, we're seeing a lot of people with drug and alcohol problems, and the group of presentations that's most on the increase in New South Wales is actually children and adolescents with mental health problems. That's the group that's got the fastest growing trajectory. Some of this is the natural shift in the population. So with the ageing of the population, and look, we've done well with prevention and with acute healthcare and some other groups. So for example, in my parents' age group, if you had a heart attack, you had a fair chance of not surviving. These days you would survive, but you would then carry a burden of chronic illness into older age. So we have shifted the burden of health in New South Wales. So the types of patients we have different types of problems. I think we've also seen a shift in the framework around some complex social issues. So things that were framed as maybe legal issues or social issues are now framed as health issues. And I think that's a good thing, because I think it comes with a more recovery-oriented and compassionate approach with a health framework, but we haven't adequately resourced the health system to absorb some of that from the social care system and from the legal and justice systems.
Well, specifically the emergency departments as the entry point.
Well, it feels like, and sorry, I'm talking a lot, James, I'll give you a
No, please, no.
But it feels like at the moment all roads lead to the emergency department. So, if you are found intoxicated on the streets, it's no longer a police matter, you're brought into the emergency department. Drug and alcohol issues have become an emergency department issue. If a social care, I just think of social care, a child in formal care, if they have a behavioural disturbance after hours, they're brought to the emergency department.
Sorry, I missed that. What sort of disturbance?
A child in out-of-home care who has a behavioural disturbance will be brought to the emergency department. So it's good. A health framework is a good thing there, but we haven't done the adequate resourcing for that shift away from other services. And I do feel we have cut back greatly on all forms of community and social service, to the point where the emergency department is the only thing left. It's the only place that has no wrong door, is open 24 hours a day, is free at point of care. And unfortunately, emergency departments are not infinitely elastic.
I would also just add that in terms of why that curve hasn't been changing, the vast majority of attempts to address access block and indeed ambulance ramping has focused on the ED or on paramedics in the ambulance service, when the problem is actually further along in the system. So, of course, emergency departments have a role in making sure that they work efficiently and do the best they can, but that well is dry. We've had such a focus on EDs, we need to look more broadly at the system.
Thank you. Deputy Chair Emma Hurst.
Thank you. Thanks, Chair, and thank you both for coming in today and providing your evidence. I've got a couple of specific questions about the actual submission that you've given us, which was really useful. Thank you for that. You mentioned in the submission that other transport services such as air ambulance and helicopter rescue services, do you see the same problems with ramping and access block occurring for those transport systems as well? Is it the same thing that's happening, or is it slightly different?
Look, it's slightly different, and it's hard to comment specifically on that because it's just coordinated in a very different way. Mm-hmm. I think with most of the retrieval and air transport services, they're coordinated at a regional or even a state-based level, which means there's a little bit more resilience in the system, and also there's lot of work goes into preserving those resources to make sure they're available. But we do know of times when no air transport option is available for a critical patient. The rural inquiry last year presented some examples of that, which you'll be aware of.
Yeah, absolutely. Thank you. You also mentioned in the submission that there's a perception that walk-in patients are treated with a lower priority than patients arriving by ambulance. I just wanted to get a bit more information about what's happening in practice and whether you feel that it's discouraging people from self-presenting in hospitals.
So there is a KPI on transfer of care from a paramedic to an emergency department. There is no KPI on, there's KPIs on walk-in patients, but they have less urgency in the hierarchy of KPIs that apply to emergency departments. I think we will all do our best to look after anyone regardless of their problem and regardless of their acuity. We try not to patient blame, we try not to turn people away, we try to do the best we can with the resources we have. But I think there is sometimes the perception by the general public that if you call an ambulance, you'll get in straight away, whereas if you walk in, you'll then have to wait in the waiting room. That's mostly because in the waiting room, you can't see what's going on behind the scenes.
Yeah, absolutely. Another thing that in your submission is that you say that in order to increase the capacity of hospitals and alternate care environments, inpatient and community services must be extended outside of normal business hours. Can you explain why they currently only provided in business hours and what other limitations might be around that?
Yeah, I can talk about that in the hospital setting, and maybe James can do the community, which is more his area of expertise.
Great, thanks.
So the emergency department is open 24 hours a day. We tend to work in 3 shifts, a day shift, an evening shift and a night shift. We have slightly fewer staff on the night shift than on the other 2 shifts. It's easy to assume that emergency department presentations are chaotic and have no pattern, but they do have a very predictable pattern. And the presentations tend to increase from about 10 o'clock in the morning. They peak between 3 and 8 in the evening, and then they come down through the evening lowest in the middle of the night. The reason the night shifts are currently busy in emergency departments is because of lack of capacity during the day. So the patients' numbers build up, and then it's often standing room, sitting room only for anyone who's admitted during the night shift with minimal staff on. Part of the problem we have is the rest of the hospital, excluding some services, for example, acute obstetrics and the intensive care unit, and people on call for trauma such as orthopaedics, but they go down to skeletal staff, many of those other services, after 4:30 in the afternoon, which means, and look, there's really good evidence that you shouldn't do a planned surgical procedure after hours. Like, you will do a much better job when everyone's rested and the full team is present, but it means that there can be delays accessing care. So, for example, if I see someone in the emergency department, they need some physio input and they need to see a pharmacist to have their medication sorted out before they can go home. And that's only available during business hours. And even then, particularly with allied health, if those people call in sick, there's no replacement for them, so there's no resilience in the system. That means people can wait for days just waiting for some things that are absolutely routine and need to be provided on a more recurring basis.
Mr. Gray, did you have?
Yes, so in terms of looking outside the hospital system, it would be ideal to be able to refer people quickly into other services. An example might be in mental health. So those patients are a relatively small proportion of those that do attend the ED but have the highest levels of access block. But then there's also a group of patients which could be discharged back into the community with appropriate supports. But it's just the way our society is structured, our economy is structured. We tend to just work within fairly set hours, and that just doesn't match with health needs.
Just another point about the hospitals is the vast majority of care in public hospitals are provided by junior and training doctors, not by qualified specialist doctors. We're different in the emergency department. We do tend to have a specialist presence there from 8 o'clock in the morning until midnight or just after midnight, which means that you get senior input into decision making. In the rest of the hospital, you often get your care provided by someone who's recently out of university, who is a trainee. They provide very good care and they're very dedicated, but people can often wait days for a specialist level decision, which can be a major hold up as well. So there is a body of work here. Like, I think we need to increase capacity throughout the system, in all parts of the system, but we also need to make sure our processes are effective and that the right decisions are made first time. And that's for good patient-centred care, but it's also so we use our resources really wisely.
Thank you. You also explain in your submission that medical consultants are the only people capable of admitting and discharging a patient and are often unable to attend to all patients each day. And one of your recommendations is to implement a new role of dedicated discharge planners to assist with that role. Can you explain that model a bit further and the distinction between dedicated discharge planner and a medical consultant? Like, how would that work in practice?
So the medical consultant would be a specialist physician, surgeon, a specialist doctor, and they authorise the decision to discharge. So you'll often find a relatively, and look, this is not to criticise my colleagues, because I do genuinely believe that everyone is working very hard in the system with limited resources and the best intentions. That the junior doctors will often work really hard, when the decision, the final decision about a procedure or a decision to discharge a patient or what sort of care is required next rests with the medical consultant. And that person's often employed in a very fractional way and only visits the hospital every now and then. It can mean that the junior doctors do the best they can, but then they might predict that decision slightly wrong, and then there'll be delays until the next time that person sees the consultant or has consultant input. A discharge planner is a slightly different role. They're usually someone with nursing or allied health training who is employed in a role where they consider the person's complex care needs, and they have a coordinating role in terms of lining up the services necessary both in the hospital to get that person ready for discharge, but also in the community to make sure they have a seamless transition to community-based care with the types of allied health and community services they might need once they are home or back in their usual facility.
Thank you. And I know we've talked a little bit about regional and metropolitan areas, but based on your knowledge and experience, especially around the issues of ramping, are we looking at really quite distinct issues? Like when we put out this report together, should we be kind of looking at those as two separate sort of spaces?
Yeah, I think you do need to consider. You need to consider the different sizes of the hospitals and the location. There are quite different problems, and again, it's really tempting with any problem like this to seek a uniform solution. And I would really strongly encourage you that all solutions have to be multifaceted and involve local communities. So in the Sydney metropolitan area, if a system becomes overloaded, there is some degree to which you can load shuffle around the metropolitan area. So we saw this most probably during the height of the Delta outbreak of COVID, where we had a virtual control centre within ambulance centrally, and say, just to pick hospitals I don't work at, say Bankstown Hospital was experiencing severe overcrowding. A patient, the ambulance wouldn't take the person to Bankstown Hospital, they might instead divert to, say, Liverpool or Campbelltown if there was capacity there. Obviously, that only works while there's capacity somewhere in the system, and there can be problems with taking people outside of their local area when the specialists who are known to them and their community services aren't connected to the facility where they end up. In a rural area, there's literally nowhere else to go. So if you're somewhere, in regional New South Wales, the big regional centres, they have to absorb that load and they keep absorbing it, there's nowhere else to go. So say you're at Tamworth, the next place to go is John Hunter. There's limited capacity. You can't come into Sydney because it's just not patient-centred to get someone so far away from their family. Obviously, for severe trauma or severe, like someone with highly specialised needs, you do that. You transfer to where that care is, but you can't do that for routine care to the same extent you can in the city. The other thing that's important to note is that in the city there's a vast plethora of other services available which just don't exist in rural and regional areas. So there's more capacity to absorb things in the community as well.
I'd also just, my apologies, very quickly, just back to your point around patient transport, air transport. That can be a significant issue in regional areas depending on the capacity with the system, which then, of course, contributes to access block within that regional hospital as well. So if it's waiting a day or two to transfer a patient, for instance, into the city, that's a significant amount of resourcing that's not available for that community at that time.
So just to give you an example of that, say I'm working in a resus team in a small hospital in New South Wales. The emergency department stops when there's a critical patient in the resuscitation bay. The entire team in a smaller hospital will be required to provide critical care to that patient. So if you've got someone from a major road trauma who presents to a small hospital, every nurse and doctor and orderly and security guard on hand will be involved in managing that one patient who has critical care needs. If that person then can leave quickly and get to a source of trauma care in the city, then that team's freed up to get back on with the less acute patients in the emergency department. But if that person waits there for hours, that entire team is then providing ongoing care in what's sort of a pseudo-ICU environment within the emergency department, and that renders them not able to provide timely care in a proactive way to the other patients who are waiting in that emergency department. So this is a significant issue for smaller emergency departments.
Thank you.
Thank
Okay,
you.
Thank you, Chair. So, and thanks for coming today. So in March this year, we had budget estimates and we had the Minister tell this committee that the concept of what still causes major grief in other states, that is ambulance block, is actually very rare now in New South Wales. Was he misrepresenting what is happening in New South Wales?
Look, New South Wales does well compared to other states and territories because we do. I just want to acknowledging the significant work that has been done by New South Wales Health to work through these problems, so particularly the whole of health program, which I hope you'll be aware of. So New South Wales Health does do well compared to other states, but it's fair to say that access block, ED overcrowding and ambulance ramping are significant and chronic problems in New South Wales emergency departments.
Yeah,
Sorry, could I just confirm that the New South Wales government and the New South Wales health system does
Order,
well
Chair.
compared to other
Chair,
states? I
order.
was just getting
But
clarification.
you have
as
your
to
own
the-
time
Please,
later,
please.
Wes.
We know that we don't cut in on each other.
Yeah.
It's Kate.
I was just seeking some clarification of the.
You can seek clarification in your own time.
Okay.
We know how this rolls. So, Kate.
Thank you. So when the minister said that ambulance blocking, he called it blocking, but ambulance ramping, access block is very rare. That's not true, is it?
It's
in
not
New South
rare.
Wales.
It's not rare. It's common. But New South Wales Health, to give them their dues, has done some work on this that has yet to happen in other states and territories in Australia.
And so when you said as well that there's a crisis in emergency department staffing, I think you said. Do you think that New South Wales Health and the government is recognising that, by the sounds of it, our public hospital system is in crisis?
I do think they are aware that the system is under incredible pressure. The language of crisis is really hard, isn't it? I guess throughout my career, I've always wondered what would it take for the emergency department workforce to break, and we keep just pulling that extra little bit out of the tank. But I can honestly tell you the kettle feels dry at the moment.
Yeah, a lot of the submissions that we've received for this inquiry certainly seems to imply that many staff are at breaking point, the emergency departments are at breaking point, the public hospital system itself is at breaking point. Would you agree with that?
I have seen senior staff, particularly nursing staff, who have dedicated their lives to caring for patients in emergency departments, so they've had enough and retire or resign or leave healthcare in the last couple of years.
Because I think your submission also states the fact that hospitals are operating at 100% capacity consistently, that there aren't enough beds for people to get to. That's another issue, I think, that there seems like the government isn't responding to enough. I recall when I asked the New South Wales Health and the Health Minister about this, they'll rattle off numbers of beds and increases in staffing, almost as though everything is fine, they're dealing with it, they're putting on more staff and they're supplying more beds. So what's not happening? Because every time we ask the government this, they seem to imply that they've got it under control and they're addressing it.
So we do. Working in a public hospital is like playing a game of bed Tetris. There's so much effort goes into, getting maximum efficiency out of the beds. I think we need more beds, and I think we need better processes. So we need to increase capacity and we need to increase flow. It's some of that is most of that is resourcing. Some of it is capacity. A lot of it is integration across the system. A lot of it is anthropological. So I do think there's an acknowledgement of the problems. I don't think we've seen adequate work towards health reform. I think there's a fairly common shared vision, and I was outlined in a conversation piece only the other day about moving to primarily community-based care. I think that's a common vision across the world, which is hospitals become smaller, the vast majority of people will be cared for in their own homes or in community-based settings. It sounds easy, but the reality is that requires more resource and more coordination and very sophisticated digital mechanisms to be able to do that. We've been trying to shift towards that by cutbacks through efficiency and lean thinking in the public hospital system. You can't drive those efficiencies through just setting smaller and smaller targets. You actually need to put the work into clinical redesign and change management and transformative healthcare.
Yes. Just to explore this further, I visited Westmead a couple of months ago and was just shocked to hear from a senior emergency physician there who met with me along with some other staff. I was shocked to hear of the decrease in the beds at Westmead, something from 937, I think it was a few decades ago, to 550 something now. That doesn't seem to me to be a case of the government ensuring there are enough beds in New South Wales when a patient needs a bed.
I think we need to do a better job of matching population needs to the acute hospital capacity and also the community care capacity. And part of the other problem we have is we have highly specialised services in a lot of our hospitals, and their beds don't necessarily match patients' needs. I think we need, there's work we need to do on making sure we actually have beds available that match the care needs of the patients we have presenting for care now, not the theoretical needs of patients, a decade or two ago.
You're saying, you said as well earlier, that it's this cost-cutting ideology. This is getting to the crux of it, really, is that there was a decision a while ago, let's all care for people in the community, that'll be great, it'll be less on the health budget. LHDs are working towards KPIs around, they've obviously got budgets that they have to work within, and essentially they're not wanting to put or can't put more beds in. Obviously it's staffing as well, but it does come down to the fact that in the budget is not allowing enough beds according to demand right now in the community. Is that right?
Yeah, I agree. I think we all want that transformation of care to a community basis. That's what people want. That's what I want for myself or my family. But that doesn't happen just through driving efficiency through budgets and targets. It actually happens by doing the hard work around the clinical redesign. We're too ideological when we do clinical redesign in hospitals. We rely on good intentions and doing the right thing. We need to think hard about where the money goes. We need to think hard about the relationships between the state and federal governments. And we need to actually think hard about the rules and legislation that drive some of those behaviours, because we get the system that we design.
And another thing, I suppose, a part of all this is the big kind of hospitals that the government continues to invest in, wanting to put you can call them kind of shiny big hospitals, big new wards. But is that being matched with the right kind of number of beds, if you like, that are fully staffed and funded and have enough staff? Because what I'm hearing as well from the unions, from nurses, is that some of these wards just can't even open in these hospitals.
So we've had a tremendous infrastructure spend in health in New South Wales over the last several years. It's welcomed and it was necessary, but there is no healthcare without trained, skilled healthcare staff, and we need to have a concurrent investment in looking after that staff.
Thank you.
To the government, the Honourable Wes Fang.
Thank you, Chair. Thank you both for appearing today and providing some insights to the committee. I wanted to take you to your submission first, and I note that the submission itself was written by, it has the name of Dr. Trevor Chan. Now, he has obviously put the submission forward, and I note that he's the chair of the New South Wales faculty. But I note also that your head office for the college is based in Victoria. So I imagine that you have some experience across the whole of the country with this issue. Can you provide some insights to the committee about how other states are perhaps experiencing the same issues, and noting that you actually provided Ms. Femin some feedback about where New South Wales is, how it is that we are in relation to some of the other states?
Yeah,
So,
absolutely.
You go first, James.
This is a national problem. Indeed, it's actually a binational problem. We also work in New Zealand as well. So I think Claire mentioned earlier that around the world we're seeing these types of issues occurring. So New South Wales is not unique in these problems. I'll refer back to my previous comment, though, that unfortunately too many of the solutions that have been put forward right across the country continue to focus on the ED and on ambulance rather than the broader system capacity.
I'm the binational president of the college, and I work very closely with Trevor, who's the New South Wales faculty chair. And because I'm based in Sydney and have a bit of experience with similar inquiries around the country, I chose to come today, and Trevor was working.
Sorry.
No, that's
When I say that, I guess I was just seeking to point out that there's been a lot of input from your organisation, so that I was hoping that given the multiple inputs, that there might be some experiences to other jurisdictions as well.
Yeah, so look, it's fair to say New South Wales does have some strengths in this space. First, I think the problem has been well recognised by the creation. There's been a focus on ED and general hospital patient flow through the whole of health program in New South Wales. We do have the advantage in New South Wales of the LHD structure, which means we're fairly well integrated, but we're not so well integrated into primary and community-based care, which is a challenge for all of Australia. And we do have an advantage in New South Wales in that we use a common electronic medical record. So we have some data that's visible. That is not the case in other states. I would say New South Wales is probably best in terms of monitoring and data on this problem. We are probably the best in terms of having a centralised coordinated program attempting to address the problem. We are equal to the other states in terms of having the problems of across the hospital community interface with how we integrate and work well with general practice and with potentially resident, especially residential aged care. So those problems are not unique. I would say the other state that's doing well in this space is Queensland, which also has an active program looking at patient flow across its hospitals, also has a similar regionalised structure. The thing I do think they do better than us is recognise that you need people with experience in change management and business cases embedded in the emergency departments. So as James said, a whole bunch of the focus on fixing access block has been on fixing the emergency department. I think we're probably modelled of care up to, we've done most of the things we can do. What we need now is some expertise in terms of engaging the rest of the hospital and working better across that ED community, ED hospital interface. I really like the business change managers who are embedded in some of the large Queensland emergency departments. I think that's a very good model.
I note that the Regional Health Minister, Bronnie Taylor, often says that if the solutions were simple, we would have done them already. And I think that the fact that you've provided the insight that this problem isn't just in New South Wales, it isn't just in Australia, it is in fact worldwide, points to there being not a simple fix to this, but probably more than one and quite complex. Would that be a fair assumption? Given that we do know that the issues exist across the world, have you had the opportunity to perhaps look at some of the other systems around the world that have done work in this space? I note, for example, in the UK, they've got a similar issue, but there's Leeds. There's a Leeds model, which I've done some reading on, where they've been able to reduce their ramping issues to about a quarter of what the UK seems to have across its nationwide network. Are you able to provide some insights as to what some of the other jurisdictions are doing, what they're doing well, and what lessons have been learnt out of that either have been employed by the New South Wales Department of Health or could be looked at in the future?
Yeah, so the paper we tabled earlier from the Sachs Institute, it does exactly that. It's a literature review of international solutions to access block, so that should provide some answers. I guess in terms of where's doing well and where's doing not so well, Australia's middle of the pack. There's the systems like Denmark, for example, which has completed the transformation to community-based care, but it doesn't have the same emergency department type system as we do, so it's not so easy to equate it. You can look at, I'd be very cautious of solutions from the UK, which has a very, very different structure in that all general practice is public. Mm. So the NHS, they don't have the federal-state divide we have between acute hospital and primary and community care in the NHS, so the solutions don't work quite as well. So you might have heard of NHS 111, where someone can ring and can have their call coordinated and directed to an appropriate service. That's far harder than the Australian environment, where we don't have general practice enrolment and we don't have general practice under the guise of the state. So it's much harder. I guess if you want to look to where's doing really badly, I would suggest that you read some papers coming out of Canadian emergency medicine at the moment around what things they're starting to close rural emergency departments in Canada because they can't staff them and they can't provide safe care. So that's a place that's doing badly. It's pretty equivalent to Australia.
The only reason I raised the Leeds model was because I guess I started down the rabbit hole of looking at perhaps how New South Wales compared to, say, Victoria, where obviously your head office is located. And so I imagine that you would have quite a detailed experience on the Victorian experience with this issue compared to New South Wales. So then I started looking at what Victoria is doing around that space, and then they obviously have started some work around adopting that Leeds model, which is where I picked up on that.
I forgot that. I didn't get to it, but in terms of the lead model, which is rapid offload of patients who present by ambulance to the emergency department into a specialised ambulance offload zone, we're really worried about that because it takes people you haven't met before whose problems aren't differentiated and it puts them into a poorly staffed pool. You would be far better off to find a solution for the people who've completed their ED assessment, whose problems are described and their care is being commenced, and find somewhere to temporarily house them with staff behind the emergency department, than to create a model like the Leeds model where you offload people who haven't yet been assessed or managed or had their treatment commenced by an emergency department doctor or nurse.
So in that instance, then, do you think perhaps the Victorian government's decision to try and model some of their changes around that solution is perhaps not as beneficial as, say, some of the changes that the New South Wales government's adopted to try and resolve that issue?
Yeah, look, I think we all want ambulances back on the roads able to provide emergency care to people who need their help. But we're very concerned about models where you rapid offload undifferentiated, untreated patients into an emergency department that doesn't have capacity to admit them. We would far prefer that you created a model where you can transfer people out of the emergency department who've completed their care to free up beds for those new patients when they arrive. Okay.
And in relation to workforce, and we know that workforce has been probably one of the biggest challenges that we face, not only during the pandemic, but I guess coming out of the pandemic with the health sector, because we had, I guess for a long time, had the opportunity to bring trained professionals into the country, which was somewhat, the tap was closed during the COVID period. Is it fair to say that some of the models that we've got now in relation to attracting and retaining staff perhaps won't see benefits for years, perhaps decades, given that there's obviously an amount of time that you need to be trained to either be a ED specialist or even a nurse or an allied health professional in an ED setting. Is that sort of it's not a quick fix? We can't just turn the tap and fix this ramping issue tomorrow.
No, so at the top end of the workforce, at the highly skilled end of the emergency department workforce, and that's in both medicine and nursing and also in allied health, and also the clerical and technical staff, it takes 8 to 10 years to train someone to be competent to work independently.
Yep.
Where there's low-hanging fruit there, though, is, so for example, my shift on Monday evening, I'm making beds, I'm getting cups of tea. Unfortunately, I couldn't find any cups, so, I'm going to the storeroom, I'm trying to, I'm doing all of that, I'm answering the phone. I think there's low-hanging fruit here in providing some support staff who can provide some of those, more basic bedside care tasks and some clerical and technical support, like stocking trolleys and cleaning and making beds, for example, so you can free up the highly trained clinicians we do have to do some of that more clinical work.
I'd also note that, of course, immigration will always be one part of our workforce strategy, but Australia has the capacity to train nurses, doctors to a very high level, and that should always be the basis of our workforce strategy. International people coming over would always be an adjunct to that.
It's also important to stress that the loss of workforce we're seeing now is not just due to breaks in immigration patterns, it's also because there's an enormous trend at the moment for people to decrease their working fraction.
Yep.
So long-term part-time has become very common.
Yeah. And I guess the last, and noting the time, Chair, I just wanted to ask one last question,
You
if that's
don't
all
wanna-
right.
Yeah, no,
Yeah.
you've still got 4.5 minutes because we've sort of gone
Oh,
over,
okay.
so.
No, thank you. Well, I'll only ask one more question if that's, and to try and bring us back on time. But I just wanted to ask the question around training itself. And obviously, Mr. Gray, you've indicated that one of the solutions is that we do train more doctors and that we have the capacity to do so. But Dr. Skinner, can you perhaps provide some insights as to where you've got a senior clinician who is responsible for the oversight of that trainee? That does provide an additional burden on the senior clinician, doesn't it? In the short term, that does create additional stress where you've obviously indicated that perhaps some of that workforce is stressed. So that's where we need to provide assistance around that training, isn't it? It's to those senior clinicians who are responsible.
Look, training is very much part of a senior clinician's role, and it's an enjoyable and satisfying part of their role. It's very, very hard to provide adequate training in an overcrowded emergency department. You don't, it becomes far easier to do a procedure yourself rather than spend the extra time to supervise a trainee doing it.
See one, do one, teach one.
No, we don't do that anymore, but
Okay.
thanks for the suggestion. Trainees are a vital part of our workforce. In emergency medicine, we do run a very heavy junior to senior ratio. So, for example, one senior clinician will be supervising 8 to 10 junior staff. No other specialty works with quite that ratio. Yep. We've been told the emergency medicine workforce is oversubscribed for years, but that all relies on that very junior workforce where the vast majority, if you go to an emergency department, you're likely to see a junior doctor,
yep,
with the senior doctor only providing some supervisory input. You go to a GP, you see a consultant. You go to a surgeon, you see a consultant. So we need to actually think about making sure we have a sustainable workforce pattern as well so that people aren't burning out because of the supervisory burden. It is a pleasure though, mostly.
Yeah, I know I said last question, but it was just something you just said then. And look, I was being facetious when I said see one, do one, teach one. Obviously, that was the old. I spent a lot of time around medical fields, so it's sort of one of those things that just rubs off. But when you said that we don't do that anymore, I think that's also part of the issue, isn't it?
I think we just don't have time and space for training. We have cut back. Everyone is just seeing the next patient on the list over and over and over again. You need to make sure that you roster people and employ people in numbers that there's adequate fat in the system for them to teach and train the next generation, to attend to their own continuing professional development, and also to undertake quality improvement activities which are vital for the ongoing care of patients.
Yeah. Thank you so much for appearing. Your insights have been really valuable today. Thank you, Chair.
Thank you very much. And I have to say that was a whirlwind tour, but a very, very detailed tour of emergency medicine and a range of factors. And I think a brilliant way to start the inquiry to have such eminent people who've got such detailed experience being able to go through this in so much detail. So on behalf of the committee, thank you very much. Now, there may well be some questions on notice, or perhaps more likely supplementary questions arising from members having an opportunity to read Hansard, and particularly some of the answers you've given to some of the complex questions. So our committee secretary will liaise with you in regards to that. So once again, thank you very much. Much appreciated.
Thank you very much for the opportunity to speak with you today.
Thank you.
Thank you.
Thank you.
making your time available today to join us for our hearing. Appreciate that you're very busy individuals and had to carve out some time for us, so thank you. Just need to go through the formalities of having you either sworn or affirmed to give your evidence. It's easy if I move from my left to right to Mr. Beaton to go through this. So we'll get you to commence by stating your name, your position title for the organisation that you represent, and swear either an oath or an affirmation, whichever you prefer, the words of which should be before you. If not, put your hand up. So we'll start with my left.
Good morning, John Bruning. I'm the Chief Executive Officer of the Australasian College of Paramedicine.
Thanks.
I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you very much.
Good morning, Michelle Murphy from the Australasian College of Paramedicine. I'm the Government Relations and Advocacy Lead. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you very much. Mr. Castellan.
Yeah, good morning. Chris Castellan, State President of the Australian Paramedics Association. My affirmation is I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth. Thank you.
Thank you very much. And Mr. Beaton.
Scott Beaton, Vice President, Australian Paramedics Association, New South Wales. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you very much, Mr. Beaton. Can I commence by just thanking both organisations for your submissions in the first instance. The Australasian College of Paramedicine, your submission is submission number 28. It's been received, processed and stands as a submission and therefore evidence to the inquiry. And the Australian Paramedics Association, New South Wales. Once again, thank you for your submission. It stands as submission number 19 to the inquiry. It's been processed, uploaded and also stands as evidence to the inquiry. So committee members have had the opportunity to read these, so you can take them as read for the purposes of understanding the background the members will have in regards to your submissions. Can I invite both organisations, one representative from each, to make an opening statement, and if you're okay with that, we'll then move to questions from members. So are you comfortable with that approach? So we'll start with the college. Who would like to?
I will, thank you.
Thank you, Mr. Brenning.
Thank you. On behalf of the Australasian College of Paramedicine, I thank the Chair and the members of the committee for the opportunity to contribute to this important piece of work. Our health system is no longer fit for purpose. It was built to treat acute and emergency patient presentations, and while we've continually added to it and built on, it isn't working. We have an ageing population with chronic and acute health conditions that require ongoing care and management. Our tertiary hospital system is not designed to manage these patients effectively. We need to be managing the ongoing health of our community, in the aged care facility or in the home. Ramping an access block is a symptom of inpatient hospital services unable to meet patient needs. The inability to move acute patients from emergency departments to hospital wards, and the safe discharge and out of hospital care of patients. Ultimately, ramping an access block highlights a health system in distress. And the key issue is the inability for the community to access the right care in the right place at the right time. We're all aware of the issues of primary health care and the community access to it. I think we all know the broader solution. We need appropriately resourced, equitably distributed and universally accessible and free primary health care would address many of the issues facing our ambulance services, emergency departments and hospitals. If all non-life-threatening, non-urgent conditions were treated in the community, that's via a GP clinic, in the home or aged care facility, via multidisciplinary teams, and most non-life-threatening, urgent conditions were treated in larger clinics and urgent care centres, you will have gone most of the way to solving the problems with our system. Speaking specifically about paramedicine, we became a registered health profession 4 years ago, but we have not been appropriately considered and embedded in the health system outside of the usual ambulance service emergency response. Paramedics are independent practicing clinical experts in urgent and unscheduled care. They are comfortable treating patients in any setting, pretty much like no other health profession. And they are needed to be strongly considered part of the solution to deliver community health care that's required today and into the future. Thank you. We look forward to discussing our submission in more detail.
Thank you. That was a very precise and clear and opening statement that I'm sure will lead to questions from committee members. Mr. Castellan, can I invite you to make an opening statement?
Thank you. I'm going to pass that across to Scott Beaton, the Vice
Sorry,
President.
Mr. Beaton, I shouldn't have assumed. Mr. Beaton.
No problems. Good morning, and thank you for the opportunity to appear on behalf of the Australian Paramedics Association New South Wales members. My colleague and I have combined ambulance experience of over 40 years. We have worked in metropolitan and regional New South Wales, and both of us are acutely aware of the ramping or bed block and access block. Bed block is not a COVID problem. It has been a problem since before we both joined New South Wales Ambulance. Yes, it is getting worse. But again, it's not due to COVID, it's a result of years of failure to address the key issues in our health system. In my 20 plus years as a paramedic, I've worked in metropolitan, regional and rural New South Wales. I've experienced extensive delays in metropolitan hospitals, up to 9 hours, and most recently a 3-hour ramping when on a specialist regional hospital transfer, which took a total of over 8 hours to complete. These delays impact not just the patient and paramedics who are sitting or standing idle, but the community in general when there are no ambulances to respond. To put it into perspective, 2 hours of ramping for an ambulance on a hospital transfer in regional New South Wales often means there's no available ambulance in a rural town for 6 to 7 hours. Our submission details how paramedic workforce is demoralised by this issue. 2/3 of the workforce are considering leaving the job due to burnout, of which ramping is a major contributing factor. No access to meal breaks or any other downtime results in fatigue. When a 12-hour shift with no break, nowhere to sit and eat, no way of heating a pre-prepared meal is then extended due to ramping, and then when this happens every shift, something is very wrong. This is the normal life of an on-road paramedic. This was the same pre-COVID and will not disappear as we move forward. Some successful strategies were introduced during the height of the pandemic to assist paramedics in access block, such as portable crib rooms. However, these have now been removed. There is no magic solution to fix the problem. Both long-term and short-term changes are needed to assist in easing burden on our emergency departments. These include a complete review of the triage system, expanding the extended care paramedic and patient transport workforce, and a whole of health approach with more GPs, more community support networks and greater infrastructure. We thank you and hope to be able to share our experiences with you from the front line.
Thank you, Mr. Beaton, and that's also a very helpful opening statement, which I'm sure is going to lead, in addition to the evidence from your submission, to a number of questions. So we'll start with questions from the opposition and start with the Honourable Rose Jackson.
Thank you, and thank you for coming along and your submissions and your statements, your opening statements. I think something, probably this is to Mr. Castellan or Mr. Beaton to start with, but others should just sort of feel free to jump in if they think that there's something that they'd like to add. For paramedics such as yourselves and those people that you represent, obviously with substantial amount of experience, is it fair to say, I think it's consistent with the submissions that you've made, that ramping in New South Wales is the worst that it's ever been? Is that a fair statement?
Scott?
I think that it's probably at its worst at the moment, yes. although it was bad in the early 2000s, it seemed to have been relaxed somewhat, but now it's certainly back with a vengeance, but across whole of New South Wales.
Yep.
Whereas previously it seemed to be metropolitan based mainly, it's now the whole of the state that seems to be being affected.
Yeah, I would just agree with that, that certainly it's as bad as we've seen, with regular examples of paramedics with patients on their ambulance stretchers, awaiting care into the hospital for many hours. And quite often it would be quite a metrocentric issue, but we are now seeing the carouselling of bed block going out into regional areas, which Mr. Beaton's already noted put significant strain on what is already minimal resourcing to areas that don't have multiple paramedic crews to assist them. So I would concur with Scott saying it's as bad as we've seen at this point in time.
Thank you for that clarification. As I said, consistent with your submission and the statements that you've already made. I mean, one of the reasons that I wanted to ask that is because I then wanted to put to you a statement that Minister Hazzard made earlier this year, where he described what he described as ambulance block, but ambulance ramping is, I understand what he was referring to. He described it as actually very rare in New South Wales right now. So I wanted to put that statement to you and contrast it with the statements that you've just made about how your members are telling you that it's in fact not very rare, it's the worst it's ever been.
Well, I guess the irony of that statement wasn't missed on operational paramedics at that point in time, and there was significant bed block around the state on that given day that statement was made in different areas. Look, we can always look at data and strategies and processes, but ultimately our cohort is a group of people, and I think the previous submissions have stated that it is the professional individuals that keep the systems together, and we advocate for those people, and by default we advocate for the patients that we see when we go out there. So bed block is a significant concern for us at this point in time. It's been an ongoing concern. We've reiterated the dire diagnosis of bed block at the moment, and we acknowledge that there's no simple answer to that. But we are certainly here and thankful for the opportunity to provide some clarity on our perspective.
I mean, we might get to some of the, potential solutions or responses in a minute, but I did just want to draw you out on this because I think it is first necessary to establish the nature of the problem. I mean, it's clear from your submission, but it's also clear from that statement from the Minister that the government doesn't understand or accept it's a problem. He describes it as very rare. So you mentioned that the irony of that statement wasn't lost on your members. In terms of the feedback that you got from your members in terms of comments like that it's very rare, that it's not a problem in New South Wales, it's perhaps just a COVID thing, or it's just a winter seasonal thing. The feedback from your members on those kind of statements is that that's just not true, isn't it?
Well, from our members, that would be correct. We'd recently done a survey and 80% had stated they'd waited over 4 hours in bed block in the last 12 months. So was every paramedic stuck in bed block for that period of time on that day? Probably not. But it certainly is an issue on that day, and the feedback we got that was that wasn't a realistic statement from the coalface.
I mean, in your submission. Oh, sorry. Yes. Go ahead, Mr. Beaton.
On the day that the minister made that comment, our Facebook page lit up with photos of the day, showing the bed block at varying hospitals around the state to obviously highlight that he was incorrect with making that statement. It's a daily occurrence. It's not a rare thing.
Yeah. Good, thank you. So we've established, at least from what your members are telling you, it's a real problem. I next want to move to some of the consequences of that problem. I mean, the impact that the ambulance ramping is having on patient care. In your submission, there are some pretty, horrific stories about patients whose care was seriously compromised because either an ambulance wasn't available or they were stuck in an ambulance and unable to get the sort of best practice care in an emergency department. I think that really goes to the point that you made and others have made. It's not just about statistics and data, it's about real people. So, stories such as patients with shortness of breath waiting 40 minutes for an ambulance to arrive, subsequently having a cardiac arrest and being pronounced dead, a patient who was hit by a car waiting on the side of the road for 45 minutes, multiple patients having heart attacks, waiting for proper care in bed block, paramedics doing CPR in hallways in front of other patients to try and revive patients. Those stories are very horrific. Would you say they're very rare? Have you picked out, the sort of worst of the worst, the sort of, things, or would you say, in fact, those stories are becoming more common? Give us a sense of the frequency of those kind of stories in New South Wales.
Yes, well, whilst I don't have my finger on the pulse, pardon the pun, on all of the cases across the state, certainly those issues have been submitted by our membership due to the significant concerns that those members felt on behalf of those patients, the delays that were seen. Yes, I've heard of those stories. I've potentially been involved in similar stories like that over the years. Our concern in regards to delays and ongoing response time delays to get to our patients is that these occurrences can and will happen. In regards to, is it happening more often? I would suggest that the population growth, our ageing community and the comorbidities of care out in the community, of illnesses in the community, would suggest that these are becoming more prevalent, and we need a fit-for-purpose paramedic workforce with suitable resourcing to get to them and attempt to give them every opportunity at the best clinical care.
I mean, I want to invite Ms. Murphy or Mr. Brunning to comment as well. I mean, do you have, in terms of the adverse impact of ambulance ramping on patients, is that something that you have views on as well?
Yes, thank you. If I could make a comment, I think it's there's plenty of research and evidence out there that is demonstrating that patients waiting for care have worse outcomes. And in our submission, we presented some data from New Zealand and from Australia that shows poorer health outcomes. Our previous colleagues from the College of Emergency Medicine talked about the ageing of our community, and so they're living with chronic health conditions, and therefore they're more complex, and therefore the complexity of those conditions need to be treated. And so when there are delays in treating those, then there are worse outcomes as well. So our experience is the same, that patients are deteriorating, and that's not just poor health outcome or death for our patients, but it's the impact on our colleagues and our doctors and nurses and paramedics that are trying to look after these patients who are, because of the systems that we're working within, inhibited from being able to provide best care. That's why we come into this profession. Having spent 27 years myself as an intensive care paramedic, we want to look after patients. We want to deliver best care. We're driven to do that. And so at the moment, there's this structural system that's not allowing for that to happen. And the consequences are felt on both our patients and our staff and our colleagues.
I might just ask one more question and then invite my colleague, Mr. Donnelly, to ask some questions too. I mean, I wanted to just, there sometimes is a little bit of commentary in the media that's encouraged by government that it's the fault of patients, that patients are calling ambulances for silly reasons, that they sort of have a blood nose or, they want to get, some kind of relatively minor treatment done quickly, and so they just call an ambulance. I mean, is that your experience? Is this a problem because it's the patient's fault and they're the ones calling ambulances for sort of silly reasons and chewing up resources that should otherwise be going to those more serious cases that we've identified, people waiting on the side of a road after a car accident, people with breathing problems? Or is it in fact not the case that patients are chewing up resources unnecessarily but are calling ambulances because they genuinely need urgent care?
So if I could start by answering that question. So this is absolutely not the patient's fault. This, we are responsible to provide healthcare for our communities, and we pride ourselves on providing great health outcomes in those communities. When patients can't get the care they require, or they don't have access or the availability to that care, then they seek alternative sources to get that care from. They're not the experts in healthcare. They're not the experts in the services that they need. We are. And so they will tap into the most available service that's at their beck and call when they need help. And for them, they don't know the difference between a life-threatening emergency. They're not trained when blood starts pouring out of your nose to know what to do. And so they're it's an emergency for them. And so do they call 000 and does an intensive care paramedic come to something that they are overqualified to treat? Absolutely, that happens. Is that the patient's fault? No, that's not the patient's fault at all. And are patients waiting for care are the patients that are waiting for ambulances, is that the patient's fault who's using the resource? No, it's not. It's a failure in our system to provide access and availability of the healthcare that our patients and our communities need in the time that they need it.
Thank you. My questions to both organisations, but the question actually specifically presents itself in a comment within the submission of the Australasian College's submission. Specifically, it's under recommendation 1, but the sentence is the one I want to particularly comment on. It states in the second paragraph, and can I just say, before I go into the question itself, I think a number of people outside medicine and health as professionals, or people even on the edge of it, would be surprised by this statement. But it says that aged care facilities must provide holistic care to deliver palliative care and end-of-life care in the home or facility. I'd just like both of the organisations, and it doesn't matter who answers it, multiple answers, that one just assumes that particularly facilities are where many people enter into and ultimately end their life, and that may be quickly, it may be not, as the case may be. And of course, at the end of life, when someone is getting towards the end of their life, I'm informed by doctors, it's pretty predictable, that particularly in the last 7 to 14 days. So death occurs regularly, or potentially regularly, in these types of facilities. But I've heard time and time again, and this suggests this sentence, that in fact, in a number of instances from these facilities, people are quite close to the end of death, transferred to an emergency setting via the emergency department in hospitals in quite significant numbers. In other words, it happens quite often, and ring 000 and get the ambulance. Would you care to comment on that and the extent to which this does happen in either residential or aged facilities?
I'll start, given it was the college's position. I think that my opening statement touched on the challenges that our health system has, where it's really geared, the hospital system particularly, to acute and emergency presentations. And we have this ageing population. And so we're forever going to fill up the hospitals. We can build more, and we did need more, but the beds are just going to end up being filled up because these people at their end of life require some more care than is generally available in an aged care facility. But do they require emergency acute care? Yes, if you've had a fall and broken a hip, yes, you go to hospital as an aged care resident. But we need to be able to get people back out of hospital to their home, to their aged care facility, where there is holistic complementary care to take them through to their end of life. If we're going to put every aged person into hospital, we are going to have a problem.
At the end of their life.
Yeah. So that's where we need to work out a system, and where our ideas of solutions are, is that if we have multidisciplinary teams, and that is doctors, nurses, paramedics, allied health, able to provide a more complete care for the aged and people in those facilities and in their home as well, that we can treat them there and keep them there longer to the end of their life, preferably. I don't know how many people feel that they want to die with tubes out of them looking at strip lights, you know, in a hospital. I think they'd prefer to die in their home or in their facility around their friends and family. And if our solution is everyone goes to hospital, then it's going to be full, and the care that people expect and want isn't going to be there. And that's where the solution needs to be. And we're talking about community paramedicine, we're talking about innovative models of care, we're talking about what does our community need to age respectfully, gracefully, and die comfortably.
End of life, yeah.
Yeah, and that's really important. And I think that's where, you know, we've heard from the College of Emergency Medicine, you know, build more hospitals and more beds and more flow through. We actually need to stop taking so many people to the emergency department. We need to treat them in the community. We need the health professionals working together as multidisciplinary teams and deliver complete care to take care of our community effectively.
That's
And
very
if I could add one point to just raising that, and it goes back a little bit to what Ms Jackson was saying earlier, but our aged care workers currently in these facilities are human beings as well, and they're treated to a skill set. And so when they get to the end of their skill set and ability, they panic or they worry or they're not sure what to do. And when they can't access, you know, primary support or GP support or after-hours support, they call an ambulance.
Yeah.
And when the ambulance
Even
can't
RN
access,
support.
absolutely, if they can't, exactly. And so even, you know, when the ambulance gets there, you know, if there isn't the primary care or the ability to prescribe antibiotics or the ability to do any of those kind of small tests that could be done, you know, with a team of people that could come and visit and support that patient to stay in that facility, then they take them to hospital because they know they need an x-ray or bloods done or antibiotics. All of these things can be provided in the facility if there were the access to those kind of tools and specialist skills within the facility in that primary care setting.
Can I just hear from the association in terms of practical experience? I mean, you may not be able to reduce it to a percentage of visits to facilities in any given day or week, but just as a general observation.
Did you want to start off, Scott?
Yeah, in respect to a lot of the regional areas out here, the aged care facilities don't necessarily have a registered nurse on duty at all times. In fact, quite often it's 9 to 5, Monday to Friday. So therefore, when a person does become ill and they have an end-of-life plan, as was touched on before, the staff only have a certain skill set. So then their fallback is to call an ambulance to then assess this patient. And they just want that patient out of there, and we have to take them to the hospital. There's also other issues where you have some patients that do not have end-of-life plans, and therefore we're then bound to take them because there's no way of leaving them behind at the nursing home where there isn't the level of care. GPs, you know, putting in end-of-life plans and assisting the patients, or if they call the GP for an assessment of this patient. GPs are so busy out here where you can wait 3 to 5 weeks for a GP appointment in some of our regional communities. So for the GPs just can't drop everything, get themselves down to the nursing home to check out that patient. And it's a difficult situation. But I do agree with our previous statements from the college is that we should be looking at a greater scope of practice so that we can get the whole of community to leave these people in place, whether it be in an aged care facility or at home. You know, people make a decision they want to die at home or they want to die in their current surroundings, and we shouldn't be forced to be taking them to the hospital.
Thank you very much.
Yeah.
The Honourable Emma Hurst.
Thank you. Thanks, Chair, and thank you all for joining us this morning. I wanted to start with some questions to Mr Brunning and Ms Murphy. You note in your submission that access block and ED overcrowding contributed to higher mortality rates of 20 to 30%, which is an absolutely shocking figure. And I believe the data relates to 2009. I'm wondering if there's any more recent indication of the impact on mortality rates and if it's going up since that 20 to 30% figure in 2009.
The most recent data that we had, and it was also mentioned earlier, I think it's on ours, and it's come out of New Zealand, there was a 10% greater chance of dying within 7 days of admission when experiencing delays in admission. And I think the College of Emergency Medicine also quoted those figures. So I think that we probably need some up-to-date data from Australia would be good, but I don't have any other details of that. But that's very recent out of New Zealand.
There is a study about to be published out of Victoria, which looks at the quality and safety and morbidity and mortality of patients while they're ramped and waiting for entry into that emergency department.
Thank you. That's really useful. Thank you. Your submission also recommended using profiling tools to identify and track medically at-risk Australians and provide in-home services. But you note that there's currently no effective models to do this and that the current model is unsuitable. Can you tell us a bit more about this current model and how it works or doesn't work and what needs to be improved?
So there's a couple of excuse me. There's a couple of different ways of I guess looking at these at-risk and high-risk patients. And so one of the trials and pilots that's happening in a regional Victorian town is around using paramedics to go to check in on patients when they've had a procedure or returned from hospital, just to do that kind of follow-up holistic care to make sure they've got the right services and access to those kind of things. So that requires notification and linkage between primary healthcare networks, tertiary healthcare networks, the whole of kind of government, the whole of health, which is a bit clunky and difficult. And so we're advocating to look at how we can better support these patients and how we can link in across tertiary and primary healthcare settings so that these patients are tapped in and have the care they need. And we know that if we follow up and if we go and check in that they've got the right medication and they've got access to the supports that they need, that they don't represent and that they don't, come back into that tertiary system. But also there are complications associated with all these kind of procedures. And I'm using an example of, let's say, someone has chest pain or they have a heart attack and they go in and they have a stent or they have a procedure. There's a 10% risk that stent or that procedure will reocclude in those first 14 days. So, tapping in with those patients and rechecking in on them to make sure they've got all of those things that they need is really important because it stops that representation, but it also stops deterioration or impacts of side effects or consequences.
Thank you. I've got some questions as well for Mr. Costello and Mr. Beaton. You mentioned in your submission that cars should be sent to relieve paramedic crews once they are past their finish time and stuck in bed block, but that it rarely happens. Could you speak to some of the obstacles that are being faced about sending out those relief crews?
The obstacles in your question are the desire or want to follow the policy, number one, and the elephant in the room is the enormous workload that we are currently experiencing. Yes, that is a policy that New South Wales Ambulance does have to ensure, and the reason why you would have that is to ensure that paramedics who have already done 12 hours and are entering into their 13th, 14th or 15th hour will be relieved so that they can obviously after that period of time it's very fatiguing and resilience does dip when you get that long into a shift. So I would, to answer your question, it doesn't happen very regularly, even if paramedics particularly ask for it. In saying that, I'm sure there will be examples where it has happened, but it is not the norm due to the enormous workload at the commencement of the new shift. There's no cars left over to do those types of resilience roles, to get them off, to get them home to see their partner, put their kids to sleep or shower, or just, you know, focus on basic hygiene functions. So, Scott, anything from you, Matt?
No, I agree. It does happen, but it's quite rare because there's a large amount of jobs sitting there waiting for that next shift to come on to cover. And then they end up in the same queue as the crew that's been waiting there, waiting to finish their night with their day shift.
Yeah, thank you. You also say in your submission that many members have identified improving the triaging system as a key action in reducing bed block, and that the current triaging system does not allow for clinical nuance. Can you expand on that and give us any suggestions on how to that triaging system actually needs improving and how it will work in practice?
Oh, well, I can certainly start, and I think it complements previous discussions around holistic care within the community, that we probably need to have a level of nuance within our triaging system to ensure that, and I also want to reiterate that people phoning 000 are not the concern. They are phoning because they are generally upset and concerned around their personal well-being. That's why they call 000. But ultimately, in the triaging system, it's a very blunt instrument that it catches a lot of patients as very, very high priority response times. When the paramedics get there on scene, it may not have been the case, and so I guess for us, we just want to see that the most appropriate cases are being responded in a timely manner to reduce any of those negative outcomes that we heard about a little bit earlier in our submissions around devastating clinical and personal outcomes for not only patients, but it's a ripple effect to families and the paramedics that deal with this. But certainly making sure that that nuance flows down to ensure that community paramedicine becomes a big part of our trade, that we can support the community. I think that rolls on to what you just mentioned.
Yeah. Ms. Murphy?
If I might clarify, that the triage system we're talking about is the triaging of 000 calls.
Yep.
Yeah.
Yeah. So when a call comes in, there's a system that the call takers go through. It identifies whether or not the patient is serious. Now, this also occurs with the booking system, so a non-urgent calls that can come in for transfers, etc. Now, if someone's suffering a heart attack and needs to be transferred from one smaller hospital to a large hospital, then they should be given the highest priority. But when someone is requiring an X-ray at 3 o'clock in the morning, because there isn't one, do they really need to go from a small hospital to a big hospital in the middle of the night for an X-ray? And they're the sort of things that we're talking about, that the system is failing in that it doesn't identify the most highest priority first.
Could I make a comment, if I could, just for the benefit of the committee here?
Thank you.
And so I think there are two things. There is the 000 triage filter system, and when you have a call centre, particularly in Sydney and Victoria, which is my experience, where you have 1,500 calls coming in a day, the priority and the purpose of having a rapid ability to triage that call is to identify those patients in immediate life threat, for the call taker to be able to create an event and send an ambulance, but to provide that life-saving intervention on the phone in that moment. So those tools, usually ProQA is the most common tool used across Victoria. It's an internationally renowned medical triage tool. And so you need to have a blunt instrument to filter that very quickly to be able to identify those critically unwell patients who can't wait in a queue. And we've seen the recent news around Esther and communications and delays to 000 calls, which is catastrophic. And so the next part of that is, once you filter that blunt tool and you need to have a look at what that other pool of calls, so take out that 1.5% of true emergency life-threatening calls, and then you have those other emergency events. And there is some evidence that suggests that being able to have a health professional that's trained, so in Victoria we use paramedics and nurses. New South Wales has developed the same tool during COVID for that triage system in its infancy, but expanding that would go a long way, which is the virtual clinical care centre. And so what we've been able to demonstrate is it's very safe for these patients to go through to what we would call a secondary triage service, to then spend a bit more time with the patient, say, hey, what's going on? Using your clinical knowledge, using some validated tools to identify the category of those patients, to filter again with some, life-threatening emergency questions, because some of those get missed, particularly for non-English speaking or elderly patients. So to filter that again, but then to be able to provide advice, home care, and direction to these patients. And we've seen in Victoria 50% of those patients that go through to secondary triage services, if you have appropriate alternative service providers that you can connect these patients to, don't require an emergency ambulance. New South Wales are experiencing a similar thing, and so expanding that kind of service to help patients who call Triple O because they don't know what else to do and they've got a problem that needs healthcare, I think is really important. But they're two separate things, and both need to go hand in hand. Sorry.
It's very helpful. No, that's very helpful to know. Thanks. Kay Femin.
Thank you, Chair. So let's just continue on that issue. So that just makes perfect sense. That's just absolutely, that's part of the solution. It's common sense. Why is the New South Wales government not doing this? You're saying Victoria is?
They are doing it.
Yeah, so New South Wales are doing it. And
what else needs to happen? Because you said before that the triage system is broken. So what more needs to happen then to fix it?
Well, I think Ms Murphy has provided some clarity on that, is that New South Wales have come in a little bit late in the piece, and it was probably COVID prompted by that there was just such an enormous volume of calls coming in. So we do have this VCCC, this virtual care centre, where you're right, the most important and life-threatening cases are having ambulances responded immediately, and the call takers are staying online, and if their call takers believe it's a significant event, they can be referred to more paramedics or medically related people in the call centre to assist the journey on the other end, because we don't know what's going on the other end. But yes, we do get to these non-life-threatening events, which make up 9 out of 10 of our calls that we go to, and how they can better be managed. We would hope that the model going forward is supported. It's the implementation of it at this point in time is we're cautiously optimistic that we can progress forward with this, and we would suggest that would be one of the strategies that we could use progressing forward to ensure that life-threatening cases are responded to in a timely manner, and lower acuity cases also can be responded to in a timely manner, but relative to the incident on the other end of the line.
Thank you. I'll push ahead just because of
Sure.
time. Mr. Beaton, I just wanted to get your response to, and my colleague has mentioned this before, but particularly your response to the comment by the Minister, Brad Hazzard, in the budget estimates in March this year, in response to a question I asked him about ambulance ramping. And this is when he said the concept of what still causes major grief in other states, that is ambulance block, is actually very rare now in New South Wales. When you heard the Minister say that, what was your response, and what was the response by your colleagues?
As I said before, it was actually, I laughed, to be perfectly honest, because it was just a statement to show that perhaps the Minister or his advisors are completely out of touch with what's actually happening in the hospitals. Now for years, I know I've been at a hospital where there's a system called the Matrix, which stops you from going to a particular hospital. Only a certain amount of ambulances within an hour can attend. They've put hospitals on bypass so that some sort of politician can come and visit and see that there's no hospital ramping there. That's because ambulances were denied from going to those hospitals. This is a thing that's been happening for years, but the problem is out there everywhere. We've got daily pictures on our Facebook page of hospital ramping, whether it be in Gosford Hospital, Dubbo Hospital, Wagga, Liverpool, Westmead. It occurs everywhere and it's on a daily basis.
Thank you. You've also said in your submission that, in fact, ambulance ramping was terrible, I think, in 2017 to 19. I'm trying to find the exact thing, which I probably won't be able to in time. But, in fact, that this was going on before COVID, that this was an issue that your members were raising with the government, that things were getting worse. Do you feel like the government has been ignoring your calls for years now to fix this problem, to get more ambulances obviously on the roads, but also to fix the problem in terms of access block in our hospitals?
Yeah, it's been a problem, as I said in the opening statement. It's been a problem in the 20 plus years I've been a paramedic. It is getting worse. We had the height of our flu seasons where it was always bad for years and years, but now it seems to be a constant year-round thing. So instead of being seasonal, it's now just a day-to-day problem that's occurred. Everyone buries their head in the sand and they treat it as normal, and this is the problem.
Thank you. I mean, it just is extraordinary that we had, I'm quite angry about it because it was a question from me to the Minister after speaking with your members actually about the extent of ambulance ramping, and his response to me was that it is very rare in New South Wales. I mean, that's what the Health Minister is saying to this committee, this Health Committee, when asked about what he is doing about ambulance ramping. It's not acceptable, is it, Mr. Beaton?
No, it's not. And it's not been acceptable for a very long time. It's harmful to paramedics, it's harmful to patients and the community in general. We have response times that are blowing out across the board, and increasing the amount of paramedics puts more ambulances on the road, but that just at the moment puts more ambulances into bed block. It's great to have more ambulances and more paramedics, but it doesn't help when they get to the destination with the patients, that they're then all stuck in for hours on end and there's still no ambulances to respond.
Yeah, thank you. That's actually puts it all into a very good perspective, that last statement of yours. I did want to explore a little bit about the failure of this government to support the extended care paramedics program. You have highlighted that in your submission, and it's also something that I've asked the government about multiple times. Why is New South Wales Ambulance and the government so unsupportive of this program that clearly saves the health system money? If there were more extended care paramedics, if they were supported more in regional areas, what's the politics behind the fact that the government isn't supporting something that your members want that would save the health system money? Mr. Castellano, I might go to you firstly.
Sure, thank you. Thanks for the question. Look, I can't actually speak to the politics around that. Only the people involved in those decisions can speak about that. Our members are telling us that we believe it would be a very, very worthwhile program to be rolled out across the state. I think it goes without saying that having highly skilled and qualified extended care paramedics with a much larger scope of practice to provide the lower acuity and out of hospital care that a lot of our community requires can only be advantageous to them.
Mr. Castellan, can I just jump in? My time's about to expire. I do want to just ask for the response on this, that you've said in your submission that extended care paramedics are routinely used to stop the clock on response time key performance indicators. Could you explain what that means?
Well, an extended care paramedic has those higher skill sets for those low acuity cases, but to keep it short, they're quite often being used for hot or P1 responses, lights and siren responses, to get to higher acuity cases to tick the box on KPIs and response times. And it appears to be not the most appropriate use of those skill sets out there, and we believe it's hiding a problem of appropriate paramedic resourcing and some of the issues that will come up in this inquiry.
If I could comment. Could I comment, please?
Yeah, go on, please.
Just the college, we're fully supportive of extended care paramedics and community paramedicine and the greater utilisation of the skill set of paramedics. But the expansion or the greater utilisation, I think, is partially hamstrung by the lack of expert paramedicine advice to government. Currently, we have a situation where, you know, if you want to know how to use paramedics better, where does the government go? Do they go to an ambulance service who have KPIs and requirements to hit targets and move people and get them to hospital and do these sort of things? Actually, what you need someone independent to be able to say, you know what, you can actually use paramedics in this way. And the ambulance service may not wish to propose the utilisation of paramedics in different ways because it may take away from the emergency response requirement. In Victoria, we have the one and only Chief Paramedic Officer who sits separate of the ambulance service and is able to provide advice as to how paramedics can be utilised in new and innovative ways and different ways. And we actually saw through the initial start of COVID that actually made a significant difference because paramedics were able to be utilised much more widely than emergency response and to support the health system with taking care of COVID patients who were, you know, able to leave nurses in hospital and those sort of things.
Sounds like you're suggesting that be a recommendation to this committee.
It's in our,
Yes,
it's in
it
our
is.
document.
It's quite training intense, though, for an extended care paramedic to be taken off-road and to provide the clinical skills that they need to then go out, progress out into the community is quite an intense process. And again, you can't just, cook one up and have it ready to go tomorrow. It takes quite a while, so there is a delay. We've just found that the ongoing training for extended care paramedics and their resourcing out to regional and rural areas appears to be difficult for New South Wales Ambulance to manage. Because there are a lot of core skills that they need to complete pretty regularly to ensure that they're competent in those skills. And we would like to see extended care paramedics, complementary to your submission, rolled out across the state to smaller communities.
Thank you very much. We'll move now to the government questions. Sure. Now, we will continue after 11:30, which is a scheduled break, to ensure you get your full allocation of time. So are you okay to stay back for another, say, 10 minutes?
Yes.
So over to the government, the Honourable Lou Amato.
Thank you very much, Chair, and thank you all for coming to today's inquiry. Look, your knowledge and input is very valuable to this inquiry. I might go to Mr. Beeson first, and I don't mind who else jumps in afterwards, okay? But you were touching on aged care facilities earlier on, and you said about registered nurse. Do all aged care facilities have registered nurses? And if they don't, if aged care facilities had a better system in place, would that be better for the patients there? And also, would that also alleviate some of the pressures on the hospital system?
I can't comment on all of the nursing homes in New South Wales, but obviously from experience in my area, that the registered nurses that work in our aged care facilities in our regional New South Wales, they generally work 9 to 5 Monday to Friday. There's usually one registered nurse at our facility, and then everyone else is in either an enrolled nurse or a AIN assistant nurse, someone in training. So quite often when they call 000 and we go through the VCCC that was discussed before, they're triaged, but if there's no registered nurse on site, then we get sent as an emergency response to check out that patient. Whereas during the day when there's a registered nurse, what we've found is that they will go through a process to treat the patient in-house before sending an ambulance if required, sometimes a long time down the track, or we just aren't sent at all because that person, that registered nurse can treat the patient as per the advice from the VCCC.
Okay, so in the aged care facilities, how are they treating then the residents there with end of life? So if a registered nurse is only there for, say 9 to 5, what's happening after that?
Well, after hours, if something goes wrong with that patient, is when they call 000.
Then they've got to go through 000 and wait.
We go through the process, and quite often we're transporting these patients to the hospital.
It's entirely appropriate to go to some end-of-life cases when there are some remedial treatment that can keep them comfortable, and that's entirely fair and reasonable. The end-of-life process, something which people don't really talk about, can be a very, very ugly situation that is very confronting for people who aren't in the field. And assistants in nursing who have carriage of anywhere between 20 and 80 patients after hours, there's other work-related stressors on them to fulfil their role, and it is a very easy fix to phone 000 to have paramedics come out. We are very thankful for the workforce that works in aged care and provides support for our aged Australians. They do a fantastic job. They do have some clinical advice call lines that they can contact, but it doesn't actually really make up for the high skills of a registered nurse on site that can be hands-on.
It's definitely an improvement in terms of the care to those in the aged care facility if there's a registered nurse on staff, and it would definitely reduce the likelihood of a call out to a paramedic to come, from the ambulance service. And I think that, we know that the federal government has proposed, a nurse in every aged care facility, which, I think is a good step. But we do still have the situation where even with the nurse in the aged care facility, once you hit the top of their scope and what they can do for that patient, then they're calling the ambulance. So I think it improves the care that is provided, but it doesn't provide all the care that is needed, not just at that end of life phase, but in the aged care facility. And that's where if you had multidisciplinary teams with a mixed skill set of doctors, nurses, paramedics and allied health, that less of those transports would be required, and they would be less likely to end up in hospital. And probably what we haven't discussed is it's getting them back out of hospital as well, which is a major issue. So they go to hospital and you think, they'll be there, a week or 2 weeks, they'll be cared for, they'll get better, and then they will go back. But you get to the point where you go, can they safely go back? Can they be cared for appropriately back in the facility? And if that answer is no, then that's it, they're staying. So that's where, a team approach of the healthcare professions working together to have a much broader skill set for everyone in that group to provide that care means that we can take some of the pressure off the hospital system.
Yeah, no, thank you very much. And that's what we've heard before, even previous inquiries too, even with the euthanasia one, is that a lot of people, if they're suffering, they go, well, look, I'd rather just get out of here. I've had enough, Where if they had the appropriate care at the facilities or at home where it was, one would be less of a burden on the hospital system, and again, that would be quality time that they could spend with their loved ones. Another thing I heard as well, I don't know how true this is, but I was only talking to someone the other day. They're up, I won't mention the area, but they're talking about bulk billing. A lot of doctors now, they're not bulk billing, and that's forcing a lot of people, obviously those are lower socioeconomic backgrounds and pension and so forth, they're actually going to the emergency ward now rather than the doctors because they can't afford the bulk billing. Have you heard that? Is that true?
If I can comment on that, I think that the funding system for a healthcare model overall is not fit for purpose. So I think that it sets up people who can't get in to see a GP, or the GP is no longer bulk billing, to go find free healthcare elsewhere, and the ambulance service is free. The emergency department is free. And so it also inhibits the ability for local health districts and other providers to employ health professionals that don't fit inside the Medicare benefits scheme to be able to work and deliver care. So that impedes the ability to employ paramedics, to employ physios, to employ other people, because they'll need a fee-paying service. And so I think there's lots of challenges in that funding model. What the answer is, I'm not 100% sure. I think it needs to be multifactorial, and I think there needs to be different pathways and avenues, the current workforce incentive schemes, etc., are very isolated to just a few who are eligible to, be part of that system. And therefore, if you can't get a GP or a nurse practitioner in a community, then you can't have any health professional. And you might have extended care paramedics and physios and pharmacists who want to come and work in that community. But because of the funding model, they can't come. So the community goes without any kind of health care because our model says it has to be a GP or a nurse practitioner because it has to be under the Medicare scheme. So I think that there's lots of, and we've seen corporate services, and particularly in the mining industry and some larger industries where they're the main employer of a town and there's lots of revenue and funding, and they provide funding for health services that are bulk funding, and that creates this ability for health practitioners, multidisciplinary teams to come in and provide excellent quality healthcare for the community and not just for the workers within the facilities. And we've seen those be very successful, but it's because they're not reliant on one model of funding.
Yeah, that's based on a US model, is that right?
No, it's on the RACHO, which is the NACHO, which is the National Aboriginal Controlled Community Health Organisations model, where you have more block funding. But we have this issue, and it's the elephant in the room that isn't something that the state governments can deal with, which is the funding of primary health care being episodic and based on Medicare. Really challenges the system to provide holistic, complementary, complete care to the community. And the example Michelle's talking about is out in rural WA, which is an Aboriginal controlled health organisation where there's a lot of mining sites, and there's this bulk funding provided that means that they have a complete health system that's able to provide fully holistic care. They go to homes in the night time, and it's a good model if we could provide funding that way more universally across Australia.
Yeah, thank you. It's quite interesting.
If I may, I just say that whether it's the bulk billing or not, it's just the availability of general practitioners in a lot of the communities. It can take, like I said earlier, it's up to 3 weeks to get an appointment at the GP. Now, you have a lot of people who will say, well, I'm not that sick, I'll wait until I can get in to see the doctor. And it could be 2 weeks away, they've got a bit of a chest infection. They progressively get worse to the point where they can't breathe, so they end up calling an ambulance and they end up being presented in to the hospital. Now, then that means that they're desperately unwell. They need to be a bigger hospital. They take up a bed in the hospital now for a week, whereas the ability to get in to see the doctor in an earlier time frame with some antibiotics meant that they may never have presented to a hospital in the first place. So it's the lack of availability for GPs, whether that's through bulk billing or not bulk billing, is a lot of the issue that causes people to present to the hospital. Others who can't wait to get into the GP will then call an ambulance to go to the hospital or self-present to the hospital. The self-presentations are just as big an issue that cause ramping as what ambulances bringing patients into the hospital are, because you've got all these people self-present for minor issues or because they can't get into their GP. When an ambulance gets there, there's no beds because of all the self-presentations. So it's very much a roundabout, and the need for more GPs and a better funding model for GPs is part of it, which is a federal issue.
Yeah, no, thank you very much. I'll pass on to my colleague.
All right, McDonald.
Thank you, and thank you for your time today. I just wanted, in your recommendation, in your submission, recommendation 2, where you said consultation on models for temporary transfer of care options, if you could, I guess, expand on that. And I know you've said that they should never be long-term solutions, but if you could just, I guess, expand on what the models might be, that would help with that situation.
Okay.
So that was on the Australian Paramedics
Yes,
Association submission. Yeah, absolutely. Well, I think what I'd like to say with transfer of care, there are different models out there where it might be paramedicine based. You might have extra paramedics in the emergency department assisting with transfer of care, and in some instances there's nurses doing that. I think there needs to be further consultation because there can be local solutions available to some of these emergency departments that are specific to local area health districts. In one hospital, paramedics may be freely available because nursing availability is not, and vice versa in other areas. I think there does need to be a more collaborative approach. We have health relationship managers, which are people who are the conduit between New South Wales Ambulance and the emergency departments. And certainly that transfer of care is critically important. Not only because we want to try and release paramedics to go back out into the field to assist with patients, but because we need to make sure that they're safe as well. We were talking about early on in the piece about people being left in corridors and stuff. That's plainly not what we're advocating for at all. They do need to be in a safe clinical environment as well. So in regards to transfer of care, there are a few solutions available that might be specific to local area health districts. So that would probably be my answer to you on that one.
Thank you. And then the other question, I guess it refers to a recommendation that ACEM have put in for consistent KPIs for ambulance to ED offloading. Do you actually have any KPIs?
Yeah, sorry.
No, okay, carry on.
Absolutely. So the ambulance services all have KPIs about transfer times. They're called something different, offload transfer times. I think that, for these time critical patients, speedy, timely, efficient transfer of care is critical. I think one of the broader issues, though, is the patients that we're transferring and where we're transferring them. So we have a large pool of patients that go to ED that don't need to be in ED and could actually be transferred to other services, so urgent care centres, GP clinics. Often patients will ring because they can't get to the hospital, and so we have a system set up where ambulances take patients to emergency departments. And so there isn't a system set up to go, ambulances can safely, and there's been some pilots in Queensland and South Australia and Western Australia, I think, around transferring patients to other facilities, so urgent care centres. And there's different groups will espouse that dangers in paramedics' ability to assess the patient and take them to the right place. There's been no deaths, no adverse outcomes from any of these trials and studies that have safely, effectively picked the right patients to go to the right facilities for the care that they need. So if I can just, I think that that's really important. Paramedics are professionals. They do diagnose the patient, they care for the patient, they treat them, and they're able to determine, which facility can provide that ongoing care safely and effectively.
Well, that brings us to the end of the session. Sorry to take you beyond the time, but I have to say your evidence was very detailed and rich and leaves us with lots of material to ponder. I'm sure there's going to be some supplementary questions arising from members having a chance to read Hansard. So once that's done, we'll liaise with the Secretariat and the Secretary back to yourselves in regards to provision of responses to those. But on the behalf of the committee, thank you very much. It was very, very good and most helpful evidence. Thank you.
Thank you.
Thank you, Mr. Baton. we normally have people in the room and people on the screen, so we're actually looking in both areas, both room and on the screen, but with both on the screen, that makes it a little bit easier for us. So once again, thank you both for making your time available. We appreciate that you're very busy and had to carve out time to both make the preparation for today and make the time available specifically. Can I deal with the formality first, which is to have you formally sworn or affirmed to give your evidence? So it's part of our procedure here. And that involves asking you to identify yourself, your name, your position title if you're representing an organisation or not, as the case may be. You may be appearing as an individual. I think that's the case for Associate Professor Baines. And then swear either an oath or an affirmation, whichever you prefer, the words of which should have been provided to you, and if not, just raise your hand and we'll ensure we take you through that. So we'll start then with Mr. Waters. Could you please proceed?
Good morning. My name is David Waters. I am the Chief Executive of the Council of Ambulance Authorities, representing emergency ambulance services across Australia, New Zealand and Papua New Guinea. I will take the affirmation. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you very much. And Associate Professor Baines, OAM. Have I pronounced Baines correctly, Associate Professor? Have I pronounced your name correctly?
I'm getting crosstalk.
Okay. So we have a little bit of...
David's acclamation is in the background.
He's got the hearing open in another tab, I reckon. Often.
Can you hear that?
Professor Baines, do you have the hearing open in another tab? Are you live streaming the hearing in another tab on your browser? Sometimes that leads to reverberation.
The other point is I understand, Mr. Waters, you're coming to us from New Zealand. Is that correct? You're over in New Zealand, so there might be a very tiny lag as well. In any event, we'll just take this very carefully and slowly, and if we need to just pause at any point, we'll do. But we'll do our best to try and remediate that issue. So, Associate Professor Baines, could you please go through the formalities for the purposes of swearing or affirming in?
I still have crosstalk. Good morning. My name is Ray Baines. I appear as an individual with an abiding interest in health, and I declare no direct or perceived conflicts of interest. I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth. So help me God.
Thank you very much. I'll invite both of you now to make an opening statement, and then following the opening statements, we'll open up to questioning from committee members. Just to confirm with you, we have committee members from the opposition, the crossbench and the government here at the table today. So there'll be quite a cross-section of questions to be directed to both of you. So we'll start just with the list in front of me. There's no particular order, but if we start with Mr. Waters, you're first on my list. Would you like to make an opening statement?
Thank you. Firstly, the Council of Ambulance Authorities represents the 11 statutory ambulance services across Australia, New Zealand and Papua New Guinea. And that accounts for in the region of 4.6 million patients being attended to annually, with about 3.8 million patients taken to emergency services. Obviously, ambulance services play a critical role in the delivery of safe, high quality and timely care, providing essential emergency response services to treat patients and transport them to hospital where that is necessary. Delays in hospital transfer care occur where patients are unable to be transferred into the care of hospital clinicians in the emergency or other hospital departments. In these circumstances, the patient remains under the care of paramedics until such time the transfer of care can occur. The cause of transfer of care delays are multifactorial and often not entirely in the domain of any individual part of the health system or hospital. The resolution of the causes of transfer of care delays, or ramping as it's more commonly known, must be considered not just an ambulance and hospital issue, but as a whole of health and intergovernmental system level problem to be solved. Transfer of care delays is not an indication of an ambulance service's performance, rather than of a health system under systemic strain. The time taken to complete an acceptable transfer of care varies across Australia, New Zealand and PNG. However, 30 minutes is generally the accepted measure, and anything greater than that is considered a delay. We do have some instances where ambulance services do have a slightly longer window to do the transfer of care. Over the last 2 years, CAA members have reported that their transfer of care delays are increasing, and it's not uncommon to see periods of 4 to 6 hours patients remaining on the ambulance stretcher, and in some instances exceeding that up to 12 to 14 hours have been reported. The transfer of care delay is an important consideration in the care of patients, and it has a direct impact on patient safety. Ambulance services have traditionally transported a patient to ED when that's required and handed that patient over, now being faced in many jurisdictions, not just in Australia, but globally, where they have to care for that patient for much longer periods on the stretcher, which involves a different type of care to which they traditionally provide. This also has a direct impact on their ability to respond to other emergencies in the community, which leads to patient delayed care and potential harm for patients waiting for an ambulance in their moment of emergency. I'll leave it at that and happy to take questions when you're ready.
Thank you very much, Mr. Waters. That's very helpful. Associate Professor, can I invite you to make an opening statement?
Thank you. I recognise and pay tribute to the exceptional dedication and expertise of those working at all levels within the health system. That commitment is ever present, but has been especially notable under the demands occasioned by the COVID-19 pandemic. There is indisputable evidence that the health system is under stress, which is placing both patients and healthcare workers at unacceptable risk. The consequential impacts and the resulting harms are well described in several submissions to this inquiry. Shortfalls in staffing and maldistribution in the health workforce has had a profound impact on ageing patient populations and those with chronic conditions and mental health issues. Past investment and reliance on tertiary facilities means that hospital emergency departments have become major 24-hour entry portals for general as well as emergency and unscheduled health presentations. The result is highly visible bottlenecks with ambulance ramping, bed block and hallway help. At a national level, a greater focus is now being placed on primary and preventive care. These developments need to be considered in framing the effective use of the available health workforce when it comes to the delayed handover of patients. An expert and available workforce is the key to effective healthcare. While the terms of reference at this inquiry are very broad, I've therefore focused attention on the sustainability of the health workforce and the current and future role of paramedicine. The submission emphasises the interconnected nature of healthcare and the gatekeeper roles played by ambulance services and primary care providers. I discuss how paramedics can support primary care and thereby potentially reduce the input demand for emergency department and hospital care. The recommendations I've made also outline mechanisms for the avoidance of ambulance transport to emergency departments and thereby reduce the incidence of patient offload delay. I provide a snapshot of paramedicine as an underutilised health profession and how the legislation and regulations pertaining to paramedic practice have not kept pace with the rapid development of the profession and expanded practitioner capabilities. I suggest that consideration of paramedicine has revolved around the ambulance services with inadequate consideration of the paramedics who work outside those organisations. This ambulance-centric focus creates uncertainty regarding the legal status of private paramedic employment and inhibits the use of paramedics in other areas of health. Paramedics already can be found in GP clinics and hospital emergency departments, but their engagement is sporadic and the profession is ignored for funding and Medicare purposes, which is, I agree, a Commonwealth responsibility. But put another way, it's like having legislation and regulations that recognise registered nurses who work in public hospitals and ignoring them elsewhere in health. I therefore propose that formal recognition of paramedicine as a health workforce should be undertaken by the government with removal of unnecessary impediments to practice that date from a bygone era. I also provide a supporting paper which I call the ANSCO anomalies, and I'd like to table that. And this discusses the need for a review of the Australian and New Zealand standard classification of occupations, or ANSCO, to ensure the appropriate classification of paramedicine and its inclusion within the health domain as a nationally registered health workforce. This might include roles as community paramedics or practitioners working in urgent care centres, GP clinics, district hospitals, or alongside other health professionals. The effective deployment of paramedics and their contribution to health will be limited without embedded representation and the input of expertise at a senior policy level. I therefore propose the input of clinical and operational advice through the appointment of an independent chief paramedic officer within the Department of Health, as already exists in Victoria. To optimise the capabilities of New South Wales Ambulance, enhanced roles are recommended for paramedics employed by that service that would enable innovative models of response likely to safely minimise transport to hospital emergency departments. Examples of new models of care from the UK are provided to supplement the pilot studies and other work currently being done within Australia. I wish the committee well, and I'll answer any queries to the best of my ability.
Well, thank you, Associate Professor Baines, and just to confirm that in regard to the supplementary document, which is headed occasional paper, the ANSCO anomalies, and then there's a subheading dated August 2022. We have received that and circulated that to members, and it will become part of your evidence to this inquiry. So,
thank you.
Thank you for that. Now we'll move now to questioning, but before we do, can I just ask members, can we pinch 15 minutes out of lunch? Which, I mean, if we don't pinch some time out of lunch, we've only got 20 minutes between ourselves. Is there any great...
Slightly reluctant to, Greg. I've just got a bunch of stuff I've got to do. I'm sorry.
Okay,
but,
well,
I mean, and the government's asking questions, I might have to do that.
No, let's be reasonable about this. So if we do 10 minutes each, that gets us to what... well, it's still too late. At 8.
I could go 5. I just have a couple of...
Okay, no.
I just...
sorry.
So
if we go through to, say, 12:35, can we just reach that agreement?
Chair?
Is that okay?
I used to go in
I'll see the questions. Okay, well, thank you. That's generous.
In order for... Because I know people got...
Okay, no, that's generous.
During their lunch break, so we're
Shall we still go for the extra 5 minutes? And
we can put ours on notice.
So thank you. We've just a bit of housekeeping. So we'll go to on or around 12:30, but no later than 12:35. So we'll move to questions. Honourable Rose Jackson.
Thank you, Chair, and thanks to both of you for coming along. I'll try and move just through a series of questions sort of reasonably quickly just to try and cover a few issues. I mean, I think the first thing just to establish clearly from both of you, it's consistent with the submissions that you've made and the comments that you've made, it is your view that the issue of ambulance ramping and bed block in emergency departments is increasing in New South Wales. That is your understanding of what is happening in our hospitals and with our ambulance system right now.
If I may answer, yes.
Yes?
From my perspective, yes, it is increasing. I think you can see from the recent report by the Australian Medical Association, AMA, that it's increasing across all jurisdictions. It is a global issue. But interestingly and worth noting, New South Wales's response still has the best performance across ambulance services in Australia.
So we recognise it's beyond question that this issue is prevalent and increasing. Do you think that that increase has been predictable? Is that something that has, we have seen over a period of time as becoming more and more predictable, or do you think that this is something that's sort of come out of nowhere? I might start with you, Mr. Bainge, but Mr. Waters, if you have anything to add, that'd be useful too.
I would suggest that it is predictable, but that the extent of or the prevalence of ramping or bed block has been exacerbated by the COVID-19 pandemic. That was not predictable. However, in the long term, there needs to be consideration of the workflow, and the workflow is a factor that is systemic, and the demand and stress within the system has been increasing at a steady rate.
Thank you. I would agree to a degree. Transfer of care delays have been in existence for many years, in excess of 10 actually. Ambulance services throughout Australia and the world have worked with health services to manage transfer of care delays. Certainly in our post-COVID or nearly post-COVID world, the peak that we saw as a result of COVID and our winter peak hasn't returned back to what we'd have expected as normal levels. And we're not seeing any signs that that's going to happen anytime soon. So I think you're right in your assumption that we will continue to see an increase in transfer of care delays due to the current system infrastructure that we have in our health system.
I mean, I think there was a comment made. Oh, apologies. Continue.
So I was going to say that I think we do have to recognise ambulance services and their colleagues in ED and health services have tried many, many different approaches to manage transfer of care. We're continuing to see new initiatives. The good thing about COVID was that it introduced a lot more recognition of the value of virtual care and virtual ED and telehealth and a whole range of other electronic approaches to managing patients. And those benefits can continue to be exploited further.
It's good to try and find something good out of COVID, I suppose, some kind of very faint silver lining. So, I mean, there was a comment made by a witness earlier today from the Australasian College of Emergency Medicine that sort of suggested you look at least, in New South Wales, ambulance ramping is the new normal. And I think that's, is that consistent, Mr. Waters, with your comment that, we just have not seen a decrease after COVID, after seasonal peaks, that this current situation is now situation normal for New South Wales hospitals?
It's jurisdictional, certainly. And we have seen this level of transfer of care delays in other ambulance services prior to COVID. And it's very well reported. I think opening the media on a daily basis, you will see ramping across all Australian states, territories, and of course, United Kingdom, Canada, and the US. The reality is that we're seeing an influx of patients who have delayed treatment, hence the increase of patients presenting to ED, and compounded by difficulty in accessing GP practices and difficulty in accessing post-hospital care in the community. We're just seeing an increase in bed block, bed access in all systems at the moment.
I mean, thank you. It is just important to establish those underlying facts because, as you say, there has been quite a lot of coverage of these issues in other jurisdictions, but the suggestion has been made that this isn't something that is a problem in New South Wales. This isn't something that our health system is dealing with. And so part of the purpose of this inquiry is actually establishing those underlying facts that no, in fact, this problem is certainly an issue in New South Wales as well. So now that we've sort of got that clear, I just want to move on to a question about, well, what does that mean? What does that mean for the individuals, the patients who were involved in, caught up in this situation? I mean, I wondered if either of you had any reflections on the adverse impacts that ambulance ramping and bed block is having on patients. What does that look like? What does that mean when we say, terms like ambulance ramping or, care delays? They can sort of sound a bit clinical in a way. I think it's important to take the conversation to the patient level and be clear about what sitting in an ambulance trolley for up to 12 hours actually looks like. What does that mean in terms of someone who's seeking care? So, Professor Banger, if you had any reflections first, and then Mr. Waters.
I'll be fairly brief. It can be demoralising. It can be mentally distressing. It can, in fact, lead to the deterioration of the patient. And I take your point. I don't like the term ambulance ramping. That totally takes away the issue of the impact upon the patient. I tend to talk about patient stacking or patient delay. That's more relevant because it's the impact on the patient that is most critical. But never forget that it also has a serious impact on both the mental and the physical health and well-being of the attending practitioners, the attending paramedics, and the attending people within the emergency department who feel demoralised because they cannot provide the help that they would like to. David?
So I would agree with everything Professor Banger said in that instance. I think it's important to note that patients spending an extended time on a stretcher is detrimental, certainly, to their health. Paramedics are trained to respond to emergencies, not to long-term care, and caring for a patient on a stretcher requires them to consider things like nutrition, toileting, pressure area care, many nursing-related aspects that they wouldn't normally have to consider and are having to adapt to. I think more importantly, though, those patients are getting a level of care. The patients that are not getting care are the ones that are not receiving an ambulance in our communities because those ambulances are blocked at the hospital. And we know, and many ambulance services are now reporting many hours lost in regards to ambulances unable to leave a patient and return to the community. In a typical shift, an ambulance crew would see 8 to 10 patients often. Currently now in many jurisdictions, not necessarily the case in New South Wales to the same degree, they're seeing 1 or 2. So a huge impact. I would like to note that I speak about ambulance service delivery internationally. And one of the case studies I hold up as best practice is New South Wales Ambulance's relationship with its health department in managing transfer of care delays. It is an exemplary example of a commitment of senior executives in both the health department and the ambulance service to put the patient at the center of their care and try and minimize the transfer of delay in any way they can. And as I said, I often hold it up as a best practice example.
Mr. Waters, I just wanted to quickly ask, do you have any New South Wales-based statistics, both in terms of the number of patients seen per shift, for example, or the number of hours lost to ramping? Those kind of figures are particularly useful for us. Is there anything that you can provide us in that regard?
I don't have that information to hand. I could take that on notice, certainly.
That would be useful.
Thank you, Mr.
Yep.
I would also mention that the health information system within the New South Wales government and health system provides an extraordinary amount of information about issues like that.
Thank you, Associate Professor. Move now to questions from the Deputy Chair, the Honourable Emma Hurst.
Thank you, Chair, and thank you both for calling in to join us today. Associate Professor Bange, your submission focuses on better mobilisation of the paramedic medicine profession across the health domain. And one of your recommendations is that paramedics be given a broader role to deliver out of hospital care, including prevention and community-based health management services. Can you talk a little bit more about, how you see this working in practice?
This can occur in a number of ways. One way, of course, is the ambulance sector itself can provide assistance in a partnership arrangement with clinics and with health hubs and the like. Another way is that the paramedic can be employed within a clinic or external community service or Aboriginal controlled health service or similar. And I've given an example of the UK system where they had the alternative reimbursement of allied health and paramedicine. I suggest that those models can be employed or looked at by the committee. I've also like to mention that Canada and the US have multiple models of community paramedicine, in most cases being provided by the particular ambulance service. But if you have an expert health practitioner, then I suggest you should try to use them. And that may be in a clinic situation, provided the government system and legislation and regulations allow that to occur. One of the problems is that the Commonwealth Government in particular does not recognise paramedics for the reimbursement of healthcare provided by the paramedic for direct billing. So therefore, unlike say a nurse practitioner, a Medicare item is not provided and there is no direct billing for the services provided by a paramedic. If the clinic provides or employs a paramedic, then the doctor or the person with the Medicare provider number has to see the patient as well in order to bill. And that means there's already a barrier to the employment or deployment of paramedics within clinic situations. And that is why I suggest that these impediments need to be examined, and to the extent that they are unnecessary, they should be removed so that you can utilise and mobilise that expert health workforce.
And will it also then require for the paramedic workforce to expand as well, do you think? And if it does need to expand, do you have any kind of rough estimation as to where we would need to expand that workforce to?
Well, paramedics are principally educated and trained to provide emergency care, but that training tends to be expanded more and more into lower acuity areas, and there are postgraduate courses that provide for additional education in areas of diagnosis in terms of more primary care. In order to fully utilise the paramedic within a clinic type arrangement, it will be desirable that paramedics undertake micro-credentialing or additional training, but in many cases that is already in place and that could be mobilised if the opportunities were there.
Mm. And you mentioned, I know you mentioned the UK in your submission, and you've just now mentioned as well Canada and the US. Why do you think we're so behind in Australia? And is there any sort of understanding that you have as to why governments have been reluctant to do the same thing here?
You have to look at the history of paramedicine, and governments have tended to view paramedics through the lens of an ambulance service. And that's good. we have in Australia some of the best ambulance services in the world. Let's make no bones about that. They are among the best in the world, and they have trained our paramedics 40, 30 or more years ago, and paramedics were employed by the ambulance sector. However, paramedics now, for the last 25 years, have been trained in universities. People pay for their own education. They become registered practitioners as a health practitioner under the national scheme, and therefore they are empowered to work to the extent of their competencies, and that generally is set by the Paramedicine Board of Australia. So the government, which has at a jurisdictional level tended to look at paramedicine as being within the ambit of the ambulance sector, has, I think, not fully adjusted to the concept of paramedics as an independent registered health workforce. However, if we look at the Commonwealth, we have this state-Commonwealth divide for funding and for legislation as well. And at the Commonwealth level, we have very few, if any, that I've met none, working for the Commonwealth Government Health Department who are paramedics. Most of the positions within the Commonwealth Health hierarchy, within the advisory committees, within the systems that would examine legislation and regulations, are occupied by nurses or medical practitioners, and that's quite understandable. So it is also one of the reasons why I believe that at the Commonwealth level and at the local jurisdictional level, we need a chief paramedic officer who can bridge the gap between what was and what should be.
Thank you.
Thank you very much. Move our question now to Kate Fairman.
Thank you, Chair. Thank you, Professor Bange and Mr. Waters. That is all very interesting. And I just wanted to keep going on what you were just talking about, Professor Bange, in relation to the Chief Paramedic Officer, which has been a recommendation from other witnesses as well. Would you care to explain how the appointment of a Chief Paramedic Officer in Victoria has led to better outcomes in that state, and possibly Mr. Waters, if you care to respond to this as well. But I'll go to you first, Professor Bange.
Well, I think the first thing is that it means that paramedicine is considered when it comes to issues relating to workforce. The Chief Paramedic Officer in that state has a senior role, one of the top 4 executives in the peak leadership team, and during discussions on how responses will be made to things like COVID, to vaccination, to mental health and other areas, that CPO has been able to put a point of view which really only comes from a lived experience. The position also is independent from the ambulance service. The ambulance service has a very important role in looking after its principal responsibilities, but the Chief Paramedic Officer stands alone or stands independently and is able to provide an input that takes into account not only the public ambulance service, but also the private paramedics who are working out there in the field. So what you do is you get an input which is more holistic and is able to take account of the benefits and the contributions from a first-hand knowledge of what paramedics can do.
Thank you. Mr. Waters, did you have anything to add to that?
Certainly. Look, I absolutely support the concept of chief paramedics. I think it's very important to have paramedicine at the table. These very important discussions regarding health and emergency management from a health perspective. My view, though, in regards to your current inquiry is that I think the most important thing to consider is that ambulance services transport somewhere between 25 and 33% of all ED admissions to hospital. That is a significant amount of patients. We have the ability to work together to reduce that amount of patients presenting to ED. The New South Wales example of the VCCC, the Virtual Clinical Care Centre, is a great example of how we can manage patient flow, provide solutions for patients in their homes without them having to be transported, or providing some forms of referral service. We're seeing a significant, in fact, a massive investment in the equivalent of the VCCC in other jurisdictions to manage patient flow to ED with a lot of success. So I think in the short term, it's definitely will contribute to reducing transfer of care delays. In the longer term, planning across the whole of health with input from the appropriate level of paramedicine, paramedics, as in the form of a chief paramedic, at those key decision-making tables will definitely impact on the quality of patient care, workforce planning, and a whole range of other contributing factors to improving patient safety.
Thank you. Quite a few submissions to this inquiry have raised the issue of lack of mental health beds, particularly, and also a lack of care within the aged care facilities, which places an additional strain on beds. And we have beds occupied, and including people waiting for NDIS placements as well. What are your thoughts on that in terms of, let's start with mental health. Does that seem to be a big contributor to access block, the access block that is at the core of this inquiry, in your experience? Mr.
Certainly,
Waters?
Anecdotally, there is a lot of support that says our mental health patients are not receiving timely care in their communities. It's very difficult for them to access any form of mental health care out of traditional office hours. The 000 system is literally the ambulance at the bottom of the cliff, and they revert to that. And although our paramedic workforce have some mental health training, they are not mental health experts in their own right. They need to collaborate with mental health teams and on occasion with police. And what we are finding in a number of jurisdictions is that a dedicated paramedic, mental health nurse, police response reduces the number of transfers to ED significantly. Although that is still a sticking plaster to the much broader issue of a lack of mental health resources and access to mental health services, generally speaking, for our community. The same could be said for aged care. We know that in the residential aged care setting, the ability for higher level clinical decision making out of hours is slim, and the care staff who are on duty refer to the ambulance service as, again, the only option left open to them. And for many of those patients, they don't require to go to ED. They need a clinical intervention in their place of residence, and that is just not available to them in the current situation.
If I could just add to David's comments, I absolutely agree. Mental health presentations are significant for the ambulance sector, and it's also perhaps less understood or recognised that falls is a key input area, particularly in the aged care area. And you find that response to falls taking somewhere between 25% to 35%. I'd have to check the latest trauma registries to confirm that, but particularly in the older patients, falls are a significant load on the system. My final comment on this aspect is that of hospital flow and the 24/7 nature of presentations, and the fact that hospitals tend to operate or have operated on a 9 to 5 basis, 5 days a week. but the load on the hospital may occur at any time. And looking at the flow through a hospital, the ability to have an exit from the hospital will determine what beds are available. And too often it's found that there is nowhere for the patient to go. No mental facilities, no aged care facilities, and the care of the exit patient is critical to the ability to have beds available and cascades back to the system right through to the emergency department.
Thank you very much.
Well, gentlemen, that brings us to the conclusion of this session. On behalf of the committee, I thank you both very much for your participation. You bring to the table a great deal of experience and knowledge and information, a fair bit that you've been able to share with us this morning, and I'm sure it's going to inform us most helpfully in our deliberations with respect to the preparation of our report and, importantly, its recommendations. So, once again, thank you very much. I do apologise for the late start, but on behalf of the committee, once again, thank you both very much. Thank you.
Thank you.
That brings
Oh, we weren't
Well,
recording it?
good afternoon, and welcome back everyone to our sessions this afternoon. We're very fortunate to have three very experienced emergency medicine staff specialists with us this afternoon, along with District Chair of the Southwestern Sydney Local Health District Medical Staff Executive Council. So thank you all very much for making yourself available. I can't imagine how busy you are as experienced clinicians out there in the field. So you've obviously had to carve out time, not just to make your submissions, which are very helpful, but also to make the time, and we do appreciate you doing that for us. The formality first, and that is to have you formally sworn or affirmed to give your evidence. It'll be easier for me if we just sort of move from left across to right, getting each one of you to identify yourself, your name, your position, title, and swear either an oath or an affirmation. I gather you're appearing, well, sorry, I'll get you to clarify this. If you're appearing as an individual, to in fact say that. If you're actually representing an organisation, you ought to say that as well. So we'll commence.
So I'd like to thank the committee again for giving me the opportunity to speak. My name's Pramod Chandru. I'll be speaking as an individual.
Thank you.
And I am an emergency staff specialist working and trained from medical school all the way to my consultant level practice at Westmead and Nepean hospitals.
Thank you.
Can I progress with the affirmation?
Yes, please.
So I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you, Dr. Chandru.
My name is James Tadros. I also did all my training across Western Sydney from University Medical School onwards. I currently work as a staff specialist in the Nepean Hospital, and I also do some work across other districts at Concord and Ryde as well. And I'm here representing as myself as an individual.
Thank you, Doctor.
As an emergency specialist. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you very much. And Dr. Ung.
Yes, my name is Sethi Ung, and I'm here as the chair of the Southwestern Sydney Local Health District Medical Staff Executive Council.
Thank you, Doctor.
I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you very much. So just to confirm, and we're grateful for, as I said, the effort that's gone into this, your submissions. So Dr. Chandru and Dr. Tadros, your submission has been obviously put before us, been processed, and now stands as submission number 21 to the inquiry. It's been uploaded to the inquiry webpage and stands as evidence to the inquiry. And Dr. Ong, your submission for and on behalf of the group, the Medical Staff Executive Council, received, processed, and stands as submission number 24 to the inquiry, and equally been uploaded to the website, specifically the webpage on the Parliament's website, and stands also as evidence to the inquiry. What I'd like to do, if you're agreeable, is invite an opening statement. Try and keep it relatively brief. That will maximise the opportunity for the back and forth questioning. So you can take as read the content of the submission, so there's no need to read from the submissions per se. We have representatives on this committee from the opposition, crossbench and government. And if you're agreeable, what we'd like to do is, after your opening statements, share the questions between ourselves, and I think that will help elucidate what's in your submissions, but also draw on some of the other points that no doubt you'll make in your opening statements. So are you okay with the procedure that way?
Yeah.
Okay, we'll commence.
I think Dr. Tadros will do a submission for...
On behalf of you?
On behalf of me.
No, that's fine. That will be nice. Thank you.
So this is something I prepared. Dear committee members, we would like to thank you for the time and opportunity for us to express and articulate some of the frustrations that we experience working in the emergency departments of New South Wales, and more specifically in Western Sydney. It was not our goal when we started out our training in medical school to find ourselves in circumstances that see us failing the needs of our patients on a daily basis, consistently lowering the expectations we have of ourselves, the system we work in, and the demands that we can place on it. But this is the truth of our current working environment. We are not good healthcare providers, and it's not because we are not trained and not educated, but because we work in an environment that we don't see as conducive to good medical care. Having trained in Western Sydney and now supporting trainees in Western Sydney, the effect on staff is extremely difficult to ignore. We are taught as doctors to introduce ourselves first, but now we find ourselves also spending the first few minutes of our patient interactions apologising profusely for delays to diagnosis, delays to treatment, absence of beds and absence of privacy, all of which most patients tolerate admirably. These people we serve bear the brunt of our failing system with remarkable good grace and kindness. The truth of the matter is that for our healthcare system, though great in many ways, is not equitable, equal, or fair. We practice good medicine, we save lives, we provide whatever treatment we do in spite of the system, rather than because of it. Dr. Chandra and I often text each other our experiences at work, sometimes amid a shift in a quick break for water or food. I suppose this is a coping mechanism for the system that we become a bit disillusioned with. I'd like to read a transcript out of one of those experiences that I sent to Dr. Chandra earlier this year, where I was expressing some frustration, but I've altered some of it just to make it easier to understand, to remove some of the medical jargon.
And may I say just, and I'm sure you'll take this into consideration, if need be, to de-identify any individual. Thank you, Doctor.
Yeah. I wouldn't generally do that.
No, I appreciate that. No,
so I'll start off with what I've said. I've spent hours trying to sort out an 88-year-old lady in kidney failure who's been waiting 6 hours. I had to go out to the waiting room to pick her up in a wheelchair. I found her laying down across 3 chairs and some bystanders were helping her daughter to slowly move her around because she was so weak. This is basically third world. They just keep prioritising the ambulance offloads who aren't their sickest. It took me 20 minutes just to get her into a wheelchair, then wheel her around to find a space to see her. Dr. Chandra replies, "What a use of time." I then reply, "The nurses just can't start anything for this woman while she's out there. They cannot give any slow intravenous fluids, but she is 88, so a fluid bolus will just put her into pulmonary edema and might kill her. Maybe that will get her a bed. I just wrote up 500 mils to try and do something for her." I continued later on in the evening, and this was 4 hours later, 12 hours after the patient first presented and 6 hours after she was first seen. It was 5 hours after I ordered her initial CT scan. I said, "Remember the 88-year-old? Her abdomen is riddled with metastatic cancer of unknown primary." 12 hours later, she finally got to a bed in time for me to tell me that she was probably going to imminently die from this. The worst part is, her and her daughter have been so nice the whole time despite our rubbish care. She still hasn't had the fluids. Dr. Chandra replies, "God, that makes me feel worse." We do not argue that we are an authority in the field, but in our submission, we wish to highlight causes of access block and ambulance rehab that we have identified, their effects on patients and staff, and strategies for improvement we would just like to put forward to the committee. Dr. Chandra and I sit before the committee today to advocate for our patients, our staff, our students, and an apparently universal healthcare system, which we believe has failed to keep up with the modern demands. Thank you.
Well, thank you both doctors for the joint opening statement. It's very frank and to the point, and I'm sure there'll be some questions following the second opening statement. So Doctor, would you like to make an opening statement?
Thank you, Chair, and thank you, committee members, for the invitation to come before you today to represent the 1,500 senior medical officers working in the public hospitals of Southwest Sydney. We would like to have acknowledged the tremendous efforts put in each and every day by our colleagues, ambulance officers, emergency doctors, emergency nurses, and allied health colleagues, doing their utmost to preserve safety and quality care at the front door of our system. We strongly believe the undue pressures and stress they are under due to access block and ambulance ramping can be offset by providing a combination of adequate hospital inpatient capacity to be able to consistently receive the flow of acute admissions and sufficient outpatient capacity to facilitate them returning home, as well as providing specialist services for chronic and complex patients to ensure their disease processes are optimally maintained in the community to avoid them needing to access hospital care acutely as much as possible. In particular, we wish to highlight to the committee the challenges faced by patients and families living in difficult socio-economic circumstances in Western Sydney, and those coming from a culturally and linguistically diverse background needing to access emergency departments for non-urgent but necessary care due to the lack of access of services in the community. Thank you.
Thank you, Doctor. Well, we'll commence with the questions, and as I said, we'll share it around between the respective groups represented here at the table. So we'll commence with the opposition, the Honourable Rose Jackson.
Thank you, Chair, and thank you, doctors, for taking time to come and talk to us. It's incredibly important to hear your perspective on this issue. I wanted to start just by sort of establishing the nature of the problem, because there has been some suggestion in representations from the Minister to this committee previously, in public commentary, that access block and ambulance ramping are not problems in New South Wales, that those are problems that other jurisdictions are dealing with, but that here in New South Wales, it's not really something that we're experiencing. That's not reflected in your submissions. That's not your experience, is it?
Are you happy for?
I'll just sort of throw the questions generally,
perfect.
and then
Okay.
if I have a specific one, I'll put it specifically, but I'm just really welcoming all of your feedback.
Perfect. I mean, I think the easiest way for me to contextualize the response to your question is that when we are taught how to practice emergency medicine by the college, in the routine guidelines, there are standards of care by which we abide. None of that really factors into account the system, with the assumption that the system is functional. Now, I can remember a time when I started practicing emergency medicine as a junior doctor, which for all intents and purposes is not that long ago. I started 2015 as a junior doctor as a junior emergency trainee. And access block and ambulance ramping was an issue, were terms that I had heard of, but were exceptions to the rule rather than the rule itself. I cannot remember a time in the recent past, and I would extend that to anywhere between 5 to 7 years, where I have practiced in an emergency department with appropriate access and flow. I honestly also am not sure that I would know how to practice emergency medicine with access and flow now, because I've had to adapt my methods of care and routine practice to cater for a system that is not working.
Yeah, and so, I mean, would you agree with the statement that sort of access block, delays in treatment in our hospitals, that's the new normal? That's normal now, for those delays to be there, for patient care to be compromised because of those delays? That situation normal?
In my experience in the hospitals that I work in, yes, that is the norm.
Unfortunately, Dr. Chandru talks about not normalisation of access block and ramping, but a numbing. The frontline staff have become completely numb to it, and not condoning it or accepting it, but have learnt to adapt to live on the knife's edge. You know, the effect of this on the frontline staff, doctors, nurses, allied health, it doesn't really get displayed until they completely burn out and they leave the workforce.
Dr. Tadros, I think you said in your opening statement that you feel as though you're sort of failing patients daily. I mean, what kind of impact does that have on you as a clinician and on colleagues who feel every single day, every single shift, that they can't provide the level of care that they want to provide?
Yeah, it's tough, and I think it's important to understand that this not all places are equal, and unfortunately, you see the hospitals in Western Sydney do bear the brunt of this, and I think that's evidenced in the data that has been presented several times, and I'm sure everyone has been across. I think it's multifactorial as well in terms of the way it affects staff. I think in terms of our trainees, we see a situation in which we have our trainees coming towards the end of the training and they have to sit exams. Those exams, like Dr. Chandru alluded to, are based on a standard of care that we're expected to deliver. And you're expected to answer the questions in a correct manner that takes into account what the hospital situation should be like. A lot of our trainees who have done all their training in Western Sydney recently do not know how to answer those questions because they have not encountered situations where they have access to the resources available. A common example is that the College of Emergency Medicine frequently asks about situations where there's a surge or there's a disaster that needs to be dealt with. And that question is answered on the basis of a hospital having a normal amount of occupancy, which we see as somewhere just above 80% or around 80%. Most hospitals, especially within Western Sydney, are operating at 100 or close to 100 or even over 100% capacity. And so those trainees actually don't know how to even approach these questions. They don't know that they can decant patients to somewhere else because they're used to operating in a situation which is always a disaster. And there have been situations where people have been confused by the question because the question alludes to a disaster and they're expected to identify that, but that for them is what they're doing every single day. I think that takes its toll, but also the fact that we are seeing high rates of burnout. We are seeing trainees who leave the workforce and go do something else. We are seeing people who, just struggle with every shift. And I think it's a very unfortunate thing to see, especially for something that we obviously have a passion for and we've chosen to do. And we've chosen to invest years and years of our lives into training towards. So it is very disheartening, but also has, marked effects on training and will for years to come.
I mean, one of the challenges here in a way is, as you say, trying to sort of decipher what can often be quite sort of clinical language into concepts that are easy to understand. And so one of the questions that I had was, in your submission, you talked about patients waiting so long after being triaged that their clinical acuity had transcended their initial triage category. Now, I'm translating that from doctor to politician to mean that patients are coming in presenting, with an illness or a disease or an issue, and that as a result of the delay alone, that situation has deteriorated. Is that right? Can you explain what that means, in a way that we might be able to sort of understand as lay people?
Of course. So I think where it starts from is the Australian Triage Scale, or the ATS, which is what's used across all emergency departments in Australia in order to categorise the urgency of treatment required for a patient, numbered from 1 through to 5. And as part of the ATS, there's an understanding that patients who have a lower or a higher number category can wait longer to be seen. And those numbers vary. I guess one of the challenges of emergency medicine in the context of access block and delays to treatment is, for example, you have a category 2 patient who, could vary in their presentation or the reason they've come to the ED, but in general requires medical review and assessment within 10 minutes of triage.
Would that, help me out here. Is that a car crash?
So that could be someone with
falling
chest
off a
pain.
ladder?
So someone with chest pain, for example,
pains, right, yep.
would be a classical example. So that patient requires assessment and treatment initiation within 10 minutes as per standard operating procedures in all EDs. Now, where it becomes challenging as a clinician is you might walk into a department and there might be someone who has a higher category. So, for example, a category 3 or a category 4. Now, that might be a patient with abdominal pain, for example. Now, a category 3 patient should be reviewed within 30 minutes. But that category 3 patient has been waiting 3.5 hours. And now it becomes very difficult to know if I should go see the chest pain within 10 minutes, or if that patient who has been a category 3, who has been deemed to be clinically urgent enough to be reviewed in 30 minutes, is now, in theory, a lower number now, because that's what I mean when I say they've transcended their category now. A category 3 that's been waiting for 3 hours may no longer be a category 3 and may actually be a category 2. And there are processes within the system to re-triage patients, but my triage nursing staff are overwhelmed with new patients, and it's very difficult for them to associate and do the clinical reviews required. And so things become very challenging. And that's, I think, what I was trying to articulate by that statement. Does that make sense?
It does. And let's talk about the consequences of that. Do you see people who you believe are dying unnecessarily because they're not receiving the care that they need to receive? Someone who has abdominal pain that's waiting far too long, chest pains that's waiting far too long.
Yes.
Is that? Yeah.
This is the answer to your question, frankly. You do see patients who deteriorate while waiting to be seen. You see patients who deteriorate while waiting treatment. There are situations that are very frustrating where you have made the effort to see a patient in a corridor with absolutely no privacy in a loud situation, sitting on a plastic chair. And you have identified their issues, you have made a plan for treatment, but you cannot initiate that treatment due to a lack of treatment spaces. And that patient, you can watch them deteriorate in front of your eyes just because you don't have any access to treatment for them.
And you've seen patients die as a consequence of those delays.
Yeah, fortunately, I have to say that they do occur, but they're not very frequent. Like, let's be honest here, not very frequent. But the bigger impact is the delays in treatment. Prior to cardiac arrest, is if you get a disease process and it is allowed to go past a certain point, then it significantly prolongs their length of stay in hospital, and then they contribute to the access block issue.
Yeah, I can see
And
that
furthermore,
vicious cycle.
death and adverse outcomes from a mortality point of view are bad, yes, of course. But when you have an 8-year-old child who has a broken elbow and they've been waiting 3 hours to get some pain relief, that is a travesty in and of itself, independent of whether or not the outcome is bad for that patient. And triage categories are assigned based on, obviously the severity of illness, but also the need for acute treatment. So sometimes the delay to that treatment can be just as bad as, an adverse outcome for the patient, both of which I think from a patient point of view are unacceptable. And so, yes, the deaths are bad, and I agree they don't occur commonly, but they do occur. Adverse outcomes occur frequently, but delays to treatment, unnecessary patient suffering occurs very commonly because of the delays that occur from this.
Yep.
I'd also like to mention on behalf of the staff working in emergency departments now in New South Wales, what goes under the radar are the near misses.
Yeah.
The patients who get salvaged, they've been waiting for a long time, then they finally get picked up and there's a quick flurry of activity. Their lives are saved, but their staff are under constant stress trying to patrol their departments, trying to pick out these patients from the wait rooms because they're not in a bed initially to be assessed appropriately.
Yeah.
Wow.
Thank you. Yeah.
The Honourable Emma Hurst, Deputy Chair.
Thank you, Chair, and thank you all for coming in and attending today and providing evidence. Dr. Ung, you've already covered this a little bit, but I just wanted to sort of flesh it out a bit more. You noted in your submission as well that a lot of patients are needing to stay longer in emergency departments, sometimes for days, and that longer length of stay is the bigger problem rather than the sheer volume of patients coming into the emergency department. Can you give us a little bit more information about why they're needing to stay longer in the ED and what's contributing to that?
Yeah, so the patients will get assessed, get diagnosed, and an initial management plan put together. But unfortunately, the emergency department doesn't have the specialty resources in allied health. And I'll use stroke as an example. Like, everyone's familiar with stroke. If you have a stroke, you need to access the stroke unit where you can get the allied health services to rehabilitate. Spending a day or more inside an emergency department where it doesn't have the right environment or resources to address that, then prolongs the recovery, and sometimes it's detrimental to the recovery. And that's because the stroke wards are full already. And not just full, but the back end of it, where their stroke acutely treated patients are waiting for a rehabilitation bed. If those rehabilitation beds are consumed already, then there's that backflow. And then the overall patient journey or the length of stay in hospital gets drawn out.
You also explain in your submission that the ambulance ramping problem is so grave, particularly after hours, that patients that have been driven to hospital are given lower priority purely because of the need to actually just free up ambulances to get them back on the road. Is this fairly standard, or is it specific to South West Sydney LHD?
I mean, I can only speak for South West Sydney. I think the gentleman can speak for the rest of Western Sydney, but I'm fairly certain that it is across the board. In that, not that they're actively given lower priority, but the demand, and we support, hospital executives getting the ambulances back out there. If we need to offload an ambulance to be able to respond appropriately in the community, then everyone will lean towards that patient waiting, who's come appropriately by private transport, just to wait a bit longer. But sometimes the bit longer ends up being hours longer.
Did the other doctors have anything to contribute to that one as well?
I agree. I think it's a strategy that has been employed at the hospitals that I work in, with both of them. And I agree. It's one of those things where it's incredibly frustrating to see people who sometimes have even waited for an ambulance and either been realized that it's going to be too long and come in because out of sheer concern, and then not being able to get them into an appropriate treatment space. And I'm not of the opinion that one process is more important than the other. It's just a frustrating clash of unstoppable forces that end up culminating in, poor patient care, really.
I think there is just a situation where there are some patients who arrive via ambulance and they may have a lower clinical urgency, but due to other issues, they need to be offloaded to a bed, for example. And so classic example is a lot of our patients who come from aged care facilities. They're not people who, an ambulance can bring in and just, get them to sit in a chair, or they can walk around and things. They need to be offloaded to a bed. And unfortunately, that then takes up an acute care bed, and that acute care bed can't be used for someone who maybe have brought themselves in. And I think it's frustrating, but we've just come to have to figure out some sort of medium, because we're trying to work in a system that doesn't really work. And so we're trying to get those ambulances back out there, because we know that will just lead to further delays in treatment for people who need it.
Yeah. And I just wanted to get your thoughts as well about the impact of all of this and the pressure on emergency doctors and how it's impacting junior doctors and other medical care staff. I assume it's affecting training, particularly for junior doctors and their experience as well. And I just wanted to get your thoughts around what's happening in that space because of these problems.
Well, I'm a trainer of junior doctors, and I'm very proud of these two gentlemen next to me who came through our medical school.
Here.
I think for me, having trained doctors over the years, in emergency medicine, it has really accelerated their burnout. So we don't expect doctors to burn out in their mid-40s. That's so much time and energy spent into training them, just to see them burn out well before the expected retirement dates. It's tragic. It's really, really tragic. And more importantly, we can't backfill them either. As soon as they burn out, there is a very small pool of junior medical staff who can then be trained up to become a senior medical officer.
Yeah. Kate Fairman.
Thanks, Chair. I just want to pick up on that, actually, if I may, particularly with Dr. Chandru and Dr. Tadros, in relation to the mental health impacts that the situation in our hospitals, you've called them third world and a disaster. What's the mental health impact, if you wanted to talk about your colleagues or yourselves? Like, I'm sure we've heard that it is severe, and as you said, doctors are quitting and worse.
It's look, I'll preface this with saying that I love what I do and I enjoy going to work every day. But part of my role as a senior staff specialist is to provide education and training. It's an inbuilt role that any senior doctor will say is part of their job, but as it's an area of interest of mine, and so I've had close relationships with trainees ever since I was a trainee myself. And there's no doubt that rates of burnout, disillusionment with the system, all of these problems, whilst being exacerbated by COVID and the problems that occurred because of it, were on a trajectory that was leading to this point anyway, prior to COVID-19. In the years prior to COVID-19, the access block was accelerating remarkably quickly, and adaptations were being made and concessions were being made around patient care. But obviously COVID, as it did with so many other things in our country as a whole, it brought out inequities within systems. And I think that brought those problems to the fore, which accelerated burnout. We're in a state now where junior medical workforce recruitment for ED training is at its worst I've ever seen, particularly in our area health services. And so again, that speaks to the problem that Dr. Ung was implying, that backfilling these positions when senior medical staff retire or when they leave the profession altogether is almost impossible.
I tend to agree, and I think that one of the factors that I'm proud of, but also is very unfortunate, is the fact that a lot of staff are being held up by their colleagues. And I think if there would be a lot of people out there, a lot of staff that you would come across within the health system, especially within emergency departments, who would say that they probably wouldn't cope with the job without their colleagues there to support them. But although that is excellent to see that that's happening, I don't think it should be that way, and I don't think the onus should be on other staff around them to just basically prop them up and hold them up and help them through.
Can I get a sense then, because there's no doubt that from the evidence already this morning, and you're very good, both of you, very good submissions, that there is a crisis. Clearly, you would have gone to the hospital executive or the LHD to let them know what's going on in the hospitals, to say to offer solutions. What has been their response? Are you finding that the government, the LHD, is listening to your requests for help? We're really keen to kind of find out, whether they're listening and what they're doing about it.
Yeah, in my role as the District Medical Staff Council Chair, I'd have regular interaction with our executive, and I have to say we do work very well and closely together. But the problem is beyond them. We talk about the constant need to catch up in resourcing for southwestern Sydney, for example. I'm sure Western Sydney's the same. That we both lobby separately to resource the rapidly growing population in southwest Sydney, and we were here talking about this a couple of years ago. And we're constantly on the back foot, constantly, and always playing catch up. Never have we gotten to the point where we think, okay, now we're resourced to our population. Let's make it leaner. Let's maximise it. We are still on the back foot.
I think there's only so much give you can have in a system that's at 100% occupancy. I think there are lots of, you can call them solutions, but probably not so much solutions that people have put forward over the years that have been implemented, and that's probably the only thing that's gotten us through up until this point. But there's only so much give in the system, and I think that's probably been maximised up until this point.
So you've, in terms of your situation then, you're saying that it's a kind of system-wide situation when you're saying that the beds are operating at 100% or above 100% capacity. What does above 100% capacity mean? Because 100% capacity is every bed full, right? So this, you're talking like in corridors and stuff, potentially.
A patient in the waiting room waiting a bed for a day who's been identified as someone who needs acute care but is still sitting there. I see that as above 100%. That's not a treatment space. That's a patient who's,
should have a bed and doesn't have one.
And normally we would start our shifts with anywhere from 30 to 40 patients in a situation like that, and maybe 10 of those not in treatment spaces, so sitting in inappropriate treatment spaces, chairs or in the waiting room.
So you just had your mouth away from the microphone for a minute, but so anywhere between how many patients?
So in terms of admitted patients to an ED, on average we would have anywhere from 30 to 40 admissions in an ED at the beginning of my shift. Out of those 30 to 40 patients, anywhere from 10 to 15 of them would be in inappropriate treatment spaces, and so would be counted as over census. And that's what we would mean by operating at more than 100%. So you might have an admitted patient in a chair or in the waiting room waiting for a bed.
And also when we're talking about 100% occupancy or more, we're talking about staff beds. There's been a lot of capital works, and there are empty wards. Empty spaces. They're not counted in the denominator. They are not staff beds, but they're physically there. They're built, ready to be staffed. We just need the staffing, and then they can be commissioned as beds to access.
They've been officially opened by the minister, I'm assuming.
Your time has expired. Your time has expired, as you pointed out previously.
Honourable Westphal.
Thank you, Chair. Doctors, welcome. Just on that issue, and I note that Ms. Femmer was getting quite excited over there, but
so does the minister.
Order.
Let's
Thank you.
You're not the
sorry,
chair.
I've
Listen,
taken your
let's
job.
just
My
proceed.
apologies. My apologies.
With
Chair.
patience, let's get on with it.
Just on that issue, we know that when we build a hospital, we're building it for generations, decades, generations to come. If we were to build a hospital right now that has every single bed opened, that really wouldn't allow us to have much capacity into the future, would it?
Of course.
So
based on population data.
So
at the time of design.
by having a hospital that has extra treatment facilities that can be expanded onto into the future would seem like a more sensible approach to hospital design, would it not?
But sometimes population predictions change, and the opportunity to revisit population changes and requirements, demand do occur. I do concede they do occur. However, there's a lag. When the population shifts or rapidly expands, like in Southwest Sydney, and there's the 12-monthly budget cycle that says, yes, we recognise that, let's resource it a bit more. There is a lag to staff these beds, to recruit the staff to fill them. So unfortunately, the areas that bear the brunt of this lag is the emergency department.
And I just want to add to that. I think often that planning is already on the back foot, using the example of, staffing everything, but it'd be the equivalent of you going and ordering a burger for lunch, me cutting the burger in half, giving you half, and telling you, but you need to grow into eating more of the burger, when in fact it doesn't make you any less hungry at the end of the day, because at the time you needed that entire hospital. So if you build a hospital with, let's say, 500 beds, and that is the requirement at the time, only opening 400 beds and saying that the rest is for future expansion while it's the need now doesn't mean it's any less needed. It just means that it's not staffed at the time.
But that's probably not the right analogy, is it, really? I mean, when we're talking about what we're doing here, what we're saying is that, you've ordered a burger, we're going to give you a burger and a salad, and you can put the salad in the fridge and have it for afternoon tea. That's really the analogy here. That what we're doing is we're building what's required now, but then we're also adding extra so that in the future, when you're hungry again, you've then got that opportunity. That's the analogy that really we should really be using.
But what I'm saying, that's what we should be using, but what you've provided is actually only half the burger. So what's been provided is not adequate for the needs right now. What's provided is well below the needs right now. So it's well below the requirements that are already required.
So let's come to that. Did you have the opportunity to watch some of the earlier testimony from witnesses by any chance?
I was able to catch a little bit. I was at work until...
No, I understand that. It's probably a bit dry sometimes. I love tuning in, but, not everyone does. That's okay. I assume as emergency physicians, you're all members of the College of Emergency Medicine. That's correct?
Yes.
Yeah. So we had Dr. Claire Skinner, who appeared earlier, and Mr. James Gray, who's policy within the organisation. And they provided us some testimony that was, in effect, that the ambulance ramping issues that we have in New South Wales aren't unique to New South Wales. In fact, they are prevalent all over the world. But the other bit of the testimony that I found very interesting was that they said that New South Wales was probably doing it the best out of all the states. And, we were doing a lot of things in this space that were a lot better than other states. Now, have you worked in other states? Have you got some experience as to what's happening in other states?
I mean, regardless of that, that's no solace for the patient sitting in the waiting room, waiting for a whole day for an inpatient bed. Though.
No. I accept that. I think all of us here in this room would have a great deal of empathy for those patients that are in that circumstance. But the question that I asked was, have you got experience as to what's happening in other states? Given that this isn't a unique circumstance to New South Wales, given that this is happening across the country, and in fact, we heard, in places like Canada, it's a lot worse than what we've got here.
Just because it's a lot worse doesn't mean...
No, I haven't finished my question yet.
Sure.
Have you got experience in working in other places? Have you seen what is happening elsewhere? And if you know of any jurisdictions that have a better system than what we have in place at the moment, can you provide some of those examples so that we can actually provide that part of the evidence in the report?
Just before you answer the question, I understand it was a rather lengthy question with some component parts. But, and I'm not trying to cut you off, but in fairness to the witnesses, they come with what I'd probably describe as intimate on-the-ground work and work experience. That's their role. In terms of inviting them to ask or answer questions to do with comparative analysis, I think with the greatest respect, may, not saying will, but maybe beyond their remit, and either they can't answer it or need to take it on notice. I think that in fairness to the witnesses.
Yeah, no. I'm actually after that real world experience.
I want to partially answer that. So number one, myself, I haven't worked in other states. I've worked in developing countries in Southeast Asia, which don't have the privilege of having an ambulance system at all. But I'm not going to compare apples and oranges here. On behalf of the organisation, the group that I'm representing, I want the committee to consider solutions outside of the emergency department and ambulance systems themselves, and that look at the inpatient hospital services capacity, and in particular the topic that no one seems to want to talk about, which is chronic and complex care. All these patients with chronic conditions, if only that they had better care, and that's something to share with the Commonwealth, better care out in the community, that they would destabilise less often and need to come to hospital less often, need to be admitted less often, and not contribute to the access block issue.
I understand that aspect of it, and obviously there's always the concern that the ED has perhaps become the default setting of patients who are seeking treatment, when perhaps they are more appropriately seen outside of the system, perhaps through allied health or GP. Like, I understand that's one of the solutions, but I guess in the circumstance that we have in New South Wales what your college described as one of the better systems, can you perhaps identify some of the areas that are working elsewhere that you might have read about or that you've seen in operation that we can look to actually implement here? Because as we said earlier today, there is no, if there was an easy fix, it would have been done already. So they're all, I guess, going to be complex solutions to this problem. Can you perhaps provide some insights as to where we can start with those complex solutions?
I think first we need to highlight the fact that the care given across the state and the issues across the state are not equal. There are hospitals, and especially the hospitals we work at, and the reason we're here to advocate, that we feel are definitely lagging behind other health districts in terms of access to resources and access to medical care. And they're further compounded by the fact that our patients cannot afford to pay large out-of-pocket expenses for outpatient appointments. And not only that, but subsequently have reduced access to all those appointments and things. So I think first, before asking the question, what are people doing interstate or internationally, we need to ask the question, why are people getting different access to medical care depending on where they live across our state? I think when we answer that question initially, then we can further think, how can we first make it equitable here before looking abroad?
Well, let's go to that point then. When you say that the area health, local area health networks that you work in, perhaps have less equitable access, can you provide some idea as to how other jurisdictions around the state might have better access? Because, look, I'll speak plainly. I'm from Wagga. I'm a Nat. So we have a regional centre, and look, I think we have a pretty reasonable access to healthcare there. I would expect Western Sydney would have a better access to services than perhaps we do in Wagga, and I think we're lucky in Wagga with the access that we have.
I think you're talking about two very different patient populations there, and I think it's difficult to characterise as a single sentence as to what makes our patients vulnerable, because everyone's individual circumstance is very different. But when I'm talking about a lack of resources, it's it's on both sides of the equation. There's not enough resources, but there's also an overwhelmingly large number of people who need access to those resources. So even boiling it down to something as simple as, if I send someone home and I say, could you please see your GP in a day or two to get some follow-up for this particular reason you've come to the ED, and they tell me, well, it's a 2-week wait to see my GP.
Yeah.
What am I supposed to do with that information? It's a reflection of an imbalance in the system. And whilst I'm not aware of systems in Wagga and how those things work, I can advocate for the patients who I look after who bring these problems to me every day. The patients who know that there are alternative means and routes to seek healthcare, but none of them are available to them. And I think this speaks to some of the part of our submission where fundamentally the friction lies that you've got a 24/7 health system in the ED trying to interact with what is primarily a 9 to 5, Monday to Friday system. And then to think that those two systems are going to work in such a way that people don't fall through the gaps is an illusion. And so trying to increase the overlap in the Venn diagram between the interaction between those two systems is the way forward. Now, that's going to look very different in different health settings. But if I was to boil it down to you, what should you be looking for in the solutions that you're looking to implement? Fundamentally, the policy would be that. And that might be increasing access to chronic care if a health district identifies that as an area to work for, or it might be increasing access to mental health services, which I know as a person who works in toxicology and works in my emergency departments, that's a huge issue in the 2 EDs that I work in.
Yeah. As I said, I don't imagine that there is any simple fix to any of these. And when we say distilling it down, there probably isn't an opportunity to do that. But I thank you very much for the time you've given today and the insights you've provided. Thank you.
Well, thanks, doctors. We could probably usefully have you for another half an hour or more to continue to drill down. But time's beaten us. But before I thank you specifically for coming today, can I sincerely thank you on behalf of the committee and all members of Parliament for the outstanding work that you do very much at the coalface, looking after the citizens of this state. You may not get those thanks very often, but we understand the amount of work, particularly in recent time, the last 2.5 years, and we sincerely thank you for that. We also sincerely hope that this inquiry is going to produce a report with some recommendations which hopefully will add to the downward pressure on what is obviously enormous challenges you have, and hopefully we can improve things over time. But thank you very much for making yourselves available today. It's been very helpful. I suspect that, or not expect, I expect there will be questions that committee members like to pose to you as supplementary questions, following the opportunity of members to read Hansard. So if you'd be agreeable, our committee secretariat will liaise with you, and that'll enable them to follow up on some of the questions that we've started to explore in the hearing this afternoon. So once again, thank you very much, and the great work's appreciated. And to please pass on those thanks to all the people in New South Wales Health that equally support your work with you. Thank you.
Thank you.
Thank you so much.
Thank you.
For making yourselves available to come along this afternoon. You're all very busy people, and you've had to carve out time in addition to preparing the submissions or overseeing the preparation of the submissions to actually come in this afternoon and give of your time. So we're very grateful for that. Get through the formalities if you could first. and start with Mr. Hayes. We'll go from left across. Get each one of you to state your name, your position title, and swear either an oath or an affirmation, whichever you prefer, the words of which you should have there, and if not, just put your hand up and we'll provide them. So, Mr. Hayes.
Jared Hayes, New South Wales Secretary of the Health Services Union. I swear that the evidence I am about to be given by me shall be the truth, the whole truth, nothing but the truth, so help me God.
Thank you, Mr. Hayes.
Lauren Hutchins, Assistant Secretary, Health Services Union. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you, Ms. Hutchins.
Shay Candish, General Secretary of the New South Wales Nurses and Midwives Association. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you very much. And Ms. Falconer.
Kelly Falconer, Registered Nurse and member of the New South Wales Nurse and Midwife Association. I swear that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth, so help me God.
Thank you very much. Can I just confirm that we've gratefully received the submissions from both organisations. They've been duly processed and have been uploaded to the committee's webpage and stand now as evidence, obviously, to the inquiry. For the Health Services Union, submission number 34. And for the New South Wales Nurses and Midwives Association, it's submission number 31. So you can take those two submissions as read. We have them here to refer to if we need to. But I'll invite you now to, if you're agreeable, make an opening statement, one each from the organisations, and then we'll open it up to questions from committee members. There's members of the opposition, crossbench and government here, so we'll take the opportunity to obviously speak to some of the matters raised in your submissions, but we will look forward to your opening statements as well to also stimulate some discussion too. So, Mr. Hayes.
Thank you, Chair. So HSU has had a significant interest in health outcomes from a paramedic, health worker, aged care and disability worker viewpoint. To be clear, ambulance bed block or ramping is a symptom, not a cause. The effect on the community of ambulance ramping promotes delayed response times, decreased patient outcomes, a potential for longer hospital stays, increase in stress on paramedics and other health workers. The reasons for these delays are multifaceted, and I wouldn't suggest for a minute to be able to quantify them today. Workforce resourcing, cost shifting between aged care and health, aged care funding responsibilities, supply and demand issue, NDIS support, exploitation and profiteering. The government has announced an extra 2,750 paramedics. However, unless there is an innovative program for pre-hospital care, the opportunity will be lost with respect to decreasing the presentations at hospitals. I note that HSU is meeting as we speak with the Ministry of Health to promote community-based outcomes that would limit presentations and promote community paramedic engagement. The issue of ramping can be addressed and was addressed by Susan Pearce, the current Secretary of the Ministry of Health, in 2016. It's important to note around that time, ramping or bed block was out of control. The ambulance would have ART teams, ambulance release teams, to be able to facilitate an opportunity. Focus by Ms Pearce and the ministry at that point in time decreased wait times at hospitals dramatically. Following that, COVID comes along and we now have a problem back again. So it's not as if it can't be addressed, it can be addressed, but it needs to be a will to make it addressed. However, unless there is a royal commission into where the health dollar is currently being spent and identify the wastage, the blockages, the profiteering, the health system will continue to suffer. There will not be enough money to be able to prop up. Bearing in mind the health system now spends 1/3 of the state budget. I don't think we can afford 50% of the state budget. Thank you.
Thank you, Mr. Hayes. Next opening statement, thank you.
I'd like to thank the committee for this inquiry and the opportunity to provide evidence today. There's no denying that demand on our hospital and health system has increased dramatically, as has the complexity and acuity of patients. More patients are presenting to emergency departments via ambulance and ramping times have worsened. The detrimental effects of ramping, including risks to patients, hospital staff and the ambulance service, led to the introduction of key performance indicators to keep track of ED activity. However, an unintentional bias developed because of these KPIs, and many EDs are now viewed as managing primarily on how well their ramping is handled at their facility. This can often drive a culture of treating and allocating beds or spaces to patients who have arrived by ambulance over walk-in presentations, which undermines the process of clinical triage, whereby access to treatment is based on acuity or need. Flow throughout emergency is a balanced responsibility of the nursing and medical staff to manage demands of the ambulance service and the waiting room. In collaboration with hospital and ambulance management, flow coordinators attempt to create movement in the department while considering KPIs focused on ramping length and treatment of patients with consideration of benchmarks. The reality, of course, is that the ability to influence ramping and patient care within ED is almost entirely dependent on the capacity of the hospital beyond its emergency department. The system in which our nurses and midwives find themselves now is one of dysfunction. The issues are never isolated and tend to be cyclical in nature. The wards and units within a hospital are constantly pushed to discharge patients, often too early, for follow-up in the community. The community system is also under strain and at times struggles to follow up patients and maintain thorough and consistent care. This results in readmissions via the emergency department, which then adds more pressure to ambulance services and once again wards and units. This is the nature of access or bed block. To address ramping times and access block, nursing staff are pushed to offload ambulances into treatment spaces that are often termed transfer of care beds. This allows the ambulances to get back out on the road, but also creates more issues around ramping when they return if the transfer of care bed remains full, and often this occurs. Access block leads to patients commencing treatment and monitoring in assessment spaces, which creates additional pressure on medical and nursing staff as their capacity to assess new patients is then compromised. Access block and overcrowded EDs put enormous strain on clinical staff, resulting in increased work-related stress and decreased job satisfaction. The experience of our nursing and midwifery members is that many are choosing to decrease their clinical hours or leave the profession altogether. The relentless physical and psychological pressures placed upon staff is contributing to the ongoing workforce shortages. Many report workplace fatigue and moral injury. There is no one solution to ambulance ramping and access block. However, improved staffing and skill mix levels in our EDs, inpatient wards and units, and community healthcare settings must be implemented to ensure safe care can be provided and sufficient staff are available to ensure capacity within the hospital more broadly to overcome access block. Investment in primary care is also key to reducing demand on acute care services. Without system-wide reform, we will not achieve the improvements necessary to deliver better health outcomes for all involved. I'd invite Kelly to talk to the local clinical issues as well.
Thank you. Ms. Falconer.
Good afternoon, and thank you for inviting me to share my first-hand experiences of ambulance ramping and access block within the New South Wales public health system. I'm in my 25th year of nursing and 21 years have been in the emergency department. I'm employed as a clinical nurse specialist and have advanced practice nurse skills, advanced life support in adults and paediatrics and education qualifications. I'm very experienced in my field, highly regarded by my peers, leaders, managers and medical specialists I work with. There are not many of my kind left in the ED. My work ethic is second to none. I'm a proud nurse and deliver a high standard of care each and every shift. However, never in my 25 years have I felt as unsafe in my career as I do now. The past few years have proven to break many experienced nurses. We were already at breaking point prior to COVID, and COVID has just exacerbated this. They are leaving the profession due to many reasons, but mainly because of increasingly unsafe workloads, unsafe working environments, with increased aggression and violence, and unhealthy working-life balance, due to constant demand of extra and overtime shifts. It saddens me to be here today. How and why did it get this bad? Why are they not listening to us experts on the floor? I literally work in a war zone, not on the battlefields, but the war zone that is the emergency department crisis of today. a product of a completely broken system. From limited GP access to cost of GP access, not enough beds for ever developing growth areas, staffing shortages, both nursing and medical, limited mental health access, limited ambulance access, higher acuity patients leading to longer waits, increased violence and aggression. I'm speechless and overwhelmed on most of my shifts. And with my experience, that says a lot. We are placing critical patients in non-staffed areas as there's no place for them to go and be treated apart from the waiting rooms. Some of these issues I've come across include patients with chest pain being treated in recliner chairs, non-staffed mind you, and having cardiac arrests. Allergic reactions and croups being treated in triage amongst other patients waiting, being given adrenaline to keep their airways open. Patients with mental health issues being physically and or chemically restrained in amongst patients waiting on ambulance stretchers, watching in fear. Junior staff members in non-acute areas looking after critically unwell patients, giving them life-saving infusions such as adrenaline. 5-minute lessons on how to use equipment in non-resuscitation areas such as BiPAP. I'm sorry, you just don't fit the critical area right now. You're going to have to be nursed in the non-acute area by a nurse who has been told 5 minutes how to use the machine. A patient with a leaking abdominal aneurysm waiting in the waiting room for 3 hours before a CT, only to find out it's been leaking, and then lights and sirens to a tertiary hospital for surgery. Cardiac patients admitted to the cardiac wards with no cardiac monitoring. Elderly patients developing pressure areas because they're made to sit in recliner chairs for in excess of 24 hours. Patients requiring specialist care and moved to tertiary hospitals for neurology, orthopaedics and oncology, sitting in our department for in excess of 24 hours and sometimes up to 70 hours. All these incidents are real. I've lived these experiences. These outcomes can lead to death. Increased falls, medication errors and moral injury are a direct result of the increased pressures placed on our health system and staffing. Our patients deserve the world-class health system that they have been promised, and right now we feel like we're working in a third world country. Thank you.
Thank you. Perhaps if I could kick off with questions. Specifically to Mr Hayes, could I just take you to the submission and particularly the conclusion, because I'd like to link up comments in the conclusion with an aspect of your opening statement. I won't read the conclusion paragraph in detail, but if I could pick a part from it, where you say our members' report is always the crucial issues of insufficient material resources and inadequate staffing levels, which in turn make the employees who are increasingly subject to excessive workloads, inadequate training opportunities and workplace stress. So clearly what is there is a wicked problem, and something that obviously in your role you've observed over a period of time. Can I ask you, is it out of sheer and utter frustration of not seeing an improvement that you quite expressly made reference into your opening statement of a need for something no less than a Royal Commission to actually look at the totality of the universe, if I could put it that way, that's confronting us?
Absolutely. I've been involved with health since 1986, being a paramedic for some years before coming in to the Health Services Union. I've been before many of these inquiries and before many of you. We look at trying to find the answer, but we don't look at where the problem is. And this is where there will never be enough money. You know, and we'll be coming into an election soon and people want more money. We can't have 50% of a state budget going into health. I think fundamentally what we need to be doing first is look at where this money is going now. Where are those chokage points? Where is that wastage? Where are people taking money where they shouldn't be taking money? If we can resolve those issues, then we can spread the health dollar out. As I said, 2,700 extra paramedics by the government, which has been very well received. The opposition are talking about an extra 500, which is, again, well received. But the fact of the matter is it will not change a thing in terms of a hospital access block, due to the fact that, as has been indicated already today, what's going on in the hospital is showing, well, an observation outside the hospital is that ambulance ramping up. It's because they can't get in, because they can't offload. It's that handover of care, which is vitally important. We're subject to disputes at the moment. We don't want ourselves or nurses to be in harm's way on handover of care. And these things are becoming a daily issue, and they are certainly a legal issue when someone dies. And issues that have been raised already here today occur regularly and have been getting worse for many years. And so we can continue to say, okay, we'll put some more money here and more money here, but there is no more money at the end of the day. We have to get to the root cause of why 1/3 of the state budget isn't sufficient to deliver a quality health service.
Can I ask you this, and I'm sure, I think I know the answer, but just to confirm it, that with respect to the members you represent, which are well known within the health system, broadly defined, but particularly in this context of public health and public hospitals, are members putting it to you in such stark terms that they've never seen it as worse as it is? That kind of very definitive statement?
Absolutely. And I think every crisis is an opportunity. From 2020 to 2022, the pandemic was here. It outlined the lack of resources, the under-resourcing of health. And this is whether they're allied health professionals who are exhausted, whether they're people who are admin officers at the ED who are being abused every day, the violence that is presenting within hospitals. These things have manifested up until 2020. We're coming out of COVID now. Those issues of normal flu, winter bed block, violence in hospitals, they will start to ramp up. But at the same time, we've now got a workforce that is depleted. And I would think for the next 12 months, attracting, retaining people in the workforce is going to be even more difficult. So it is a matter of urgency that we don't look at this in a piecemeal effect, that we look at overall, particularly when you look at aged care, the cost shifting in aged care alone. It's just remarkable. That we did a GIPA on in the Illawarra area. We found that there was 8.6% of beds taken up by aged care residents. At the same time, we found 210 registered aged care beds in the community were given back to the federal government. So we've got a decreased aged care opportunity. That flows on to the public health system, that is not funded by the federal government. So there's another major issue.
The Honourable Rose Jackson might have some follow-up questions.
Yeah, thank you. Thanks so much for coming along. I mean, I wanted to start just quickly. It's raised earlier, perhaps to you, Mr. Hayes or Ms. Hutchins, this term of ambulance ramping in a way, it makes it sort of sound as though it's just a vehicle sitting on a ramp somewhere. It kind of hides in a way what we're actually talking about. I wondered, do you sort of have a reflection on, we use that term, it's a kind of understood almost clinical term, but it's not really an accurate term, is it? Because it's not just a vehicle sort of sitting on a ramp somewhere, it's actually paramedics frustrated who can't get to the next call, a patient lying there who can't get the treatment they need.
It's a clear identification of, to my view, basically malpractice of a patient. Someone who was of the view that they needed emergency ambulance transport to get to a hospital, and we hurry up and we wait. That means also that person who needs an ambulance isn't going to get one because the ambulance is still at the hospital. So as I said, it's a symptom, it's not the cause. But it is a frustration. Then you look at paramedics who are doing 15, 16-hour days before driving to and from work. The exhaustion that comes on with that. As I said before, the violence is starting to increase again. The impact on our members at times sort of rub up against the nurses in not a good way, because everybody is so exhausted. Everybody is trying to do the right thing, but clearly there is only so much room in an ED for a patient. And then we have to have other people coming in over the top trying to resolve that matter. So I really wanted to make that point at the outset, that this was dealt with by Susan Pearce in 2016. These things can be dealt with again, but there has to be a 24-hour, 7-day-a-week focus to resolve these matters, and I don't think anyone's been supporting that at all.
And that sort of is what led to your call for even something of the status of a royal commission to ensure that focus is necessarily given to this issue.
I'm sure everything that you've heard and everything that you will hear, there are so many competing interests in health. But this is a universal healthcare system. It can't be universal for some and not for others. And whether you're regionally based or you're metropolitan based, we should be able to make sure that that public health money, taxpayer money, is spent wisely, is not gouged. If there are blockages in with the system, why don't we look at the back end first? Why aren't patients discharged early so that frees up a bed for someone to come through? Why aren't there enough diagnostics so a patient isn't waiting in the ED, waiting for medical imaging or waiting for pathology, and on it goes? But we have, and you'll see in our submission, the pathology, it's just cutting back as much as you can. Now, that's telling you all the time there's not enough money, but there's got to be enough money. It's 1/3 of the state budget.
I wanted to ask you a question, Ms. Faulkner. I mean, it was incredibly powerful evidence. Thank you for telling some of the stories that you've experienced. I mean, I know that you're not a very inexperienced nurse. In fact, you're an incredibly experienced nurse. And if that's what you're dealing with, can you reflect on what it's like for someone who doesn't have, 25 years of knowing how to respond to a rapidly deteriorating situation, a high stress environment? What's the lived experience like for a new nurse? Again, we hear, new nurses coming into the system, that's great, but what's their experience like, and are we going to be able to retain those new nurses considering what it's actually like in ED at the moment?
Thank you. My experience 25 years ago was amazing. I had extremely senior people watching everything that I did, teaching me everything I know. I am the nurse I am because those people built me up to be who I am today. The nurses of today don't have that, not even a little bit. I cannot stand there and watch my junior staff members doing everything that they're doing because I have my own patient load and then some. We're constantly over census, so not only am I looking after the beds that we have staff for, I'm looking after beds that we don't have staff for, and I'm talking resuscitation bays. So if we've got a 1-in-1 in resus, we have 4 beds in there, we have 3 staff, 1 is a non-funded bed, we're constantly full with 4 critically unwell patients. When I first started going into the resuscitation bays, I always had 2 senior staff with me, side by side, constantly telling me what to do, showing what to do, explaining when something wasn't going right, why it's happening. I can't afford to do that today because I'm looking after 2 critically unwell patients. So it's a 5-minute session. Half of them aren't even advanced life support, so they don't have the skills to give medications when required to, because we should be there with them, teaching them at the time. Most hospitals don't have that. There's a lot of inexperience, there's a lot of crying, there's a lot of sick leave, and there's a lot of threats of, I can't stay, I can't do this any longer. We've got nurses that are leaving with less than 5 years experience. To have someone with 25 years experience working in the emergency department is practically impossible these days. We've just had 14 staff members leave with over 20 years experience since July.
Wow, amazing.
They don't want to deal with this anymore. They can't deal with it. Every day, one of those junior nurses goes on the floor and gets her patients. She's risking her registration. Every single day, making decisions which ultimately may end her in a coroner's court explaining why the patient died. And it's no fault of the nurses, it's a system that's failing.
Honourable Member Hurst, Deputy Chair.
Thank you, Chair. I might start with Ms. Candish. I was really struck by one of the quotes that you included from one of your members that you included in the submission, which said that insufficient staffing in ED is unsafe. Staffing in our ED is reliant on us doing overtime, which is causing burnout and sick leave. The constant pressure from management to have a plan to offload ambulances is stressful. How can we have a plan if there is nowhere for them to go? Can you just sort of flesh that out a bit more for us, and the link between understaffing and the bed block, and how the staffing ratios are so important to improve this situation?
Yeah, sure. Earlier, Ms. Jackson asked a question about, the visual of ambulances outside. For an emergency nurse, of which I am as well, you measure your day based on what that ambulance waiting bay looks like. So driving your car past as you go and park in the parking lot, if there's 8 ambulances lined up, you know the type of day that you're going to have before you've even stepped foot in the place. And that's reflective of the emergency department you're walking into, but more broadly the hospital. And so it's really just this sort of compounding impact of 8 ambulances, as an example, lined up means 8 patients waiting to be offloaded. You can guarantee you have a full waiting room as well. And so that already tells you that there's not flow available throughout the hospital. For nurse managers, nurse unit managers, senior doctors who are responsible for having the plan that you spoke about, it's incredibly stressful. And there's this kind of internal process of escalating phone calls and escalating stress across the ambulance service and the local hospital management, pushing for a plan to be created. But frankly, you're trying to create something out of thin air, because if there are no more beds, where do the patients go? And so that's where we start to see the usage of beds, like what Kelly referred to, that are unfunded. So we see hospital wards that are not in use opened up and patients offloaded into those. We see patients put into corridors. We see patients put into chairs, all things that go against what we would consider appropriate within our clinical judgment. But it's done in an effort to try and offload the ambulances, because we all know it's critical that they get back out onto the road as well. But we're doing all of this, continuing to take on more and more patients without the appropriate staff in a number of settings, in most settings, in fact. And so it just escalates the stress that everyone's having to work within. And inevitably, it means that you're taking on more patients than you can care for. You're rationing the care that you're offering. So if I'm a nurse who has 8 patients and I'm taking on 2 more, I can't just give more care to 2 more people. I don't have any more hands. So I'm now deciding who gets prioritised. And when people come through an emergency department, yes, they've had a very comprehensive triage. Yes, they might have had an assessment, but when you're seeing this overall bed block and incredible demand placed upon this environment, everyone's operating in a climate of doing the best they can, but inevitably things get missed. And you don't have, at that point, often very comprehensive medical history. You don't have, pages and pages of patient details in terms of, their observations. You don't have a consistent record. So you're really trying to make judgments based on very minimal amounts of information. And when you then overload that nurse with more and more responsibility, their capacity to monitor and to intervene when something goes wrong is also diminished.
Thank you. Thank you for that. Mr. Hayes or Ms. Hutchins, there was also a story in your submission from one of your members who had an elderly patient die in the back corridor of a major tertiary facility due to bed block. Obviously, it's clear from the evidence that we've received that patients' lives are being put at risk in the current health system as it's currently standing. Are you hearing similar stories to that example? And is this a situation that's going to continue to get worse, and we're going to continue to see patient deaths in a similar manner?
So I just want to note in terms of that story that was an elderly patient who had a do not resuscitate request, for completion of that story there. However, that paramedic who was treating that patient has to go home at the end of the day thinking about the way that patient passed, the lack of dignity in that patient's passing. When you enter the hospital system, you enter for help. You enter thinking that you will get that help. You don't enter the system thinking that you will be sitting in a corridor for hours, that you are waiting for pathology report to come back to diagnose you. When you're in the system, you don't think that then you're going to be pushed through the system to be exited as quickly as possible so that a bed is made available. The system is broken, that we have members in social workers who talk about the pressure to have patients released. And imagine that as a social worker, thinking that you haven't been able to actually provide the care and support that you think is necessary, that you have trained in. That is a system that is broken. That a third of the budget can go to a system that delivers those outcomes is really, really confronting. Jared spoke about aged care. We have beautiful facilities in the South Coast where 2/3 of the building haven't been opened. We have residents that sit in hospitals because there aren't GPs to treat them, or there aren't adequate staff in aged care facilities to ensure that they get the care and support they need. This is a whole system problem that we need to address, and the only way that we are going to do that is to look at every part of it.
Thank you.
Kate Finn.
Thank you, Chair. Thanks all for appearing today. I just wanted to go back to a comment that we've been asking a few witnesses about that the Health Minister made in March at budget estimates. I have asked witnesses about the comment that he made where he said that ambulance ramping is actually very rare now in New South Wales, and I think we've got enough evidence from all of the witnesses that that is a ridiculous statement. But what he said before then, the sentence before then, in response to a question that I asked about the fact that there were 12 ambulances ramping at Westmead and all of these ambulances are off the road and this was happening night after night, he said, "I think it's fair to say that from time to time all hospitals will have some issues, particularly if you have COVID patients in the emergency department, and that is the nature of being in a 1 in 100 year pandemic." Do you think that our Health Minister has any clue as to what is happening in our public hospital systems, in our emergency departments every single day in this state? I'll start with you, Mr Hayes.
Yeah. I think he does. I've been through a lot of health ministers. Some have been very poor, and I think Minister Hazzard has generally been across his brief. However, that the pandemic is something that I'm not going to be an apologist for people, but the pandemic is something that we've not been through before, but has clearly identified our shortcomings. And those shortcomings didn't come in the last 2 weeks. They came over the last 10, 12, 14 years. And we need to take ownership of that. And health has been under stress for the last 2 years. Health was under stress before the last 2 years. As I said before, in 2016, ramping was so bad that Susan Pearce had to get involved in that. So this is, I think, to be fair, it's probably a comment that could have been made better. But to your point, is in terms of covering a whole heap of issues over the past, particularly 2 to 4 years, and my dealings with previous health ministers who were incredibly poor, it's a hard job.
Ms Candish, what's your view? I mean, just to be clear, he did say that ambulance ramping in New South Wales was very rare now. And he also said that, our public hospital system, it's really as a result of a 1 in 100 year pandemic that this pressure is now on our hospitals. What's your view? Does our Health Minister have any clue about what's happening in our public hospital system?
I can't comment about what the Minister does or doesn't know, but definitely that comment doesn't fit with the evidence. There's a clear contradiction there. It doesn't fit with the Ministry of Health's own data. The BHI data that was released recently is the worst data that's been on record since that BHI data was being collected. So I think at any point, and when you look at the volume of data that's available, there is no evidence that indicates that it's a rare event for hospitals to experience ambulance ramping. And I don't believe that it's specifically in relation to the pandemic either, because this has been a worsening circumstance that we've seen for the best part of the last decade. And again, the complexity of the situation, I think, means that it's difficult to attribute to one specific factor. But the pandemic has certainly escalated a number of these factors that we've been discussing for many years in relation to increasing demand, lack of appropriate staffing aligned with beds, the complexity and increasing acuity of patients with a number of comorbidities coming through a hospital system, and having a system that fundamentally prioritises acute care with very little investment or focus around primary care and health prevention measures means that we're continually having to pour money into a system that is constantly dealing with people at their sickest, rather than focusing on how we might start to prevent increasing, or worsening of health conditions before they're requiring acute care.
Yeah, that went very
I
quick.
heard the buzzer.
Go quickly.
I heard the buzzer. Is that my turn?
I think Honourable
is
Captain
indeed.
deserves some more time. Well, we'll see if there's any at the end. Honourable Westphal.
I note my time always seems to get compressed right at the end because everyone takes so long with their questions, and I know we're back 4 minutes from the break, but I've got a few questions. And
No,
we'll see how
you
we-
won't
I
be
appreciate.
shortchanged.
You've been very generous with that, Chair, and I appreciate that. I'm going to start with you, Mr. Hayes, and I must say I do appreciate your candour when you provide testimony to our inquiries, because I don't know if it's because you've been in the role for as long as you have, but certainly you, I guess, try and cut through things. And I think you made a really good point when you said that at the moment we spend about a third of the budget on health, and we don't want it to go to half.
No.
There's obviously a lot of money there, and it's perhaps an issue around where it's spent. Do you have some views as to areas where we perhaps, because I know you said that we've had some under-resourcing, where there's perhaps over-resourcing that can actually be shifted in the budget that might actually assist this issue?
I don't think you can shift anything in the budget until you find where the money's going, and I don't think it's over-resourcing. I think it's who's taking the money. Under-resourcing comes because there's no money left, and that's my major concern. We can look at in regional New South Wales, which you clearly understand. Would it surprise you to know that a person being a locum going to regional New South Wales could be being paid $4,000 to $5,000 a day? A day.
Yeah.
How do you do that? How do you attract and retain people? Like, we have to, and this is, I can't emphasise it enough. I know I'm really labouring the point here, but we can get into the minutiae of all these different people who will come before you, all the different organisations, but you will not get to the point of satisfying the people of New South Wales in relation to good health outcomes, a good workforce that actually is complementary and supportive of the whole system, so we can effectively get a conveyor belt that moves out of the back of an ambulance, through an ED, through medical, through surgical, into the discharge lounge and out efficiently. But we can't do that when others are taking money out of the system, profiteering out of the system. And if we do not deal with that, we cannot deal with the crisis that's before us.
And I guess from your perspective, the members that you represent are, I'd say, some of the lower paid members that work in the health system, as well as paramedics. And obviously, we've heard from the APA already today, but I think you're the preeminent paramedic union, along with them, and there's obviously that debate. But in that circumstance, where you are hearing from your members, do they have a view about, say, other parts of the system staking claims about what's required, when I guess they might have a different view, say, for example, on nurse ratios, where you've got, one union saying that, we need to put more money in this area, that's going to make a difference. We know that the Labor Party haven't backed that solution. Do your members have a view on that?
Yeah, I think we do, and personally I do. I've got two daughters who are nurses, ICU nurses, so I sort of get it. What we look at is a holistic system that is complementary. That if we have, and nurses deserve to be able to work safely, and to be able to make sure that their patients are looked after without them potentially going to a coroner's court. And I think that what was said early on is absolutely true. Those issues are really there. Our concern is that it's also incumbent upon a good health system to have the right diagnostics. So someone's not just sitting in a bed because there's one person doing medical imaging. There's one person doing pathology. There's one person pushing a patient from A to B. We see as a holistic system that one group relies on another group, and if that system doesn't work collaboratively, it just becomes chokage point after chokage point. So we fully respect the nurses' nurse ratios. We fully respect the incredibly difficult workloads that they have, and the incredibly difficult worries that they have as a result of that. At the moment, we just see we're trying to get to a holistic outcome from a system, not just looking at different aspects of that system.
Yeah. So would it be fair to, I guess, summarise that as that every aspect of the healthcare system is able to be better resourced, but focusing on one part of it and not others, perhaps will not lead to the outcomes that are promised, that we need to actually look all the way from the cleaner and the store right through to the CEO and the surgeons.
It just makes absolute sense to be able to do that. But if we don't, we're kidding ourselves here today. Like, we seriously are. And like, we have to get to that point to be able to see that money is there. Look, it wouldn't surprise me if it got to 28% of the state budget. But if we're going to sit there and just throw money away, not be overly accountable for it, and I challenge anyone to support me on this, and I'm sure there's a lot of people who won't say much but will support me on this, because nobody wants to get into this fight. And we have to get into it, otherwise we will revisit this, our kids will revisit this, people will keep walking away from health altogether. And it's such an important fight to have. And if the last 2 years hasn't taught us anything, it should have taught us to have the guts to have a go now and resolve this problem.
Chair, I'll bring my question to a conclusion. No, I know we have a,
a couple of minutes.
I think, there was one other question I wanted to ask, and it came, I think, from Ms. Kendish or Ms. Falconer, I can't remember, but it was about GP access and the inability to perhaps access GP services was providing a pressure point for EDs, and we know that that's obviously the case. But we're in a system at the moment where, for example, the hospital system's obviously state-based, but things like GP services are federally funded through Medicare, and so it might be the primary health networks that have that interaction at that level. So it's probably more a lever that's being pulled by the federal government, say, than the state government. Would you have any views as to what the federal government should be doing in this space in order to provide more and better GP services to those patients who would ordinarily go to a GP but are struggling and therefore end up in an ED?
I think the separation of funding is a matter for each of the governments to work through. An individual person's access to care, from their perspective, is irrelevant around how it's paid for. And this is one of the challenges in how governments work together. I think the challenge that we see is it's not unique to GP services. We need a much more comprehensive approach to primary care more generally. There's a space for nurses in that role as well. We saw a really great example of what happens when we have comprehensive and thorough planning and stakeholder engagement through the pandemic, when we saw the immediate mobilisation of vaccination clinics as an example. So it can be done, but it requires political will. And these are going to be critical points for consideration when it comes to regional access to healthcare, as an example. Maybe a GP is not the best option. Maybe considering GP co-payments is an important way to give GPs more access, more capacity, but not every situation is a one-size-fits-all, and I think taking a cookie-cutter approach is going to be really challenging because different communities require different things.
Oh, I couldn't agree with you more, but I think that was actually the point that I was trying to elucidate with you, is that it's not just a lever that the state government can pull alone. That you've identified that GP access is an issue means that there is some buy-in on this from the federal government perspective, and so there needs to be a commitment from the federal government to assist, and that will actually reduce the pressure on EDs itself.
Absolutely. And hospital avoidance is going to be critical, but nurse practitioners are a component of that, nurse-led models, there are a range of options. If I could also just respond to the comment you made earlier in relation to nurse ratios. From our perspective, it's not an either or. A comprehensive approach to looking at healthcare is critical, and staffing nurses in a ratios model is also key to that. And that's around putting some parameters around what safe care looks like, because we will continue to see our system overwhelmed, and allocating nurses in line with those patients is a way of making sure they receive care. So when we go in and we do that analysis of what the hospital system requires, if it determines we need less nurses, then ratios would obviously afford that, but if it requires we need more, then ratios would afford that too. So it doesn't need to be a one or another.
Yeah, just Chris Minns and Ryan Park don't agree with you, that's all. So, thanks, Jay.
Well, thank you all for coming along. It's been very helpful, very insightful. The submissions were very good, but that exchange back and forth with some of the minutiae of specific experiences in the context of the broad workforce that both unions represent is very helpful. And listen, can I just, on behalf of the committee and MPs in general, just thank you as the leaders of respective organisations for the work that you do with the members in working with them and helping them and guiding them during the difficult times. We know that they very much are on that very leading edge, and it's been a most challenging 2.5 years. So we'd like to pass on our thanks via yourselves to them. So thank you very much. I expect committee members may have some supplementary questions arising from the engagement with yourselves. So our secretary will liaise with you once the hand sign becomes available. So thank you very much.
Thank you.
Thanks.
participants, this afternoon. And that'll involve you, first of all, stating your name, your position title, and swear either an oath or an affirmation, whichever you prefer. Now, you should have the words for the one that you've selected. If not, put your hand up. And can I just say, Doctor, I'm not sure whether you're appearing this afternoon as an individual, because if you are, you ought to say that. If you're representing an organisation, equally, you should say that. So you ought to be clear about who you're representing this afternoon. So over to you, Doctor.
I'm Susan Bolofsky. I am representing the New South Wales Rural Doctors Association. I'm a specialist member on their committee. Apologies that the President could not be here today. I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth, so help me God.
Thank you very much, Doctor.
Thank you.
What we'll do now is invite you to make an opening statement. Just before you do, can I acknowledge and thank the Rural Doctors Association of New South Wales, who over a period of time with different inquiries have been very helpful in their contribution. I remember in a recent inquiry had into regional rural health, Dr. Ival presented evidence at that inquiry and spoke to the submission of the organisation. So it's always been very helpful. So we've received your submission. It's been processed. It stands as submission number 32 to the inquiry and has been uploaded to the web page and obviously stands as evidence to the inquiry. So you can take that as read by members around the table. But if you're agreeable, what we'd like to do is invite you to make an opening statement. Try and keep it to just a few minutes, and then from there we'll go around the room. There's members of the opposition, the government and the crossbench here, and there'll be a desire from members from all those groups to ask questions. So I think that's all I need to say. I'll pass it over to you for an opening statement. Thank you.
Thank you. I've got a little bit of echo in the background. You can hear okay?
We can hear perfectly.
Okay.
We've got no echo. Sorry, is there? Yep. Okay, so the latest update report is that we do have Ms. Melchior, but we can't see her. So we've just got audio. So listen, if you don't mind, sorry to interrupt, we might get the swearing or the affirming LOA for her. So can Ms. Melchior hear? Oh, there she is. We can see you. Hi, how are you? Okay. We can't hear you now. Can you take off mute, please?
Yes. Good afternoon. Thank you for your patience waiting.
No. That's fine. So sorry, Doctor, to interrupt, but Ms. Melchior, can I get you to state your name, your position title, and then state either an oath or affirmation, whichever you prefer. You ought to have the words provided to you, hopefully. If you don't have those words for the oath or affirmation, just let us know and we'll provide them to you. And just to be clear, to confirm who you're representing this afternoon, whether it's yourself or you're on behalf of an organisation. So over to you, Ms. Melchior. Did you hear what I had to say?
Hello, I'm Suzanne Melchior.
Thank you.
I am, sorry, my screen's on. And I am a senior registered nurse working in northern New South Wales at a small rural emergency department with a 9-bed emergency. I'm representing myself as a nurse that's very concerned for the future. And I'm not representing any other organisation.
Thank you for that. Would you like to swear either the oath or take an affirmation, the words of which hopefully have been provided? If not, I'll work you through the words. Do you have the words for either the oath or affirmation?
Sorry, just one moment. I'm just getting that screen up.
That's okay. If you don't have it, I can work through the words. I've got them in front of me.
Of course, now nothing's loading up. Please provide them for me.
No, that's okay. So would you prefer an oath or an affirmation?
An oath is fine.
Okay. So repeat after me, please. I swear that the evidence now
I swear that the evidence now
about to be given by me
about to be given by me
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth,
and nothing but the truth.
so help me God.
Help me God.
Thank you. Now, can I just confirm that we've received your submission? Thank you very much. It's been processed. It stands as submission number 12 to the inquiry. Has been uploaded to the inquiry's webpage and forms evidence now to the inquiry. And it'll be very useful. I'm sure it's going to stimulate some questions from members when we come to that part of the session. But we'll return, if we could please, to Dr. Volosky with your opening statement and allow you to make that.
Thank you, Mr. Burkhardt. I'm making this statement on behalf of the New South Wales Rural Doctors Association that represents rural and regional doctors and has done so for the past 30 years. And it's an association that was initially formed when we recognised emerging threats both to our rural patients and our rural doctor workforce. Probably a lot of what you're about to hear is similar to what we presented in the inquiry to the rural and regional health outcomes. Many of the issues or challenges, as we like to say, in terms of facility, workforce, both hospital and community, and organisational and systems problems have already been addressed in the inquiry. And it's no surprise that the same challenges feed through into the problem of ambulance ramping. For us as both local community members and clinicians, ambulance ramping is not new, and overcrowded emergency departments have been a feature of the healthcare system for many years. We are aware of papers from emergency department research to a lack of beds in hospitals for patients to be admitted to the emergency department, and that appears to be a considerable factor in the problem. Over the many years that I've worked as a specialist, as a surgeon, it's only become worse. And as a Rural Doctors Association, we get a number of concerned clinicians worried about the safety of their patients in rural and regional Australia, and particularly New South Wales. There's a perception and a rule of thumb that it might be considered the number of ambulances ramped is the number of extra hospital beds needed. Those hospital beds may sometimes be available, but our busy and hardworking nursing staff are not, and that problem has only become worse during COVID, but it had also existed pre-COVID. Examples that we get from the New South Wales Rural Doctors Association are patients waiting in ambulances who have already been diagnosed by their very competent rural GPs with, for example, acute appendicitis, but there appears to be some form of hospital concern or policy to accept that patient because there's no bed in the emergency department, which means the patient then cannot be booked to the theatre, which means that their emergency surgery is then delayed by, 4, 5, 10 hours, which means poorer outcomes, which we are always being hounded by in the media. And I think there's a lack of perception by the community about what systems, why these outcomes are occurring and how they could actually be changed. There are also concerns that ambulance ramping or bed block occurs because at the other end of the discharge trail, many rural and regional hospitals now have whole wards of patients waiting for access to rehabilitation or nursing home facilities. Some patients in our community need to stay days longer to access services that should be available in our communities. When we speak to our clinicians, both in our area and throughout the state, they contend that the implementation of our electronic medical record has slowed the passage of patients through their emergency departments. So whereas prior to the electronic medical record, they may have seen, emergency departments may have seen between 10 and 15 patients per 8-hour shift. The difficulty in processing patients through the electronic record may decrease that to half, and that's also due to more complex patient presentations. The lack of access to services in the community can also impact the discharge process, as we've already pointed out. There's no clear evidence that the lack of access to general practice in rural and regional New South Wales has led directly to increased emergency presentations, except in the event of natural disasters. And Northern New South Wales has recently had 2 such natural disasters, where Lismore has lost 3 of its largest general practice clinics. Some of these clinics service between 10 and 20,000 patients per year. And Suzanne's shaking her head there that those patients come to the emergency departments in rural and regional New South Wales to access services that were previously available in GP clinics. The GP clinics see the patients that they were able to because they still, after 7 months, have not been able to restart the work that they used to do in such an efficient way and help keep patients out of the emergency departments. The other concern for rural ambulance ramping is perhaps in metropolitan Sydney, for example, hospitals can go on bypass, but if you're in a rural centre 800 kilometres from anywhere, there is nowhere to bypass. And that's why patients stay in ambulances. I can give you some hospitals where, for example, the bigger regional hospitals might be funded for 15 patients in their emergency department, but routinely they are after 30 patients. So in terms of safety, that would be like a Boeing plane flying 200 passengers when there's only 100 seats available. We are really concerned about the safety and the quality of care that we can provide our rural and regional hospitals. Suzanne might agree, but some of the reasons why this occurs is because there's a perception that all of these challenges are being the same solutions are being offered day in, day out, month in, month out. So there's a perception that we're doing the same thing over and over and expecting different results. Quite a number of clinicians, allied health staff and nursing staff feel that there needs to be better solutions, and other organisations that are involved in the safety and quality of people's care have other solutions, including human fact science, to try and improve systems that are clearly not working. I'll leave it at that.
Well, that's been very helpful, Doctor. That's raised a number of issues which complement very nicely what's in your submission. I'm sure that'll lead to a range of questions from members when we get to it. Mr. Milquite, can I invite you to make an opening statement, please?
Sure. Thank you. Firstly, I'd like to start with this. Why undertake the process of making a submission to this inquiry? Why start the process on a working day, as I am today? I'm on shift this afternoon, allocated the triage and intro. Right, press on a submission. It was obviously typoed and had to read, but I thought I ran out of time, but I still submitted it
Could
anyway.
I just invite the witness to perhaps turn the video off so that it might improve her bandwidth and then stop the dropouts of the audio?
Yeah.
Did you hear that? That often does help. We can hear you perfectly. It doesn't
Hansard will
affect.
just have an issue with
Is that
recording
okay? Yep. So that we should get clearer audio now. So thank you.
Hopefully that helps you.
Thank you. It does, yeah.
Why think that this inquiry is going to provide solutions to a problem that I first encountered 20 years ago in another state? Because, ladies and gentlemen, ministers and Mr. Chair, people will die, patients will have poor outcomes, patients are staying longer in the departments awaiting transfer, admission or discharge. The ripple effect is that the professionals working in health are burnt out, suffering moral injury, moving away from the front line of healthcare, or simply walking away altogether. Terms such as bed block, access block, ramping and delay to transfer are common language. No longer able to direct admit wards to wards at the base hospital, combined with centralising of special services away from rural hospitals such that I work at, have meant that any presentation that requires specialty input and inpatient admission will be and must be transferred to the base hospital, other facility across border. Ambulance transfers are sometimes for something as simple as a CT scan after hours. The effect on the frontline workers when they have all beds full, several ambulance stretchers lined up, full waiting rooms with some people also needing a bed space to begin treatment is, of course, that they are stressed. We're having to blinker ourselves to the presentations on those worst shifts, which we know we can help with, but having to attend the highest clinical need only. And so begins the process of entry. For this small rural emergency department, to my best knowledge, been experiencing this for 8 years. COVID only highlighted the deficits. I do not want to see any more mentality towards the work front line. We have and are doing our best. We feel that we're bearing the weight of this broken system, the rest of the community. Enough is enough. Change can be made, and please welcome this inquiry with an openness and hope for the future of health, to see an improvement in ambulances to the emergency departments, hospitals, transfer times, and changes to the process of critical and non-critical patients transported between facilities. Thank you.
Thank you very much, Ms. Malquay. And can I say there is no need to apologise or discount in any way your submission. It's a very powerful submission written by someone who's obviously very devoted to her vocation in nursing and been doing it for a long period of time and bringing some very first-hand insights into challenges that we face and some thoughts about what may be able to be done to address it. So we thank you for your submission. We'll pass around.
Before we go on to, can I just, it might be wise just to ask the witness, Ms. Melchior, to submit her opening statement for the purposes of Hansard because of that dropout.
Thank you. Ms. Melchior, did you hear what Kay Fairman said? It was a very good suggestion. So that will be helpful. If you can email it to us at the earliest opportunity to the committee secretariat, that will enable our Hansard, who are very accurate, to just check against that and make any corrections. There is still a little bit of dropout occurring.
Can I just suggest, Chair, that the other solution to this might be if the witness was to dial in via WebEx. That way, the phone line might have more stability. Seeing as we can't see the witness anyway, there's not a great deal of advantage in being on the WebEx computer system. It might be better to dial in with the like via the telephone system WebEx.
Does that complicate?
I'll make that attempt.
Yeah, I think she did drop out a fair bit.
Yeah. Listen, that may, in fact, that would be helpful if you understand precisely what's been just suggested to you.
It's an access.
Patrick here, my expert, is nodding with great, and Andrew, even our greater expert, is saying it can be done. So, gentlemen.
I wouldn't suggest it if it couldn't be done.
I'll make my best attempt.
Good on you. Thank you very much.
I'm like tech support level 2 over here.
All right, well, good luck. I delegate tech to anyone under 15 years of age normally.
I'm 44,
but you're 44, so that's fine. Yeah, so just while we're waiting for that to be done, perhaps, Doctor, may we commence asking some questions of you so the time doesn't just riddle away, and perhaps start with the Honourable Rose Jackson.
Thank you, and thank you so much for your submission and your opening statement. I wanted to pick up on something that you mentioned in your opening statement and in your submission, which is that we sound a word of warning against trying to attribute ambulance wrapping to a lack of general practice services. And I think that that is an important point to make because that is something that absolutely occurs, that there is this idea put out that particularly in rural and regional areas, the reason that we see pressures on emergency departments in hospitals is because of a lack of GP services, and that if we just had more GPs, that the problem would go away. But your submission sounds a word of warning against that kind of, simplistic solution. So I just wanted, you to clarify that and you to put on the record why that is actually a simplistic solution that's not going to solve the problem.
Yeah, so there are long waits to see general practitioners in many local health districts and in many rural and regional centres. And we do have when we look project into the next 10 years, we have far less numbers of resident medical officers looking to a career in rural and regional Australia, because it is a very complex, was probably one of the most difficult specialties to look after patients with complex conditions as a rural general practitioner. But also, and a lot of rural general practitioners are seeing per capita in their rural communities more patients, longer hours, leads to fatigue, possibly error, not burnt out, because not many will walk away unless there's a significant health issue for them. We have GPs for example, Tenterfield, who are in their 80s still working, trying to find someone to take their practice over. And you're right that the ambulance ramping, the example I gave, a patient waiting 8 hours for a bed with acute appendicitis, means that the next patient in the same rural region with chest pain doesn't get picked up because there is no other ambulance to pick them up and bring them to the hospital for the acute care that they require. So, but we also make the point that we don't want this to be a political football between the Commonwealth, who fund general practice, and New South Wales Health, that funds our states. And this has never been so obvious, and I hate coming back to the floods in Lismore, but those number of practices that were flooded did an enormous amount to keep enormous amount of patients out of our hospitals. And those patients are coming for GP presentations, for example, their vaccines, their tetanus, because the GPs don't have the infrastructure to rebuild their practices. They haven't had the ability to get the grants that are available because they're a small business. And there's been a number of major medical organisations who have called for medical facilities in rural and regional New South Wales and Australia to be considered an essential service because of that political back and forth, GPs being funded by the Commonwealth, but when people can't see a GP, they head to their rural hospital, which then gets backlogged, which means that patients who need to be seen acutely or picked up from an emergency trauma or with chest pain wait longer, which means physiologically they will have a poorer outcome.
I mean,
there are lots of time-critical issues in medicine when you treat chest pain, how much time you have to get a really good outcome from a stroke. Every hour of infection in the belly, sepsis, increases death rates by 10%.
I mean, avoiding that sort of, political bug passing in a way was why I answered that question, because as I said, there's sometimes this kind of simplistic idea of, it's the Commonwealth's, responsibility. They just have to fix the GPs. All these people are presenting at rural and regional EDs with issues that are easily resolved at the GP level. That they're not able to do that, and so it's becoming a hospital problem. But your evidence suggests that, look, obviously there are problems with, GP access in regional areas, but actually a lot of the people presenting at hospitals have issues that need to be dealt with in an acute care environment. whether it be a sepsis or a chest pain or an appendicitis, but there are problems in the hospital setting that need to be resolved as well.
There are systems in the hospital that could make the workflow better, and the benefit, and what I say to my trainees, one of the beauties of living and working rural and regional, your GPs will often have worked up that patient so that you don't have to get the CT scan for the appendix. These are GPs who have looked after 2 or 3 generations of family. They know the family, the genetic history, everything. And if we could get that patient out of the ambulance into the emergency department for acute definitive care, we would save thousands of hours of nursing care and doctor care, because quite often the GP has done as best they can the outpatient workup for things like acute appendicitis, a bowel obstruction, and we can do no more. We send them to the emergency department, but it does. The beauty of the health system is when it works well and is able to work well, because systems don't interrupt that. It's systems errors where rules have been created that are reactive to a problem rather than proactive. And there's not many other industries that do that when they're looking at safety and quality.
I want to ask my colleague, Mr. Donnelly, if he has a question.
Continue on, just another minute.
Okay. Miss Mel Quire, are you there?
Melchior.
Sorry, Melchior.
I am.
Apologies.
Can you hear me?
Oh, we can. Excellent. It's Rose Jackson here. And I just wanted to ask, considering, the evidence that you've given, the fact that you're, taking time, out of your shift to give us evidence, which I think is incredibly important, frontline evidence. What does a sort of typical shift for you look like? If you could just give us a sense based on your experience, your work, give us an insight into the ED, in a regional hospital right now. What's the experience like for the staff and the patients?
Sure. So having just stepped off the floor to come to this meeting, I had prior arranged with my manager. He's had a nurse covering for me. We started the shift, had handover, and in that handover, there was 1 bed space free with 6 patients in the waiting room waiting. The 1 bed space that was free was because it was a mental health patient who had just ran out of the department hurling abuse as we arrived and left. That person has since had to have the police called on them. As we went around the room handover, an example of what Dr. Volosky has explained, we've got a young female with abdominal pain who is getting packaged perfectly here with an ultrasound, a CT abdo, formal bloods, and she's waiting to be transferred to the base hospital. The next bed along is a chest pain who is waiting for a repeat troponin formally. So that troponin is a 6-hour, because we don't have pathology on site. So that gets collected and then it'll wait until the next pathology run, which was at 3 o'clock. The next bed is our resus bed. There's a 57-year-old man in there who's been on BiPAP, which is a breathing apparatus to assist with recruiting lung field and improve his breathing. He's been on BiPAP for 7 hours and he's waiting for a bed and a disposition. There is currently no ICU beds in our area health. There is none in the Gold Coast, and at this stage they're looking as far afield as Brisbane to send this man. He's deteriorating and they're at the moment contemplating intubating him to stabilise him further, but he still doesn't have an ICU bed to go to. So it's potentially that he'll continue to be managed here in this department. He has been allocated 1 nurse as an additional nurse for one-on-one nursing, as arranged by a manager, which is very fortunate. And we've got agency nurses covering gaps at the moment, and he had a skilled agency nurse available, and she's here until 8 o'clock, at which point her shift ends. So if that patient hasn't been retrieved or taken to an ICU, it'll be then one of us having to come off the floor and continue that one-on care, leaving the other areas short. In the waiting room, we had 5 patients over 85 years of age who were here for all various different ailments, and the average wait was 3.5 hours. We had a lady who's been here 17 and a half hours waiting for her imaging and pathology results because she had some abnormality. She's stable, but she's still waiting, and that bed space is occupied for her for that length of time. We had a lady who was waiting for patient transport, which was arranged and available to us today, which is not always the case. And she then, her patient transport stretcher was reallocated to one of these elderly patients who had a fractured neck of femur, as it turned out, who'd been sitting in the waiting room in a wheelchair. So this was essentially the handover at 1 o'clock with a full department ready to go. As I came to this meeting, we had moved a number of those beds and some discharges had happened. There was 3 ambulances arriving. I did one of those triages and allocated a bed to that patient, leaving only 1 bed free in the department. So there was 2 ambulances ramped, let's use the word because that's what it is, and one of those has been offloaded, and there is another one currently who is probably clocking up 25 minutes now waiting to be offloaded. This is not an extreme shift. This is a normal shift most days of the week. There is not one particular day in the week that is busier or less busier than others. I work a lot of night shift as a personal choice to try and stay away from some of the management aspects of decision making that goes on when there's just too many cooks. And it also works for my family. Up until recently, this emergency department with 9 beds in it had only 1 nurse on night shift with a doctor, heavily reliant on the after-hours manager to plug the gap. So we've now been 18 months with 2 nurses on night shift. Over the weekend, been a long weekend. Executive director allocated an additional nurse on 3 of the night shifts that I worked. And we did not stop. Those 3 nurses were busy at the bedside with clinical care for that full 10-hour shift, each one of us. So I'm painting a picture of what I know, having been involved with the nurses union, when I've spoken to other similar sized or grouped emergency departments in this state, that this is not an issue that we're just experiencing here. This is statewide. This is actually nationally an issue. One of the things that I see which really challenges us here, and Dr. Volofsky's touched on it regarding GPs who package up their patients, but they can't make it through the bottleneck of the emergency department. That happens here in our facility also. We have highly trained FACEMs on 2 shifts in the day, as well as highly experienced locums or CMOs or registrars in between. I can tell you that majority of the time these patients leave us with the full diagnosis, with the full workup, with reported CT scans, ultrasounds, and yet they have to go through the emergency department at the base hospital. No longer, in the 20 years that I've worked here, are we able to direct admit to the appropriate ward area and specialty area. So I think that's a systematic thing that needs to be revisited thoroughly, that we should, if there's a bed for that patient, i.e. if there's appropriate nursing staff to care for that patient in that bed space, in the base hospital wards, we should be able to directly transfer from our emergency department to that specialty on that ward and bypass the emergency department. There should be no need for us to be sending patients who are waiting for their neck of femur to be repaired, waiting for their appendicitis to be taken out, waiting for their coronary care bed to free up. We should be able to directly admit. And that's something that I've seen has grossly changed in the 20 years that I've been here.
Thank you.
Thank you very much.
Is there anything further? Sorry.
That's given us much to reflect on. We might move now questioning to the Deputy Chair, Donna Hurst.
Thank you, Chair. Ms. Melchior, Melchior, sorry.
We'll get it right by the end of the session.
Sorry about that. And thank you so much for your time today. I can't imagine how stressful it is for you calling in while you're on shift. But you noted in your submission that there are no CT scans or ultrasounds available after hours or on weekends in your ED. Can you talk us through, what happens in your department if somebody comes in on a Sunday night and urgently needs an ultrasound? What sort of delays is that person going to see?
Yeah, absolutely. Look, a common thing, we service a really high area of aged care facilities and nursing homes. And two of the core presentations we get from that demographic is fall and abdominal pain. And so you're right, the two things that are acutely diagnostic for that elderly, frail patient is generally CT scan of their brain or their abdomen, or even ultrasound of their abdomen. So if they come in, let's say at 4 o'clock on a Sunday afternoon, and it's identified they need a CT scan of their head. They've maybe got an obvious injury, or they've simply hit their head and they're on blood thinners, as the majority of elderly people are who have comorbidities and issues with their health. And we'd also ask the question, why did they fall? So maybe the CT scan isn't because they are on blood thinners. Maybe it's a diagnostic tool to ask the question, why did they fall? So if we don't have CT scans, our FACEM or our doctor here at this level will phone to Lismore and say, this is the situation, we're going to send them up for a scan. After hours, generally, we don't have access to patient transport vehicles. And let's say it's a head injury with a neck pain, the patient transport vehicles don't actually have a scope of practice or where they would transport patients who had a neck collar on, for instance. So those people would have to be booked for transport, and generally speaking, that transport is most suitable in a safe way for that patient so they don't have any more falls or risk of injury in an ambulance stretcher or a stretcher in a patient transport vehicle. With ultrasound, we currently have an ultrasound coverage that is full-time for several hours a day, but prior to that, it was only 2 days actually a week. It was Tuesdays and Thursdays. So what we don't have is actually even Monday to Friday coverage for ultrasound all the time. We fought long and hard 12 years, it might even be 10 years ago now, 12 years ago, to actually even get a CT scanner available here at Ballina, to even get it that it was 5 days a week. And the reason why we fought so long and hard is because the cost that we could see for those ambulance transfers was exponential. So not only was there a cost incurred, obviously, either to the patient or to health if they were transported here, but at the early part of us gathering data, it was $600 just for a transfer to get them to the base. As I understand it, having spoken to my colleagues at Lismore, when they get to the base hospital at Lismore, is what happens is that they'll arrive and they'll need that CT. Maybe CT is occupied. Maybe CT is having to be called in. So that could all happen while the patient's still on an ambulance stretcher, and they can face many hours of delay to get the scan in the first place. And then to free up that ambulance stretcher, that person then would be allocated a bed in emergency. If all's well, and perhaps let's say they've got to return back to an aged care facility, they would then wait there for a vehicle to transport them back. Now, whether that's patient transport or ambulance, and so it goes on. So somebody's journey in a realistic way could be anywhere from 10 to 24 hours to have a screening that they didn't have a head injury after a fall, or that their abdominal pain was simply constipation and not an abdominal sepsis. If we had CT scan after hours here, if we had ultrasound available to us after hours, or certainly Saturdays and Sundays till 5 o'clock, I believe that our transfers over the weekend would be reduced significantly.
Thank you.
Thank you. Kate Fairman.
Thank you, Chair. Firstly, just a quick question to you, Ms. Melchior. Are you worried about any blowback from New South Wales Health in terms of appearing at this inquiry today, or did you get permission from New South Wales Health or the union? How does that work?
So I've sought permission from the union, and I also discussed this with my manager. But I'm actually in a position where it's an issue that needs to be spoken about, and I don't believe that even the people on the ground believe that it's something that shouldn't be spoken about. So I'll wait to see what ramifications come out of this, but I'm more than happy to be a spokesperson for health and for how it's deteriorating generally, but also for this particular issue where I just see my own work colleagues and the other professionals that we lean heavily on and we work closely with our ambulance service. There's a complacency. People are so worn out that people aren't willing to talk purely because they don't believe that any change can come.
Thank you.
So I am here because I actually believe that there is change. I believe we can improve systems.
Yeah, thank you. It's just, with the individual nurses, I do know that it's very difficult to speak out, and often they can't, specifically because New South Wales Health won't let them. So thank you so much for appearing. I wanted to ask a general question about mental health beds and mental health patients not having access to beds, and I'll go to Dr. Volovsky first, and then to you, Ms. Melchior, because I'm sure the particularly in the Northern Rivers post floods, I assume the demand is more acute than ever. Dr. Volovsky, how much of an issue is the lack of inpatient beds for mental health patients? How much of an issue is that in terms of what's happening in our emergency departments in rural and regional New South Wales?
A number of our rural and regional colleagues tell us the same story, just the geography is different. So and too many patients with mental health issues, that some of whom could have been looked after in the community. Since COVID, the ability to get to see mental health physicians, clinicians, psychologists, psychiatrists, certainly in our area pre-COVID and pre-floods, what was considered non-urgent mental health care, people were waiting 16 to 18 weeks. That's increased. Some people have given up. A lot of that mental health was also provided by our GPs in the area. And again, those lack of access to GP post-floods has meant that, as Suzanne will tell you, there are multiple patients in the emergency department waiting to be assessed by our psychiatric colleagues. And a number of patients on every shift, quite a number of days before, are self-harm or are angry and harming our staff. So it's dangerous for our staff, dangerous for the patient, and they're waiting extraordinary hours to be seen in a very crowded facility. So all of these little systems that have been broken contribute to increased complications, increased morbidity, and you would know as well, every hour spent in emergency department increases morbidity, mortality. The other thing is my rural and regional colleagues in psychiatry quite anxious about it. It's almost like the only people that are able to be seen in New South Wales Health psychiatric facility are the patients that would normally 10 years ago have been admitted to psych ICU. And everyone else has to be discharged to a community where now, after natural disasters, people are still living in tents. There's, students and families living in motorhomes who are doing their HSC. I have quite a number of cancer patients that will recover from their bowel and breast surgery in tents in the wet. That's just a sustainable community, and it impacts on everyone. Everyone who's trying to just stay afloat, for want of a better word, and also everyone who's trying to prevent any further complications and working in the best interest of safety and quality for our patients in spite of what's not happening for us.
Is it okay to jump to Ms Melchior now,
Yeah,
Chair,
yeah.
if that's okay as well? Yeah.
Yes.
Sorry, my time's officially run out, but I just wanted to also see if Ms Melchior. Yeah.
Yeah, I just want to fully endorse what Dr. Volofsky said, and just add that one of the other observations, like we talk about centralising services to base hospitals. One of the things that has happened with mental health services in this district in the time that I've worked here, and I know that it's spread across other area health services, is when I first started here, we had a community health mental health team that was based out of our town community health centre. And if we had a mental health patient present, we were able to resource locally, and they could be here within an hour to 2 hours. Very similar to how we'd refer to a social worker or a physio and make an assessment in the emergency department. Now, fast forward, obviously, I believe that funding was cut significantly from our mental health community services, and we saw centralising a majority of community health facilities, but particularly mental health. And we've had to reintroduce MEC-RAP, which is an impersonal mental health assessment over Zoom, which, as you've experienced with me getting reception here within a public health system, sometimes would freeze, and a person who was genuinely mentally unwell would not cope even with that process of admission. And I agree again, Sue, that only the worst presentations who were your ICU level mental health would get the care and have the treatments that are appropriate. In my memory, the longest time that I've had a mental health patient waiting for a mental health bed in this department here was 32.5 hours. Now, that's actually nothing compared to some patients that I've heard of at the base hospital who actually waited 5 days and in actual fact were discharged from the emergency department. They never received appropriate mental health care or inpatient care because of the lack of beds, which is ultimately, at the moment, I do understand as a lack of staffing to suitably care for those people. So it's of grave concern. I don't think it's any easier, particularly in the light of what our community in our district is journeying at the moment.
And from what Suzanne also said, it's not just looking after our patients, but we have a duty of care to look after our staff. And there's some really brilliant nursing staff in all aspects, from emergency, psychiatry, and the wards. But it was interesting to hear, and I wrote it down, Suzanne said, I prefer to be on night shifts to stay away from management. There's this perception that the people that are supposed to perhaps, and not just in our areas, across the whole rural and regional New South Wales, there's all these layers of people supposed to help us, help our patients and make us a better person of who we are. But you have comments like that. We'd prefer to be away from management and just get on with the job of nursing and doctoring.
Could I just confirm? My interpretation of that comment was that it was around the tasks of management as opposed to management the people themselves. So it was about. Can the witness perhaps provide some insight into that?
Yeah, sure. I can elaborate on that. You're right. It can be taken two ways, and neither of you are actually incorrect. When I've previously been in an acting nurse unit manager role of this emergency department, as well as after-hours manager roles, as well as clinical educator. So some of my comment is actually in reference that if I'm away from the floor, then in actual fact, because I've been here 20 years in this one department, a lot of people will come to me asking for me to make decision processes which are actually the current manager's processes to decide on, or ask me to contribute to wider management decisions that are outside of this hospital, but again, that's not my scope. So there's been an active decision for myself to remove myself physically from the day decision making, so that I'm not influencing and or getting burdened with tasks that are actually they're not my job description, they're not my role. But does that add a bit of clarification?
Yes, thank you. It does. Listen, you've been both generous, very generous with your time. We've gone over, in fact, we've gone well over, which is not your fault because you've got so much valuable information and detail to pass on, but we will need to draw it to a close now. Can I thank you both very much? It's been most insightful, not just to have that opportunity to read your contributions through your submissions, but to, I think for me anyway, in particular today, have that one-on-one engagement and hear from you directly on so many matters that are going on. And thank you for the wonderful work you do for and on behalf of the communities you represent in Northern New South Wales. They've been through and continue to be going through a most difficult time and are certainly not out of the woods yet. So thank you for the great work you do. We'll move now on to our final session. Thank you very much. At what's been the end of a very full day, but we are all looking forward to hearing very much the evidence from yourselves. The formality involves having you sworn or affirmed to give your evidence before the parliamentary inquiry, so we'll do that first. Can I just confirm that Dr. Huber, you can hear me clearly? Would you like to speak so I can just check that we can hear you?
Yeah, hi, I can hear you well.
Wonderful, thank you very much. That's great. So we'll move through the swearing or affirming, and we'll get each of you moving from my left around, to state your name, your position title, if you're representing an organisation, or if you're here as an individual, just to identify that, and then swear either an oath or an affirmation, whichever you prefer, and the words should be available to you. If for some reason they're not, just place your hand and we'll provide them to you. So we'll start on my left. So.
Good afternoon. My name is Charlotte Gonzaga. I'm here as a representative from Batir. I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth. So help me God.
Thank you very much, Ms. Gonzaga. Mr. Stone.
My name's Christopher Stone. I'm the Policy and Government Relations Manager at Suicide Prevention Australia. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you very much, Mr. Stone. And Dr. Huber, did I pronounce your name correctly, Huber? Is that correct?
That's correct.
Thank you, Doctor.
Jackie Huber.
Thank you.
Thank you.
If you could then just deal with the formality.
I'm a psychiatrist. I'm here representing the New South Wales branch of the College of Psychiatrists. And I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you very much, Doctor. Well, just to confirm, we've received the respective submissions. So, Mr. Stone, with Ms. Gonzaga, the submission is submission number 18 to the inquiry. It's been processed, uploaded to the inquiry's webpage, and does stand as evidence now to the inquiry, which is great. And Dr. Huber, the Royal Australian New Zealand College of Psychiatrists submission has been received. Thank you very much. It stands as submission number 14 to the inquiry. It's been processed, uploaded, and also stands as evidence to the inquiry. So that's great. You can take the submissions as read. When I invite you to make an opening statement shortly, you don't need to read from the submissions per se, but perhaps spend a few minutes opening up the areas that particularly you'd like to draw to our attention, and then if you're agreeable after that, we'll share the questioning around. And we have representatives on the committee from the opposition, the government and the crossbench. So we'll proceed that way. Are you comfortable with that way to proceed this afternoon? Thank you very much. Well, we'll start with you, Doctor. Why don't we start with you? Would you like to make an opening statement?
Thank you. I guess the college would like to convey that we view the ambulance ramping problem as a symptom of an all-of-system problem, and something that we have noted that many of the submissions have brought up. So we regard the solution as being an all-of-system solution. In particular, we'd like to draw your attention to what we perceive to be a lack of resourcing in the areas of community mental health, inpatient mental health, and crisis mental health, which of course reaches across all areas of mental health, with particular attention to child and adolescent psychiatry and also older person psychiatry.
Thank you very much. So we'll now move to yourselves. Now, whether or not you'd like to do one opening statement or share between yourselves, you're more than welcome to share if you wish. So it's entirely up to yourselves. So.
Yeah, just one opening statement.
Thank you very much.
Look, first of all, thank you for the opportunity to attend this hearing. I'd like to start by acknowledging that we're on Aboriginal land and pay my respects to elders past, present and emerging. I'd also like to acknowledge the impacts of suicide and the importance of lived experience and the lives lost to suicide. My name is Christopher Stone and I'm Policy and Government Relations Manager at Suicide Prevention Australia. We're the national peak body on suicide prevention. We have over 350 members across the country, including the largest and many of the smallest organisations working in suicide prevention. Collectively, this represents about 140,000 workers and volunteers across Australia. We exist to provide a clear collective voice for suicide prevention, and we work to inform through data and evidence and to influence systemic changes that drive down suicide rates. Our interest in this inquiry stems from the fact that over 6,000 people each year attend emergency departments in New South Wales following a suicide attempt or self-harm. We've undertaken some work in this area, including a report focused on young people, and the importance of this report derives from the fact that it comes from young people. It was young people who decided that we do the work in this area. It was young people who made it clear that although there are things we can do to improve emergency departments, what's needed is alternatives to emergency departments for young people in suicidal or mental health crisis. For this reason, I'm joined by Charlie Gonzala, one of the 85 young people who provided input to our report. Charlie is a volunteer, lived experience speaker with one of our member organisations, Batir. Batir trains their speakers to be able to share their stories of resilience in ways that are empowering and helpful to those young people who may be experiencing difficult times. Charlie, like many young people, has had the experience of being in crisis, attending an emergency department and not receiving the support that they needed. I should note in closing that we don't intend any criticism of the hardworking staff at emergency departments. The problem is mostly that emergency departments are simply not the right place for many of those in suicidal crisis or mental health crisis. Charlie's here to provide first-hand experience of why we need alternatives to emergency departments, and these alternatives would not only be better for young people in suicidal crisis, they would, by diverting young people from emergency departments, help address overcrowding. So Charlie and I are happy to answer any questions that you have.
Well, thank you very much, Mr. Stone, and Ms. Gonzaga, thank you so much for coming along this afternoon. It's very generous to come along and share what might be some difficult memories that you experienced, but through that and talking openly and publicly help others become aware of challenges and hopefully seek assistance and obviate problems that might otherwise flow from that. Well, we'll commence our questions then. And as I said, we'll divide up amongst the groups around the table. We'll start with we'll start with the government. The government hasn't had a chance to go today first, so we'll. Would you like to? Oh, sorry, listen, I didn't mean to roll.
No. I'm happy to.
Because
I just, was not what I was expecting, Chair.
No, I wasn't trying to wrong foot you. It's just that you've need a fair go. So have a crack.
Okay. Well, would you want to? Thank you. I might direct my questions first to you, Mr. Stone, and in circumstances where there is somebody who is at risk of, say, self-harm, or where there is suicidal ideologies that are present in somebody, and an ambulance is called, what's the impact on that person when they are perhaps being transported and then being waiting to be seen at, say, an ED? Is there an anxiety issue that's created in them if they're not seen quickly, or is there a worsening of symptoms, or is it something that can be managed by the ambulance staff or the ED staff at the time? What's the experience of somebody that's undergoing or experiencing those symptoms?
So we, in our research and consultation with people, we focused on the experiences in the emergency department. And yes, you're absolutely right that there is significant issues when they spend long periods in the emergency department. As to whether it can be managed, there are certainly things that can be done. Some of the issues that occur are the fact that emergency departments are often quite distressing places in general, and that exacerbates the existing mental health crisis. There were some suggestions from young people about making separate areas and places like that, but ultimately the issue really is that emergency departments are always going to be that sort of place, and there needs to be alternative to emergency departments. Charlie, did you want to speak to your experience in an emergency department in that regard?
Yes, I think that's actually a great question, because I think I can speak for a lot of other young people. There's no clear process that we're taught at schools or at workshops of what it's like to actually call an ambulance or wait in the ED. For me, kind of spending 5 hours there while you're already in a mental health crisis, when you're already distressed, just makes it a lot worse, especially when you don't know what's going on. No one is openly communicating to you and telling you about, or updating you at least. It kind of, I guess, heightens your feelings. It's initially scary, I think, for the average person to call an ambulance or to enter the emergency department, but how much more someone dealing with a mental health crisis? For me personally, it was terrifying, and 5 hours felt like a day, you know?
I know that we've discussed quite a bit during this in hearing today that we've got a number of states that do things differently, i.e. The College of Emergency Physicians said that, in their opinion, New South Wales is doing a lot of things a lot better than other states are. Do you know perhaps how some of the other states handle people with that are in distress, you know, with mental health concerns at the time that an ambulance is called? And how does that compare to New South Wales? And I guess a part B to that question would also then be, we've got some safe havens that have opened up. I know I've got one in Wagga, and, you know, we've got some around the state, you know, quite a few in regional areas. Do you see those as being part of a way of alleviating those concerns around waiting in an ambulance or an ED? It's more of a safe haven for those people experiencing that distress.
Yeah, look, absolutely. The safe haven model is one of the models that we discuss in our report. It's part of a number of models that are run as alternatives to emergency departments. The issue is that coverage of emergency alternatives is far from universal, and it often doesn't cover a 24-hour period. And as well as that, there's certain groups who need specialised centres. What we're advocating for is youth-specific alternatives to emergency departments, as well as general alternatives, universal coverage. So I hope that answers your question.
Yeah, no, sorry, it does. Sorry, I'm trying to pull up some data as I'm talking to you about it. Ms. Gonzaga, did you the safe haven model? Have you had an opportunity to sort of see how it operates, and can you perhaps provide some insight, as much as you feel comfortable with, perhaps provide some insights as to how it might have made a difference to the experience that perhaps you and some other people that you may have engaged with might have experienced at that time?
I unfortunately haven't had the chance to really look into it outside of what's in the report or kind of in the forums leading up to it. But I know that for, again, a lot of young people like myself, especially at the time, just the knowledge of these services and hotlines is not as available as you'd think it was. So at the time when I was going through my mental health crisis, I had no idea about Lifeline even, or Kids Helpline. A lot of young people would just think, oh my goodness, what am I going to do? I guess call an ambulance or get driven to the emergency department. So I guess that's another barrier, is the lack of kind of access to these resources, as in even letting young people know about it. I never got these things at school, which is a lot of the work we do at Batyr, is kind of raising awareness for places like Safe Haven or crisis lines. But in a general sense, you know, I had no idea about these at the time, but knowing about it would have definitely helped tremendously. Or if someone at the hospital, at the ED, would have told me that there are a few options for me, that would have alleviated a lot of anxiety and stress in the moment.
Yeah, thank you for that. Dr. Huber, I just wanted to turn to you for a little bit, if you don't mind. We've heard a lot today from people that work in EDs, i.e. the College of Emergency Medicine. We've heard from the Nurses and Midwives Association, HSU, and we've heard from paramedics as well, the unions that represent them, about what they see as the difficulties with the ramping and what might be able to assist in resolving some of those issues. But from your perspective and the College of Psychiatrists, I guess it's going to be slightly different because Whilst you have some engagement around the ED, I imagine that the patients that you'll see won't necessarily have been won't see them in the ED, but you'll see them perhaps in the wards or in practice outside. But they'll have provided to you some insights as to how they felt at that time, whether it be in the acute setting in the hospital or whether it be afterwards in perhaps an outpatient setting. Can you provide to us some insights as to how you and the college might see those impacts for patients and what New South Wales might do that's good in that space, or perhaps could learn from other jurisdictions, other states or even internationally, around the treatment of people that have got a mental health concern at the time they present to an ED, whether it be through ambulance presentation or through the actual ED itself?
So I am an emergency psychiatrist. I work in an emergency department and on a crisis unit and in a toxicology unit, and have access to and have discussed this issue with psychiatrists who work in emergency departments and crisis units. So I think New South Wales does do some things well. There's just an echo. I'm having to excuse me.
Apologies.
Sorry if I get distracted.
We hear you perfectly, so there's no concern on our end. But
okay, so there are hospitals in New South Wales that have piloted a model within the emergency department where there is an area of the emergency department staffed by mental health nurses, and where there is a comprehensive liaison service that is psychiatrists and a psychiatry team that does comprehensive in-reach into an emergency department and has access to a crisis unit and, as I mentioned, a toxicology unit. And a number of the hospitals in New South Wales are in the process of planning how to create such units as well. So that is, I think, being done quite well. I would like to mention safe havens in particular, which I think are just fantastic, wonderful, do a really great job, but as my colleagues just now mentioned, are not universally accessible, generally not accessible 24 hours. I and the college, in fact, would advocate for both. We would suggest that emergency departments absolutely need to be staffed by people who have expertise in mental ill health, and should provide environments that are tailored to people who present in a crisis of mental ill health. But that ambulance ramping can't be regarded solely as a diagnosis, but rather, as I mentioned, a symptom of a whole of system problem, which is why we're strongly advocating for increased resources in the community in order to try and catch crises of mental health before they get to the point that they need to present to ED, in the knowledge that that is not always possible.
thank you very much for that very comprehensive answer. Thank you, Chair.
Thank you. Move to the Deputy Chair, Honourable Emma Hurst.
Thank you, Chair. And thank you all for attending this afternoon. Ms. Gonzaga, thank you for coming today and for speaking with us. Within this inquiry, we get to make a report with recommendations to the government, and I just wanted to hear a little bit more from you. I know you've talked a little bit about a lack of knowledge of services amongst young people, but I wanted to get some more information about what you feel that this committee really needs to know to help us sort of form some of those recommendations that will actually really assist people when they're needing that help.
Thank you, Deputy Chair. I think I think the biggest thing that I'm kind of coming here with today is the fact that the emergency department, I think, is just not an ideal place for young people going through a mental health crisis. Like Dr. Hubert said, it's amazing that a lot of hospitals now have a staff specific for mental health, but just going back trying to think back to what it was like for me as an 18-year-old having to, it's scary enough to try to get myself to say the ED. I couldn't even call myself an ambulance just because the process of calling an ambulance was something so foreign to me, and it doesn't get taught in schools. You don't really know what to expect, and when you're going through a crisis, it's not really something that you can focus on. But even in the ED, for my experience in the ED was, I remember feeling quite dismissed. I remember it would have been so much helpful if I had someone at the time really talk me through what was happening, or could have directed me to somewhere like a safe haven, or let me know of other services, or even just had updated me through what was going on while I was waiting. I think it is just a very daunting place for a young person in a crisis to be in. I think it's daunting for the average person just going to the ED, but even more so being a teenager and adolescent, especially if you're on your own, if, say, you don't want your family involved or things like that. There's a lot of stigma around mental health still, so just that environment doesn't foster that safe, supportive thing that you're seeking out when you're going through a mental health crisis.
Thank you. Dr. Huber, just based on that answer as well, in regards to when somebody, and particularly young people, do present with a serious mental health concern, what options, if any, do they have right now other than to access an emergency department when it's after hours?
That's a super important question, because they don't always have a safe haven to present to. In terms of the public health system, they should be able to access something called a crisis team, which should be available at every hospital, and traditionally used to be able to offer home visits. They used to be able to go to a person's house and give them the medication that they needed, sometimes up to twice a day. They used to be able to offer very regular community appointments with a psychiatry registrar, some sort of other psychiatry clinician, sometimes a psychiatrist. Over the years, I need to move so that my light turns on. Can you still see me?
There you are.
Yes.
We're back.
And there was light.
Over the years, it's our experience that the resourcing for those community teams has been severely diminished, which means that type of offering is no longer available. So rather than having very regular outpatient appointments with a crisis team and being visited at home regularly in order that they can avoid a crisis of mental ill health and can avoid coming to the ED, they have to just come to ED. So those resources that used to be available seem no longer to be available.
Okay, thank you for that. You also noted in your submission that the length of stay and wait times was disproportionately longer for people that were presenting with mental health concerns. For the benefit of the committee, are you able to provide some insight into why they are longer?
Yeah. ASIM has put out a number of reports reporting that data. So that's partially the data that we're using to make that comment. The question of why is complicated. We hypothesize that it may have to do with the fact that mental health beds have severely diminished. So you may notice there's a table in our submission with a description with numbers of how many people have been presenting to emergency departments with mental ill health complaints, and the number of hospital beds that have changed over the years. And the numbers that I have here is that over 5 years, the number of ED presentations has gone up by 15%, and the number of inpatient beds has gone up by 5%. So if you have more people sitting in the ED waiting for an inpatient bed, they will be sitting with the ambulance for longer and longer and longer until those ED beds become freed up, because people are going into inpatient beds, and finally the person will come into the emergency department. So we hypothesize that has something to do with it. Also, it's worth noting that assessments, mental health assessments, take longer than assessments for other medical problems, because we do take a thorough psychosocial assessment, because psychosocial distress is a significant and prominent factor for people presenting in a crisis of mental ill health. We feel that there are a number of solutions to that, all of them system-based solutions, including increasing beds, but also increasing community team numbers and, of course, resourcing emergency departments with subspecialist mental health clinicians.
Thank you.
Thank you very much. Kate Fairman. Yep.
Yes. Yep. Thank you. I just wanted to firstly thank you all for coming today, and for it's really, really important to get your perspectives. Wanted to turn to safe havens. Can you give us an idea of like how many of these are in operation throughout New South Wales? Are they relatively like within, LHDs? Are there quite a few, within each LHD right across New South Wales? Are they more kind of on a trial basis? How do people know about them and access them? I might go to you first, Dr. Huber, about that.
So the safe havens, as far as I understand, were funded as part of the Towards Zero Suicides funding injection. I believe every LHD was expected to create a safe haven, but the template for the safe haven didn't necessarily have to be the same across LHDs. So safe havens are aimed at a slightly different population per LHD. They're a non-clinical space, generally mostly staffed by peer workers, really extraordinary individuals, by the way, these peer workers. And as far as I understand, in each LHD, the word gets out in a different way. I can tell you that in our LHD, we tell every person who comes through the door that we have a safe haven and how wonderful they are. Our peer workers happen to come into our ED to speak to people who come through the door and sometimes take them to the safe haven from the ED to show them the space, and also from our inpatient ward, and invite them to attend. Also, if people call our local crisis team, we tell them about our safe haven, the hours it's open and what's available. We also have something called a suicide prevention outreach team. Many LHDs also have these, but not all, which again consists of peer workers who can offer limited community support for people who present with suicidal thoughts.
Thank you, Dr. Huber. Sorry, which LHD are you working in again?
St Vincent's. But I'll just remind you, I'm not representing St Vincent's,
Yes.
I'm representing Colleges of Conscience.
Yeah. No, you said your LHD, and I couldn't remember whether you stated that. Do either of you have any thoughts as well in terms of safe havens? So we've been kind of hearing where they are. I mean, clearly there seems to be a need for more of them, and obviously your members have found them kind of useful, valuable. They're clearly something that you would encourage the government to fund more of.
Yeah, the evidence is that they're very good. As I say, the issue is that they aren't necessarily in their current formats designed for young people, and that can be an issue. They are not always available 24/7, and the coverage, LHDs can cover a very large geographical area. Particularly for someone who doesn't have their own transport, access issues are significant. So I would describe the coverage, despite the amount of funds that have been injected into it so far, as still more sporadic. Can I also just respond one of the things about making sure that the safe havens are accessible, and this relates to the earlier question from the Deputy Chair. The key thing you need to know about is co-design. Charlie's made a number of key points about what these services need to have, and this is the thing, is that young people and those with lived experience of all ages know what's needed to make sure that these are accessible. They know where it needs to be located, how it needs to be set up, what processes need to be there.
Yeah, great. That's excellent. Ms. Gonzaga, I just wanted to ask you about, with your experience within the ED, would it have made a difference if there was a mental health nurse? It sounds like there weren't any mental health trained physicians or health professionals there at the time you presented. Is that correct?
Yes, that's correct. And absolutely would have made a difference. In my experience, when I was there in crisis, like most days, I'm assuming in the emergency department, it was just a lot of scrambling, a lot of moving about. And at the time, they didn't have any mental health nurses, or no one at least that was kind of brought to my attention, or I was brought to their attention. So I was left just waiting for 5, almost 6 hours with no update on what was going on. It would have absolutely made a world of difference if even for just 5 minutes at the start, someone was there to sit with me and talk me through what was going on, or to really just check in with me. But instead, I know a lot of things arise like ramping, but in the moment, it was just a really scary, traumatic experience.
Yeah. Thank you.
Thank you. The Honourable Rose Jackson.
Thank you, and thank you so much for coming along. I mean, we actually, it is incredibly important. We received evidence earlier today that in relation to the pressures on emergency departments, that actually young people presenting with mental health issues was the fastest growing category. So actually, this is an incredibly important part of this conversation. Ms. Gonzaga, I just wanted to ask you, if you wouldn't mind, just in a way stepping us through your story. So you've mentioned a couple of times just bits and pieces of it. You sort of didn't even know how to call an ambulance. You mentioned waiting in the emergency department for a number of hours. I just wanted you to step us through what happened to you, if you don't mind, because I do think sharing those stories and that lived experience is a really important part of us getting away from some of the statistics and the clinical sort of terminology and understanding what the journey is like for a real person, a real member of our community, and to reflect on how we can do it better.
Thank you so much. I would more than happy to. So my name's Charlie Gonzaga. Charlotte, but you can call me Charlie. I'm currently 22 years old, but my lived experience story kind of starts when I was 18 in my HSC year, so year 12. This was the first time I'd presented with really severe symptoms of anxiety and depression. I eventually got thankfully diagnosed at a community service, at Headspace, which I found very helpful. But in my first bouts of panic attacks, I remember being at like a school, an event outside of school, kind of celebrating our trials. And that was the first time I'd experienced a panic attack. And as a young person who wasn't educated or aware at the time what a panic attack may feel like, it's terrifying because a lot of people say you feel like you may die, which is, it's the walls caving in on you. It's the tightness in the chest. It's the wanting to speak but nothing coming out. And it's confusing having to feel these things for the first time, which is why kind of my friends and I decided, we don't know how to call an ambulance. What do we do? Let's call an Uber to, the nearest hospital. And so that was kind of my first experience with a panic attack and going through these terrifying kind of scenarios and, having to be left there just because of spacing issues. So I was alone for a while. And
which hospital did you go to, if you don't mind me asking?
It was the one in Randwick, Prince of Wales, I believe.
And so your friends went with you, but then there was no space for them.
Yes.
So you're on your own.
Yeah. So I was there for a few hours and just decided, eventually I was seen and kind of told, because I wasn't on medication at the time or diagnosed at the time, I was kind of just told, maybe see a GP in the morning, get a mental health plan. You get 10 sessions at the time, 2018. And then I kind of just had to go back to my party.
Right. And so, I mean, the reality is that mental health episode passed on its own, with you waiting there. It was not a clinical intervention that resolved that particular crisis for you. It was you sitting in an ED.
Yeah, it was me sitting in an ED, still in my panic attack. I was really grateful that my stepfather actually after that told me about Lifeline and these kind of resources. But even when I was in ED waiting, no one kind of raised that with me or made it known that these were things available to me even in while I'm waiting. It was a busy night. I remember, lots of people and my friends couldn't even stay. But yeah, it wasn't until luckily after that I was really grateful that one of my teachers actually recommended me to more community-based services like Headspace or our local youth services, that I was able to go and get the diagnoses and everything. But the whole experience in the ED, you know, 5 hours seems like a short time for a lot of people, but when you're going through, I remember, I think earlier was mentioned that some people wait 32 hours or 5 days, but for a young person who, for a lot of us, it's first time in the ED, it's terrifying experience if you're left all alone with no one telling you what to expect. There's no clear processes. It would have been so helpful at the time to have someone to support me with, you know, both medical and compassionate care. It would have been so helpful to at least be told, hey, there's this going on at the moment, you know, it might be this much more time to see you, or you can go, the toilets are at the back, things like that. Or just letting me know that there are mental health nurses available or not available, or just telling me my options there and then. I think it would have been a lot more helpful if someone had said, oh, because, you know, you're not diagnosed, yeah, you're not on medication, maybe just here's what you can do now to get past the anxiety attack, the panic attack, and then when you can, go to the GP, so on and so forth, instead of kind of leaving me anxiously waiting for 5 hours.
Yeah, and I mean, look, obviously it's incredibly important that you had the support of your friends and your family and a teacher that enabled you to get through that and, you know, be such a powerful advocate here today. And I know you're involved in Batir, isn't it? Yeah, and so just drawing on those other experiences, you as an advocate, you managed to process what was obviously a very scary experience as someone who's barely an adult, you know, almost a child. How can it go bad? You know, how can experiences like that for a young person having a mental health episode, spending 5 hours alone, scared, disoriented in an ED, sort of seriously exacerbate their mental health situations? Have you heard stories about how that can lead to a pretty serious deterioration in someone's situation?
Most definitely. I've had friends, close friends of mine in high school who have been in situations like that and have unfortunately just acted on those self-harm ideations. I was kind of more fortunate to be, the way my panic presents was just to kind of sit there and freeze for 5 hours. But I unfortunately know I had friends in high school who had to go through a similar thing, be it not at the ED, be it just at the kind of children's or the young people psychiatric units, whereas they'd had to wait or were not given adequate information on what was going on, or have just kind of been left in the dark. Unfortunately, what happens when you're alone for how many hours or how many days, a lot of people unfortunately do act on those ideations that they go to the hospital for help with.
And so they go to the hospital, they're waiting, there's no one helping them, and, you know, that can manifest in, you know, in terms of further feelings of isolation and, you know, wanting to sort of just act out.
100%. I mean, for me personally, I remember even feeling things like saying to myself, I'll just go home now because I don't want to bother. There's a lot of self-stigma around mental health that we know of. And when you're a young person, you go through all these feelings like, oh, I should just leave. There's someone probably more important who needs more help than me, so I'll just leave. Or someone who just won't know what to do, like me at the time. But yes, unfortunately, for a lot of young people as well, waiting just makes the feelings a lot worse. And some people would unfortunately rather just go by themselves and act on these ideations than wait 5, 6 hours, 5 days, 32 hours.
I mean, you mentioned that stigma. I just want to ask about that as well, because I think, you know, as you've already mentioned, lack of education, lack of information. People often think emergency departments, that's for when you have a car crash. Mm-hmm. That's for when you break your arm. And so there perhaps can be stigma about people that are having a mental health episode, even though, as you say, for that person, it's incredibly scary and traumatizing, but even still saying, I'm not sure if this is where I should be, and questioning presenting for help. Is that part of the problem, is the stigma and not understanding where to go for mental health care?
Most definitely. Stigma still, unfortunately, remains one of the biggest barriers to young people, especially accessing mental health. So most definitely, a lot of people, the self-stigma as well. Even me at the time, I felt quite embarrassed having to have my friends they didn't know what to do. I felt like I was being a party pooper, but now obviously in retrospect, that was you can look back and laugh and say that's silly, but unfortunately that is the reality for a lot of young people, not just in Australia, but all over the world.
And so that's the importance of that dedicated space, because, young people, creating the space, then educating young people about it. But the first step is creating it, is having it there so that they know, there is a special place where I can go. And as we've said, this is the fastest growing group. This is not a small problem. This is actually becoming a profound problem. So having a dedicated response, and that's the key part of your advocacy today, is it?
Yes, most definitely. It would have made a world of difference if I was able to walk in, let them know what I was going through, and have someone be brought to someone who would have been able to kind of sit with me and talk me through what was going on and make me feel that I was welcome and supported.
That buzzer means my time is up. So thank you.
Well, we could probably go on, but you've been very generous, all of you, with your time this afternoon. And it's been very enlightening for us. The submissions were good, but I don't think anything quite beats having the face-to-face opportunity to engage and go back and forth with the questioning. So, Mr. Stone and particularly Ms. Gonzaga, thank you very much. It's obviously, we can look at that and say, well, this comes along and says it, and it's pretty straightforward, but clearly it wasn't, and great challenge at the time. You've come through it, but your advocacy and your ability to explain and be empathetic and just talk naturally about the experience, I'm sure, resonates with a lot of young people, and no doubt will give some assistance to numbers you will not even understand over time. So thank you very much.
Thank you so much.
Doctor, thank you very much. Appreciate you this afternoon on behalf of the organisation coming along, the college, and providing us also with the opportunity to ask questions. Now, there may well be questions that arise from members reading Hansard after the hearing's completed, and if you're agreeable, we'll, through the Secretariat, liaise back with you with what are called supplementary questions, and then liaise over the return of answers to those. So once again, thank you all very much. And for those who've joined us on the net, that brings us to the conclusion of today's hearing. Thank you very much.